check if you are getting 100% because you calculate for 100%, but we know that the type can vary in between patients, product features can vary. So, you test those and check.
Yes, in elective surgeries we do that. Elective surgeries we do after the questions.
Also, our surgeons in orthopedics, they do a lot of extra interventions when they're doing surgery to decrease bleeding. So that may be something that you may want to discuss with your surgeons to do that. And we already know that when you compare the anticoagulation that you see with factor versus what we get with the bypassing agents, they are inferior. So are you using anything to monitor these patients to ensure that they have hemostasis, like patients who are on chemo or other things? Are you using K or are you using anything else?
So yes, we are using them in our institute. So in both of these cases, it was not used, but for other patients, for dynamic monitoring, we might use like, but it was not. Well, we had the facility, but it was not used particularly in these two
Because
patients.
I think especially for patients where you use 24 grams of normoxidil, it might have been useful. So just one last point more for the audience than anyone else. When you do an inhibitor assay, if patients, for example, have not been getting factor, you may get a negative inhibitor. But when you expose these patients to factor, if they had an inhibitor before and for some time you have not given inhibitor, the inhibitor title may look like it's zero. But when you re-challenge them within 4 or 5 days, they will again develop their inhibitor. So that's something to always remember if the patient ever had a history of inhibitor, just because the inhibitor is zero today, because they haven't received any factor for the last 6 months, doesn't mean that they actually are inhibitor based.
Thank you. That was the last presentation of the day. I thank all the judges for their patient listening and evaluation. We have the results in a short while. I request all the participants to remain here for the award ceremony during the inaugural session. Now we'll start with the felicitation ceremony for our judges. I request Dr. Neetu ma'am, please felicitate Dr. Naresh Gupta sir.
नहीं नहीं इसे हो सकता है।
Thank you. I request Dr. Sandeep to felicitate Dr. Tulika Seth ma'am. Thank you, ma'am. I request Dr. Varun sir to felicitate Dr. Neeta Radhakrishnan. Thank you, ma'am. Now we'll have a short 10-minute breakfast break. I request all those who have had their breakfast to kindly remain seated while the rest please enjoy. We'll gather here again in 10 minutes. Thank you.
सर अपना नंबर बोलो क्या करना है? नहीं डलेंगे उसमें। यार वो लाइन तार की मैं तो अभी ध्यान करा यार भैया को तार तो चाहिए ये डाटा केबल चली
ये फुद्दू वाली है ये लगा दो तो मजा आ जाए फिर तो मैं आज जिंदगी में गंगा नहा जाऊंगा अगर ऐसा हो जाए।
ला देंगे गंगा 10 मिनट पहुंच गई ये तो पहुंच गई और बड़ी देख हुई है इससे बड़ी नहीं है
ये चार्ज ही नहीं हो रहा भैंस की आँख।
ये पोर्ट ही बंद होगा पोर्ट ही बंद है मॉनिटर भी बंद है मेरे
देखना जरा हिल गया
पोर्ट ही बंद है यार
चलाओ इसको यार।
ये कैमरा यहाँ पे लगा है
कैमरा कौन सा लगा है
ये स्टैंड यहाँ पे नहीं लगना
निकाल ले इसको बोर्ड बंद है ना ये
बस चल गया
है
चल गया पहले पोर्ट बंद वो रुकना पड़ेगा पोर्ट ही ले लो
मेरे वाले में तो नहीं आया
इस बार भी
निकाल के लगा दे भाई तारों को सही करके लगा दे। यहाँ चेक कर सकता है तू कि आया है कि नहीं करंट यहाँ नहीं
आ गया चेक करो आ गया होगा
नहीं आया देखो ब्लिंक कर
कौन चार्जर
चल रहा है
वो लग गया पर टाइम ले रहा होगा
हाँ
यदि तो नेट चला था फिर चल
कौन है यार
ये तो डॉक्टर साहब वाला लैपटॉप
और नौ को यूट्यूब चल रहा था क्यों डिस्कनेक्ट हो गया। हाँ जाओ जाओ वापस आओ मैं अपने फोन तो चलाया मैं लाना
किया था तो जाने के लिए आएगी वो नीली की पता नहीं लगी ऑडियो जैक किधर लगी है इसे पूछो ऑडियो दी कितने लाती लाना इधर माइक चला इधर मतलब पीछे लाना माइक नहीं रुको तो सही सेटिंग तो कर दा उसकी नहीं कर देगा वो वाली कोई करता भाजी तेरी ऑडियो की फ्रीक्वेंसी आऊगी देख के कोई किस तो अच्छा अड्डा नहीं आएगी वही तो दोनों देखे घर पे नन्ना बेटे वो मैं घर पे नहीं आई रहा मैंने 2 बार तो दब गया ये कार नहीं बनी गई हाँ बाकी सारे दिन लेते रहना
लिंक आपने ओपन किया था, अभी वो चल रहा है। मतलब मैं बोल रहा हूँ
रुक जाओ एक मिनट।
हायर में ऑडियो चेक की आवाज की लिंक की है और पहले वाली। तो मैं जाना इधर बाहर
Dr. Naresh Gupta, sir.
Good morning, ladies and gentlemen. It is always a great pleasure to listen to Dr. Naresh. His dedication, commitment, and contribution Well, in the end, I will add only one line to this credit, but that I'll take 30 seconds after he completes his lecture. That is regarding the generation of a positive aura in a patient of hemophilia when he has a rare glimpse of Dr. Naresh Gupta. I am the witness. Well, we shall be updated by Dr. Naresh Gupta on the topic which has already been said, that is the revolution in the treatment of hemophilia. Very important because previous decades have remained focused on only factor VIII replacement. Even we are using extended half-life factors, but still the issues remain. There are unmet needs in the patients of hemophilia treated with factor replacement. But now we are entering in an age of revolutionary treatment, which is in full gear, molecular revolutions, from antibody treatment therapies to gene therapy to RNA therapy. Imicizumab, total mimicry, antibody in disguise of factor VIII, and hemostasis is restored. Well, that's why the questions, have we found the magic bullet? Are these addressing the unmet needs in hemophilia? The answer probably is yes, unless Dr. Naresh Gupta says otherwise. Let us listen to his golden lecture, please.
Thank you, Professor Paul. He's a good friend of mine, and he has shown that he is better than a expert. Very nice. Thank you so much. We all heard him yesterday also. This is going to be a panel discussion. So before I begin, let me invite the panelists. We have Professor Tulika Singh, Bilal, Professor Joseph John, Dr. Narendra Singh, Dr. Arihant Jain, Professor from PGI, and Dr. Prashant Chhabra, and the ever energetic Professor Varun Kaur. And one more, there is a young lady, Dr. Nita. I didn't. So we'll have her. She's around here. She was seen in the morning as a judge. So we will have Professor Nita Radhakrishnan. Thank you for all of you coming here. Many, all of you probably recognize all of them. Professor Varun Paul from here, in hometown, this ground. Professor Tulika Seth, AIMS, Hematology. Aryan is professor at PGI. Professor Sheikh Bilal is taking the mandate of hemophilia from his center, but for the whole state. He actually has shown the way how a good doctor should also become a good administrator. Professor Joseph John is very meticulous. I call him the mathematical doctor for hemophilia care. And Professor this thing is from Amritsar, which is so well known. And Professor Prashant Chabra is a pediatric hematologist. Okay, thank you, lady and ladies. We have a Dr. and gentlemen. We'll start with this, and we have some questions. Before that, I make some opening statement, and let's try to wind it up sooner than later, because we have already exceeded time with the permission of chair. Now, hemophilia, a lot of revolution has gone in over the past half a century. There was a time, 4 decades earlier, when people would die. Average age was 15 years. Dr. Nita, please. She's the dynamic lady from the Super Specialty Center at Noida. There was a time when the treatments were difficult. There were times when blood was transfused. Then they would realize it wouldn't work. Fresh frozen plasma was given. Cryoprecipitate was given. And from the blood bank, it moved to the industry as plasma-derived factors, which led to some problems. And those problems actually brought in a big revolution in the healthcare in terms of control of these transmitted infections, especially the HIV, hepatitis B and hepatitis C. And that led to the recombinant clotting factors and the extended half-life factors. And one knew that now we are probably coming to the end of the hemophilia care, because we are just extending these half-lives to such a level that one may need to be given a clotting factor once in 2 weeks, which was a good achievement. Serendipity is something which medicine does not need. Out of the Nobel Prizes that have been awarded since 1901, one dozen have gone to the field of immunology. I think the last one was in 2018, given to Dr. James Ellison and Honiso from Japan. These works led to the development of monoclonal antibodies, which we have seen for the past 3 decades and in clinical use. But what revolutionized was this antibody was not one here, they were 2. And what do the 2 antibodies do? One goes and attaches to the activated factor 9, one goes and attaches to 10, it creates a bridge. This is a job which factor 8 was supposed to do as a coenzyme or as a cofactor. So here we create a permanent bridge. Factor 8 bridge was very fragile, you know, that temporary bridge which you can adjust based on the needs. This was more strong and solid bridge. And we will talk about whether this kind of a bridge is better than the fragile, self-adjusting bridge. That is another question. Now, this is called the bispecific antibody. So you have FAB fragments, there are 2 of them, and they attach to different molecules. And bispecific antibodies came in a big way when they were developed, and I think 4 or 5 of them are there in the oncology. One of them landed in hematology. God-forsaken place. It had nothing to do with it, but this Japanese Midorishima from a very religious place, Iseshima, I think, He came up with this, and this became revolutionary because once it attached to 9 and 10, 9A and 10, it brought them together. It didn't even matter whether they were antibodies to chlorine factor 8 or molecular cases. And this is the top for these patients with hemophilia. We all know they suffer from starting from their infancy or even before they are born until the older age. As the age is increasing with the treatment, the problems also are increasing. Not only the problems also are increasing, but the numbers also are increasing. So we will start with our first question to the panelists. When you see management of hemophilia A, today with respect to hemophilia A, what challenges do we face? Professor Bilal.
The challenges in hemophilia A, particularly, we were used with the first thing is about the budgetary constraints. Usually the drugs that are coming up, from the to the extent half-life and the so what we are used about the production, the biggest challenge is about the procurement process and the budgetary constraints. Those are the biggest limitations. If you have the budget, you have enough budget, and you plan out your patients, and then ready-made available is there, so you can plan anything for the patient. That's the I think biggest challenge in the current.
So one of the big challenges was the availability of clotting factor, and there was a time when we used to say, oh, any factor, any quantity of factor is better than no quantity. But John, apart from the factor, were there any other issues that were becoming challenges in the management of hemophilia A?
Yeah, so I classified it as the operational challenges. The operational challenges are affordability, accessibility, availability. These are three areas which we don't talk about. But when it comes to therapeutic challenges, like you had predicted, there is an array of challenges that you come across with regard to breakthrough treatments, available prophylaxis, inhibitors, pseudo tumor surgery. That is the spectrum of therapeutic challenges.
What do you see non-drug interventions in hemophilia as a challenge for managing hemophilia A?
So, as far as the non-drug, so I can give you question non-drug factors.
Non-drug management.
Okay, non-factor. So, so the problem with respect to this thing is that patients are having a lot of challenges rather than if we talk of my state, in our state, the first challenge, the first and foremost challenge was the adequacy of factors. Now that it has been taken care of, majority, in fact, the majority of the things have been taken care of the NHM, but the rest of the things, the logistics of the patients getting managed with respect to these problems, like how they can travel, how they can have the benefit of these prophylaxis or benefit of the drugs being given to them. This is a major challenge in facing the patients. So second thing is like pediatric patients, they have a lot of issues with respect to getting the drugs in the proper dosage and proper format because IV access is a very difficult problem. So we have had lots of children who, in fact, we had to keep the factor for maybe 2 hours before we could find an IV access. And getting the factor at the right time is one of the challenges being faced by some of the centers because all centers were not running 24/7. So now we are having almost all the centers running 24/7. This challenge has been
Where there is a will, there is a way. Dr. Nika, there are some other non-treatment related challenges also, diagnostic, physiotherapy, supportive care, the mental state. Do you think they are important?
I think they're the paramount importance because we are still under-diagnosing most of our patients. Diagnostic facilities are only really available in larger medical colleges or in the private sector in the metros. So the most important is actually awareness and then testing. I got to know that in Punjab there are about 900 patients of hemophilia, but then there are some states in India where there are more than 3,000. So, looking at the population incidence that we have of hemophilia, the number of cases should be much more in this state. And this we're seeing all over the country, in fact, because diagnostic issues are there. Either we need to have diagnostic availability in all of the districts, or we need to think out of the box, maybe these point of care kits and other things are there. But all of this will only happen if we have awareness. And I think and all over India, the majority of cases, even the ones who are presenting to my center, are severe hemophilia. So we're missing most of the patients who are mild and moderate hemophilia.
So, Dr. Geeta, there is this issue of the number. Is number a matter of concern when it comes to as a challenge for managing hemophilia? I mean, is it that the number remains constant, we diagnose and we manage it much better, or you think the number is also increased? Like consider what you said.
I wouldn't say as the data that suddenly number is not increasing. What we are actually diagnosing only a very small fraction of the number of patients that we should be seeing. So hopefully, if we have to diagnose 1 in 5,000 like members, the number of patients expected would be more than, I think, 10 times more than what we are diagnosing currently. So the WHO data which came out in the annual global survey showed that in countries like Europe, Canada, etc., they're actually seeing 120% of their expected prevalence because of probably migrant population also. Whereas in India, we have just about 15–16% of the expected patients who are actually getting diagnosed and getting registered. And between the 2019 data and 20 data for the WFH, the number of patients in India has not gone up. It's actually gone a little down. So they are underdiagnosing significantly, and many patients, like Ma'am said, maybe mild and moderate are not getting diagnosed. And second, many of the severe ones would be dying before they actually reach our centers. So numbers are important, and I don't think numbers are actually going up. Even though awareness is a little better and diagnostics is better over the last 1 decade, it's improved. Numbers should be way more than what we are seeing right now.
Okay, so we are diagnosing very few, 1 in 7 we are diagnosing, and what Dominica also brought out is the diagnosis is getting cleaned out. So we are making a very clean and precise diagnosis, and that's why maybe the numbers that we are diagnosing actually is coming out because this juggling is going on. But Narendra, I was thinking, if we are diagnosing few number, it's not a good scenario because we are missing out a good treatment to the 80% of the population. But for the 15–20% that we are diagnosing, is it not good that we have a small plateau to manage? And India should be in a good position that you are managing only 1/6 or 1/7 of what you should be.
No,
money should be constrained, lab should be constrained, manpower should be constrained.
we should think otherwise. We don't be happy that we are treating less number of patients and we are missing other number of patients. So we should think otherwise. We should try to diagnose, we should try to suspect as early as possible. So earlier the diagnosis, earlier the continuous prophylaxis, and better is the outcome regarding physical outcome, regarding musculoskeletal, regarding psychosocial outcome. So we can manage at early stage if we diagnose all the patients. We should start diagnosing at least district levels. Our district level labs should be equipped with the diagnosis of hemophilia and other bleeding disorders.
So that's a very ambitious target that we should have diagnosis of all, and diagnosis, if it can go reach the district level, would be beneficial. And also, diagnosis of hemophilia is helpful not only for hematology or hemophilia, it has an implication for many other, or I would say all other departments. The way we could take it forward was, we would tell the principal, Dr. Rajiv sir, our principal dean and our administrator, that this diagnostics is helping other departments. The women die of bleeding as the most common the maternal mortality rate. Pediatricians face it, cardiologists face it, gastroenterologists face it, pulmonologists face it, COVID faces it, everybody faces it. If you strengthen it, it will be good. And Dr. Joseph John tells me, wherever the hemophilia diagnostics have come up, maternal mortality has come down. This map is very remarkable. So the diagnosis should be there if you want to improve the care. Dr. Prashant, he was raising his point about prophylaxis, about what should be seen as regular replacement therapy. So there are challenges when you move from the on-demand to the regular replacement therapy. How do you see them, especially in the context of India? What are the common challenges faced by this community in absence of regular replacement?
In the context of India being a developing country, hemophilia typically is an example of a paradigm disease, which is a low volume and high cost disease. And India being a developing country, presently we are coping up with all these the diseases of developed countries like malignancies, heart diseases, etc. And on one hand, we are also coping up with the diseases of developing countries like infections. So for the budget allocation, obviously prophylaxis is the standard of care in hemophilia, as we know, because for the individual per se, it increases the quality of life, it improves the joint health. So definitely it is the standard of care in the Western countries, but in developing country like India, it is very difficult to implement on a nationwide scale just because the increased cost implicated.
Dr. Bilal, everybody is speaking of increased cost. You are an administrator, and everybody tells me in this country, money is not an issue if you have a good cost. You think cost is the constraint for not bringing in regular replacement therapy?
If we just calculate, I mean, cost is not so much as the patient on demand and prophylaxis. So if you just compare the patients on on-demand and prophylaxis, overall cost on the prophylaxis will be very, the crowd, the loss of working days, quality of life, and other associated morbidities, associated on-demand therapy. So we will calculate in the overall way. But the thing is that we have to, make clear our bureaucrats, politicians, and administrators that you can just have this while costs too much. Don't think of the buy. Think overall scenario. I mean, you have a broader vision of 1 or 2 years. See how the cost is going down. I mean, he is going to school, he is regularly doing his daily activities as a normal human being. So overall cost is less. His hospital stay is less. His working days are not lost. His school days are not lost. His daily quality of life improves, and he is not a burden on the society or the country. So in that way, that we should not think of the cost of a bike. So we should think overall how it improves the quality of life. That decreases the it's not.
So I think that's a very important point which Dr. Bilal has brought out. And thankfully, Dr. Varun has included some talks in this 3-day Hemophilia Summit on issues which are of greater relevance. One of them was the industry academia partnership for the benefit of patient care. And as Dr. Bilal says, cost is a matter of time. When diabetes was treated with insulin and the monocomponent and followed by recombinant insulins came in, they were 100 times more expensive. And now the animal derived insulin is 100 times more expensive than the recombinant. So this is true, and I believe the standard half-life and extended half-life are comparable in many of the European countries. So cost should not remain as a constant. And the other issue that we touched upon is cost should not be seen in terms of that particular drug alone. It should be the annual treatment cost. If you give per unit once in alternate day and another one once in a month, you can't compare on a per IU basis. And third point he brought out is it is not simply replacing the drug. It is also the quality of life which patient has. His thinking has to go to a level where he says, I don't think I have any problem, I will jump from this sky. So that is another issue. Dr. Anil, that brings us to another issue, and that is, it is said that who develops a complication of these drugs? Inhibitor is one important complication, but these complications will not cover if one doesn't take these molecules. We don't give clotting methods, no side effects, no complications, no inhibitor. There is an impression that seems to be going around that if you give them more clotting factors, they would have be at more risk, higher risk. So if we give recombinant on a regular replacement therapy basis to everyone, would that lead to increased side effects?
A lot of studies, the SPECT trial, the other trials, there was some initial thought process that regular prophylaxis lead to increased inhibitor development, and two, that the component slightly higher. But as we have now more mature data, one thing is that the risk of inhibitor development is predominantly guided by the fact mutation rather than the therapy which we are giving. And overall, it is valid.
Okay, so the product doesn't make a difference. But Dr. Kastil, is it that if you give them more product over a period of time, that will increase the risk for side effects including inhibitors?
When we started doing prophylaxis, there was a lot of concern by the parents, and we reviewed the literature. So there is a very important study in our study where they actually looked at prophylaxis compared to on-demand therapy. And they found that prophylaxis reduces inhibitor production. The risk of inhibitors is always going to be there during the initial exposure days that we give. So usually 20, 30 exposure days, but that will be there even for patients who are on demand. Now, patients who are on-demand therapy at the time of surgery or infection or inflammation, if they get factor, they are at a very high risk of developing inhibitors. And patients who have been on prophylaxis, if they then subsequently go for surgery, will be able to avoid this. So prophylaxis does not cause inhibitors. Inhibitors, as Dr. Aryan said, is mostly a genetic phenomenon. We have families where you have a father, maybe his brothers also have inhibitors, or you have an uncle and a nephew who have inhibitors. So this is mostly due to mutations, not because of prophylaxis.
So it's a myth that was there some time back that increased usage would lead to increased problems. And it was a corollary of no usage, no side effects. But there are good studies that say now if we regular replacement therapy prophylaxis does not increase the risk of inhibitors, maybe decreases. More importantly, whatever inhibitors have to occur, they would occur in the first 75 exposure by and large. And first 75 exposures can occur in first 75 days, or they can occur over 75 months or 75 years. So it's the totality that would come in. Dr. Prashant, when you look at the quality of life or the benefits, the regular replacement therapy prophylaxis, does it really go over on-demand treatment? Like, is there a reduction only in the bleed rate or the quality life or something else?
So if we see the overall picture, if we take into account all the hospitalizations, the cardiac joints, the joint bleeds, the costs incurred to come to the hospital and going back. So prophylaxis obviously will be better than the on-demand therapy, reducing the overall cost and thus improving the overall quality of life.
So direct, indirect costs would come down if you give regular replacement therapy, and the joints, it has been seen from the research that if you give on demand, that particular bleed will come under control, but long-term damage will not be benefited. It is the same scenario like diabetes mellitus, where there is deficiency of insulin, another protein. If you give them treatment only during ketoacidosis, that doesn't help their complication. So it should be there. We also heard, Dr. John, we also heard about the quality of life would also improve. Where do we see that? Where the regular replacement therapy?
So quality of life is a definition how we look at various aspects, and we have five to, HRQL, etc. So on an average, I would say the patient's productivity improves, his disability comes down, and as a matter of evaluation, I just want to add on to the point of view that we discussed earlier, we should be talking about cost effectiveness and cost utility analysis. And then we have competing needs of budget allocation. We can do a legacy table and find out that the value addition. So just to add on to the quality of life part, the cost when we add is absolute cost which you're looking, but direct, indirect medical cost, the travel cost, the injection cost, plus the opportunity cost of an indirect cost which is lost. So we're going to make doctors in the field of hemophilia. Many patients who are now professors who are able to go to school, stand up and speak. Otherwise, the quality of life were down and they're more productive to society. So as I said, if we look at overall view, this is a expenditure well spent.
Very true, very well said. Expenditure well spent. And I'm so happy to see that majority of them are probably pediatricians. If you treat a child who has got hemophilia, you are benefiting the society, the nation, the GDP of the nation by making them productive. If you treat the elderly with the same money, you are bringing a good quality of life, but more at an individual, social, and altruistic level. So I think bringing the quality of life is very important, and thus far, what we have come to is giving regular replacement therapy is important, but as Dr. Varun said, IV can be a problem. Intravenous dose. Frequent dosing can be a problem. The indirect costs that Dr. John talked about, hospitalization when they occur, if there is a breakthrough bleed, then it is a problem. Frequent bleeding surgeries are a problem. Is there an alternative? Yes, maybe there is an alternative. And that is where what we will talk about Hemophilia, which came in 2018, has got the approval, and globally it got the approval in 2018. I think it was the same time it got approved even in India. So India has been very fortunate, and this is a molecule which can be given subcutaneously. Patients are so happy. All our self-infusion programs would go best. We won't need it. They need to take it now like insulin in a subcutaneous manner, and most of them can and do inject it themselves. You need to take it once in a month, not every day. You can take it as long as once in a month. And we would be hearing the experience of the literature and of the families on what it has happened. The dose is very simplified. When it comes to the dose, it is something like we have never accepted in medicine, one size fits all. You say X milligram per kg, you give every month, in this case it is 6. It would work for everyone. We know the standard half-life, extended half-life. There also there are many variables when you look into the pharmacokinetics. But here if you are giving 3 milligram every 2 weeks or 6 milligram every month, total dose will be the same. This works for everyone. And it seems to be good. So you have a dose which is one size all, simplified treatment protocols, simplified administration by the patient, and good results, which we will talk about because you have seen some of the presentation in the morning also, one of them. The bleed rate that occurs, annual bleed rate, when it was checked against the standard ones, it was seen if the annual bleed rate is 25, around that, it comes to 2.9, 1/10. And now we know that it is probably less than 1% also. So it seems to be a good one, but let us look at it. How does this dose, one dose fits all? How is that?
So from the trials that have come in,
studies that came out, and as you can see, the first graph is in the first 1 month, it is given weekly for 4 weeks. So let's say that is building up. But when you look at the flat curve, the first one is 1.5 milligram every week. The next one is you give the same dose as 3 milligram every 2 weeks. Third one is 6 milligram every month. And the blue area is where it is safe for preventing the bleeds. And the blue line is where these targets are achieved. And if you look at it, it is said that one size will fit all.
So it's probably a matter of attaining that level. The blue bar that you're seeing on the graph, that would be attained only, first of all, the loading dose has to be given. Only then you attain that bar and that particular, the width of that bar would be attained. And then when you give it at any of the three, so that between the 3 doses that have been approved, what has been told is that you could change you could use any one of these as per the physician's convenience and the patient's convenience. So it's not related to anything else. It's just a pure convenience that is coming into it. But in the third one, you can see that the troughs are still there. So probably in those 6 mg per kilo patients who are going to come once in a month for injection, in those ones, towards the end of that 1 month, probably there may be like trauma-related bruising, etc., that you may see in that period also, because there are troughs even there. So if there is trauma, there still could be bleed. That is one thing. Second is the loading dose is very important, because unlike in other factor infusions that we have seen so far, when you come with an acute bleed, if you give an injection, there is an immediate effect, whether it is standard half-life or in nature, there is an immediate response that's seen. But here, that unless you load it and wait for a period for that drug to start working, so it may be even, you can even see it within few days that happening, but then you still need to wait. So you can't expect this drug to work immediately for any bleed. Now coming to your question regarding the 1 dose, that is very early data for us. So we know that this is the approved dosing, but eventually in due course, I feel that there will be multiple dosing strategies that will come out of this also. Like the patients who are really having multiple arthropathy, target joints, very high ABR patients may require to be on this exact dosing. And then probably for patients who are being started on early in their lives without many joints, as like a prophylaxis regimen, very early in their life when they start, probably this intensive dosing may not be required in those children. So that eventually we will have more data that will tell us whether 1 dose is that's what is within everyone.
There is good research that has come out. This was it. This you can see there is a meta-analysis research on the dosing, and Dr. Rita rightly raised the issues of trough levels and more information. We always need more information even after the approval. So post-approval studies are very important. Utrecht in Netherlands is a very important institution that has been working on dosing, and they, unlike the Sweden, work on whether we can reduce the dose. But this was not their purpose. The pharmacologist there, this lady, Dr. Donners, worked out based on all the studies available as to what is the correct dose. And what they found was, if you look at a dose, like this dose is 50, if you look at it, this red blue would go to about 51 microgram per ml. This one would go to 48, that will go to about 38. That's look at the round circles there. So what they found was anything which is 30 microgram per ml is protective. And if you bring it down, it would not be good, but if you bring it much higher, you make it instead of 30, 90, it is not more protective. In fact, it can cause some side effects also. So what they proposed was we need a level of 30 microgram per ml to achieve the best effects of emicizumab. The dose that we give every month also gives a trough level of 38. Does that leave a scope for adjusting the dose on the lower side in our society, which is resource constant as something?
Absolutely, sir. I mean, there are many trials going on in NAM Center also, Vellore also, and AIMS also, where they have actually reduced the dose and they have seen the response, which is phenomenal today. Although the pharmacokinetic studies, what they have done, they have not approved this. But in India, we are looking at right now, when we attended the NHU, we saw that they were even using it as a single dose for a particular bleed in an innovative patient where they had some resource constraints. So giving the bypassing agent and 1 dose of Hemophilia and the bleed is gone. So I found the results quite remarkable. And if we talk about the trough level of 30, so we are having a trough level of around 30, 40, as you said, even with the 1 monthly dosing. So it targets, as far as the statement of the organization goes on, it targets a factor activity level of around 15%. So 15% is a very decent, amount of activity in the body. And if you talk of what we were using as SHL prophylaxis, we were targeting around 3 to 5. So we still have 10% gap in between. So we need more studies on this aspect for that we can have the reducing requirement in terms of both logistics as well as the capital incurred on the treatment.
Very well said. As you gain more confidence, you become more aggressive in getting the best out of it. But I think even the literature states that there may be a 20% safe margin for reducing the dose, it gives a minimum dose of a minimum level of 38 and we are allowed up to 30. So that's quite a good one that can be achieved. This drug has been studied for almost 1,000 patient years, Hemophilia, and they have undertaken many studies which are known as Haven 1, Haven 3, and Haven 4. Haven 1 was the first one. First studies are done on adults, not vulnerable children. And first studies were done because this drug also had one advantage. Since it is not like factor 8, it is mimicking factor 8, attaching to the activated factor 9, and then here, antibodies to factor 8 don't play any role. If you have antibodies to factor 8 in inhibitor patients, they go and eat up whatever factor 8 you are infusing. Here, that is not the scenario. So you can use it in an inhibitor. So the first studies were done in the adults with inhibitors. The second were done in children with inhibitors. And the third was done in without inhibitor, adolescents, and I think they included both, and fourth was with or without inhibitors. And actually there is a Haven 5 study also, which interestingly is the one where this molecule has been studied in Asia Pacific region. That is of relevance to us because all the subjects there were from the Asia Pacific region. We will not go into the details of this, but the objectives are very clear and the end results, if you look at them, were very remarkable. And the 4 clinical studies included a total of 107 pediatric patients in different age groups, and they found all these benefits. The benefits that you see here, these are the overall benefits where you see the annual bleed rate is less than 1, 0.7, 0.8, 0.9, and only the first 24 weeks you will see there is a peak when it is getting stabilized, and after that it goes up to 0.3, 0.2. That means they don't even have one bleed in a year, and that's quite a remarkable thing. And the same thing gets accentuated when you see the number of bleeds that require treatment. So the treated bleeds, it is 85 or 87% of them will have no bleed, and the remaining of them will have 1 to 3 bleeds, or mostly 1. So this is something which also takes care of not having the bleed, stopping the bleed, 0 bleed. There is an issue here, Dr. Arya. We believe in case they develop a bleed, breakthrough bleed, the management becomes difficult. Is that so?
one thing which we have created from treating using this drug, that even if they treat less. And so, which means that the management obviously becomes easier. And the other thing is we still have the bypassing agents who are just in place with the choice, obviously, they were the lowest, right? Like, which is again not so wrong, but yes, even if they bleed together. So probably.
Even if they bleed rarely. And if they bleed, the point is you cannot treat them with emicizumab itself. Because emicizumab is something which works on a longer term basis and it cannot be used for emergency. So for emergency, you will have to give the regular treatment. If they don't have inhibitors or low titer inhibitors, you can treat them with factor VIII, the usual factor VIII that they will use in the clotting factor VIII. And if they have inhibitors which are high titer, you can use the bypass agent. So the management of breakthrough bleed is largely the same as for the conventional bleed. Dr. John, there are some patients with inhibitors who have been on prophylaxis with bypass agents. And you can use emicizumab. We have seen and realized that the benefit for treating them with emicizumab without inhibitor is there. Is there any benefit of treating it in patients who are on bypassing agents also?
So, from the standpoint of prophylaxis and bypass inhibitors, that is not a common phenomenon by bypassing. We only give for on-demand. So we don't give prophylaxis and because that is extremely expensive. And emicizumab is not to be used as a treatment for AD. It's only approved for prophylaxis. Whenever there is a breakthrough, we bring in.
Okay, so you don't normally use it, but when you get stuck, some countries, some societies would give regular replacement, and as you said, it is a 79% reduction in the bleed if you start using emicizumab. Whether it will reduce the cost, we have said it would reduce the cost based on the frequency that goes lower down, based on the mode of administration, based on a no need for the individual pharmacokinetics until we have more data otherwise. And based on the fact that the indirect cost of hospitalization, no breakthrough bleeds, the indirect cost from missing the school, missing the job, parents coming in, that also will come down, and the annual cost of treatment would be down. I think this brings us nearly to the end because we are running short on time. And if there is anybody who wants to make a comment, you can make a comment. Otherwise, we'll go to the panelists for final 30-second comment. Yes, sir.
Thank you, Dan.
My question may be out of context, sir, but it's a layman question, I think so. Otherwise, it's very rare that a female will be a hemophilic, but if the female is a hemophilic patient and she starts her menstrual cycle starts basically, then is there any change in treatments and this infusions?
So if you and she's diagnosed hemophilia, even maybe as a carrier, who is symptomatic. Can you use this medicine? Is there any change in treatment? Do you give them any medicine?
So I'm not aware of any emicizumab data on female leaders, but we do know that a significant number of female carriers who we would otherwise consider as normal can have heavy menstrual bleeding. And rarely females may, because of lionization or other issues, may have hemophilia. Generally, these patients are treated with Primulate or other hormonal medications to control the menstrual bleeding. In DWB and in hemophilia patients, they may even need factor support in case they have bleeding, but I'm not aware of any suzumab data for this. I do know that there have been some reports of using suzumab in acquired hemophilia as well as inherited hemophilia, but only in the males.
Yes, sir, quickly. That would be the last one.
So my question is that this is regarding to the bottom category. If you look at all that, what kind of drugs is difficult to do? Because you said that this drug is tested only in one of those patients.
Can you please take the mic near the mic out of the
So my question is that mucilumab is a monoclonal antibody. Therefore, can it produce any side effect in the human patient?
So what I should understand was it is a novel drug, whereas saccharide is a natural agent. If you are giving this natural synthetic molecule, does it produce any side effects?
Yeah, good question. So actually, the literature says some anecdotal evidence of thrombotic microangiopathy associated with this drug. So 4 cases were reported, but later on, all of them had the usage of APCC more than 100 IU per kg in 24 hours. So there was a black box warning has been issued after that we should not use APCC in doses more than 100 milligram per kg. So as a total deterrence to this, we are not using APCC for the patients who are on emicizumab in case of breakthrough bleeding. So we are using factor 7. Apart from that, minor reactions like local side effects, whatever are seen with any vaccinations, like any vaccines or insulin, they will be seen. But what we have seen in our patients, the 6 patients we are having treatment given in our institute, they have had no side effects.
So the side effects are minor and mostly local. Serious side effects were known to occur earlier, in the previous decade, and those side effects may be to thrombosis. And in fact, this is what I like about the industry kidney and patient relationship. They put out a website, the industry, that these are the side effects that are occurring, and they independently went on and investigated it, found that the side effect was not actually from the drug, but it was from the interaction of this drug with the APCC. So that has been done. Thank you so much. So
there is one report, which is in reference to this question. That 2 cases of anti-drug antibodies have been detected. In both these cases, the drug was stopped, and in one case, bypassing agents were probably used and the subsided. In other, there was no problem and it got subsided. But information needs to be gathered from further use.
Perfect. Very well said. We had Dr. Gauri Bhanuji in our meeting last month. He mentioned, he has done a lot of studies in this, and he mentioned about one case where we had to withdraw the drugs. But I think these 970 odd patient years on emicizumab, there have been 3 or 4 instances where antibodies have developed. But nowhere in their studies have they written that they have to stop it. But the point that you raised brings me to the last statement, which I want a quick comment on. It's a novel drug, somebody said. Factor 8 is a natural drug. Factor 8 may have roles which are otherwise. So, Dr. Nita, novel drug or natural drug, what's your take?
I think in most of the centers where we are using this drug now, it's actually this drug versus bypassing agents. It's not this drug versus factor 8. So I think this drug versus episodic bypassing agents, this drug would truly hold good, and because it's able to prevent bleeds to a great significant level. There is a significant role in preventing bleeding. considering when you're using it as for patients who are inhibitor naive and you're going to start it, then we don't have enough data on factor VIII data is there out there, we know what happens after 40 years also, but this drug we do not have, so we'll have to wait and see.
Okay, so one green tick, another question available. Dr. Varun, novel or natural, one statement.
Sir, novel or natural actually, sir, if we talk of natural factor VIII, then we will have to use the PD. Plasma derived factor VIII with one relevant factor associated with it. If we talk of like, the recombinant factor, it's not actually the normal factor VIII which is produced in the body, but still we have data which is more on, factor VIII rather than this drug. So we have to be cautious in our statement. As far as the inhibitor population is concerned, right now with the available data and the response, obviously the first preference would be.
So the other one, new one for where we have used plasma derived recombinant that we have used for now a couple of decades, we don't have equivalent data with Hemophilia.
So, if we use it upfront in pediatric patients who do not have inhibitors, there was a very nice webinar that Nita had coordinated with an Israeli doctor. So in Israel, what they're doing is these children who are newly diagnosed with hemophilia, they're starting them on emicizumab, but they are giving them small doses of factor VIII so that they are tolerized, and in case later on they need surgery or they have any other issue where they will need to get factor VIII or they have bleeding, they will not develop the inhibitors. So this I thought was a very novel but a very logical way with the information that we have available in order to prevent these patients developing inhibitors in the future. But I think we need to look at, rather than talking about novel versus natural, I think it's very important that we realize that hemophilia causes significant physical and mental and social problems. We need to make sure that patients are able to get treatment. At AIMS, we have, I was looking at the surgery data, we get patients every month who are coming for 4 joint replacement surgeries. And that comes at a huge cost. So it is the number of surgeries that are happening over the country, and these patients are then, they have been usually bedridden or having so many disabilities, living in pain. So rather than waiting till they're 40, 50 years old and then doing surgery, we need to make sure that we get access to the hemophilia patients right from the beginning and prevent disability.
Very well said. And this is rightly data. I'm very fascinated because I always wonder, Ariel, that is coming to you, whether that small dose also is giving the benefit of non-hemostatic or clotting effects of factor VIII. Novel or natural? One.
For now, I think the novel one.
Novel one. Professor Bilal.
Yes, as per the thing is the new one, and previously there were a lot of attention about the drug when it came, right? So the thing is that the time is the side effect. So we have just started 45 patients from the last June 21. They are doing well, they're tremendously enjoying. I mean, the thing is that they have forgotten that only the biggest side effect is that they have forgotten that they have. So they have forgotten that. So that is the biggest side effect of it.
Yeah, so safety and efficacy supersedes in the novel, the best man wins.
So the best man wins.
So, as far as trade is concerned, it's not 100% natural. It's a recombinant factor VIII we are using now. So similarly, emicizumab and monoclonal antibodies that is also used in pharmaceutical company. So we are treating 4 patients in our hospital, and they are very happy. They are very happy. Parents are very happy. There is no school absenteeism. They sleep well in the night. Parents, caregivers, they sleep in the night. So I prefer novel.
Dr. Prashad, last word.
I don't have a personal experience in using it so far, but like all the previous speakers have also highlighted. Apart from the apprehension, if we see the holistic picture, reduced hospitalization, stable pharmacokinetics, ease of administration, and decreased annualized bleeding rate. So definitely I would like to know.
Okay, so novel drug. Everybody has done away with the apprehensions that used to be there with emicizumab. Emicizumab, which can be used anytime, any age group, any inhibitor level, any body weight, with good real world experience. But as we say, when things are too good to be true, always tread with care. Maybe they are not true. And that is what you heard in some of the voices, that we give it full marks when it comes to the concerns, we give it full marks when you use it in those inhibitors, but whatever you are using, keep your eyes and mind open for new developments. Thank you for listening to us so patiently. Thank you, all the panelists. Back to the chair.
Thank you very much, Dr. Naresh, and we are thankful to all the panelists. We had wonderful discussions. Certain solutions have been emerged. And I think so far as the unmet needs are addressed by this novel drug, I think we should continue with this, but a lot of information is needed. Well, before we go to the other ceremony associated with this, I had promised that I will let you know how an aura is generated, positive aura in a patient of hemophilia is generated by having a mere look on Dr. Naresh Gupta. Now, we know an aura in a patient of hemophilia that I consider as a negative aura, because the patient is sure that he is going to bleed in a short while. But the positive aura, in my experience, is when I was chief nodal officer at my comprehensive hemophilia care center at Jammu. We used to refer some of the patients to Dr. Naresh Gupta because I had visited his center a couple of times and have seen the working there, the dedicated staff. Because of certain personal issues and sometimes inhibitors and sometimes non-availability of the factor. Well, I used to get feedback both from the parents as well as the children. One reminds me about 13 or 14 years old. I sent him third time to Dr. Naresh. When they reached my center, I asked the child, "Doctor Sahab ko dekha?" He said, "Dr. Gupta Sahab?" I said, "Yes." "Kaisa lege Dr. Gupta, aap PC badalge." So then he looked at his father and was whispering, "Papa bolo." Then I interested. "हाँ बेटे बताइए, बताओ क्या देखा आपने, क्या बोला उन्होंने?" नहीं, उन्होंने कुछ नहीं बोला। जब मैंने उनको देखा तो मुझे ऐसा लगा कि अब मेरी बॉडी में फैक्टर 8 बनने लगा। So that is Dr. Gupta and the aura in this patient. Salute from that patient.
Thank you, sir, for such a wonderful session, and thank you to all the panelists. Now, I request our chairpersons to please felicitate Dr. Naresh Gupta, sir. Our chairpersons, Dr. K.K. Kaur, Dr. Bhavya Swami, please felicitate Dr. Naresh Gupta, sir. We have our chief guest with us, our Honorable Worthy Vice Chancellor, sir. A huge round of applause for him. Now I request Dr. Pradeep Garg to please come on stage and felicitate Dr. K.K. Kaul, sir.
It's a wait. Wait.
Now I request Dr. Amanpreet Sethi, sir, to please come and felicitate Dr. Bhavya Sonic. Thank you, sir. Thank you so much, sir. हर कठिनाइयों से अब तुझे आगे बढ़ना है, तो रुक नहीं, अभी तो तुझे और पढ़ना है. This was the motto of our Hemophilia Summit 2022. Good morning, Sat Shri Akal, Namaste. I, Dr. Anjali Handa, Assistant Professor, Department of Immunohematology, I'm so grateful to welcome our delegates, guests, and speakers to the commencement ceremony of Hemophilia Summit 2022, jointly organized by Department of IHBT and Department of Pediatrics in collaboration with Hemophilia Advocacy Society. I hope all our delegates imbibe immense knowledge from this comprehensive workshop and enjoyed our hospitality yesterday night and day before yesterday. We had wonderful two-day sessions of posters, more than 50 posters and more than 25 oral presentations. Now, without any further delay, I request Dr. Babli Kaur to please escort our Vice Chancellor, Sir, Chief Guest of the Day, Professor Dr. Anish Kumar. Dr. Babli. Now, I request Dr. Richu to please escort Dr. Rajiv Sharma, sir, our Principal, Guru Gobind Singh Medical College, Faridpur. I request Dr. Richu to please do the floral welcome to Principal, sir. A huge round of applause for everyone, please. I request Dr. Babli to please escort and do floral welcome of Dr. S.P. Singh, Controller of Examination, Baba Farid University of Health Sciences, Faridpur. Welcome, sir. Now I request Dr. Richu to please welcome Dr. Sunita Bhagat, Joint Director, P6 Chandigarh. Now I request Dr. Babli to please welcome and escort Dr. Sheikh Mittal, Medical Superintendent, Guru Gobind Singh Medical College and Hospital, Faridpur. I request Dr. Richu to please welcome Dr. Naresh Gupta, former Director, New Delhi, and he is a mentor for this workshop conference. Dr. Richu, please welcome Dr. Naresh. Now I request Dr. Babli to welcome Dr. Sandeep Verma, President, Hemophilia Advocacy Society. I request Dr. Babli to please welcome Dr. Neetu Kukul, Professor in Health, Department of IHBT and organizing chairperson of this conference. I request Dr. Babli to please welcome Dr. Varun Kaul, Associate Professor, Department of Pediatrics and Organizing Secretary of this conference. Welcome to all the dignitaries. Without any further delay, we will begin with our lamp lighting ceremony. To make this event a blessed one, invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom. For seeking the choicest blessings for the same, I invite our dignitaries on the dais and off the dais to kindle the lamp. I invite Dr. Gurmeet Kaur Sethi, co-organizing chairperson, and Dr. Shashikant V on the stage for the lamp lighting. Dr. Shashikant V is the scientific head of this conference. I invite all the dignitaries for the lamp lighting. I request all our speakers who have come from different states, please come on the stage for the lamp lighting. Dr. Tulika ma'am, Dr. Meeta ma'am, Professor Joseph John sir, everybody please come for the lamp lighting. Dr. Narendra sir. Dr. Reena Das ma'am. Dr. I request all our dignitaries to please take their respective seats. Now I invite Dr. Neetu Cooker, Professor and Head, Department of Immunohematology and Blood Transfusion, to please officially welcome all our dignitaries and guests. Good morning to all dignitaries and guests. I am Dr. Neetu Cooker, Professor and Head, Department of Immunohematology and Blood Transfusion, and organizing chairperson of Hemophilia Summit 2022. Thank you all for gracing this occasion. I am extremely overwhelmed to get this opportunity to address you all on the inaugural ceremony of Hemophilia Summit 2022. The theme of Hemophilia Day of this year was kept as Access for All, Partnership Policy Progress, engaging your government, integrating inherited kidney disorder into national policy. On this project, Nidhan was launched at our blood center to sensitize people and government on the disease and achieve better diagnosis. Automated coagulometer was installed for factors assay. We are so privileged to have with us our chief guest of the day, Body Vice Chancellor Sir, Dr. Amir Sir. We hope your knowledge and experience will help this university to rise to another level. Welcome you, sir. Next, I extend my hearty welcome to guest of honor, Dr. Smita Bhagat, Joint Director, PSEX, Chandigarh. Ma'am has put her best efforts for awareness about hemoglobinopathies and hemophilia. Our institution is providing all the factors and medicines free of cost to the patients suffering from hemophilia due to his never-ending support. I am elated to welcome our next guest of honor for the day, Dr. S.P. Total examination, BFUHS for report. He is great mentor for all academic activities of the university. A warm welcome to our next guest of honor, Dr. Rajiv Sharma, Principal, GGS Medical College, Kozhikode. He is kind-hearted and excellent in his administrative skills and has given immense support to conduct this conference. Cordial welcome to our next guest of honor, Dr. Shilek Mittal, Medical Superintendent, GGS Medical College and Hospital, Kozhikode. Sir works day and night for the best and smooth functioning of this. Good afternoon, everyone. Today we all have gathered here for a scientific workshop regarding hemophilia. I am highly honored and feel privileged to have been given the opportunity to represent from the state to address every one of you. I pay my regards to all the esteemed dignitaries and faculty members on the dais and off the dais, to all the participants and students. As you all know, hemophilia is a rare inherited genetic disease in which people living with hemophilia face day-to-day life difficulties, unexpected bleedings, pain, and mobility problems, with lot of financial burden to the family. Now, under the blood cell NHM flagship, Union Government has come out with the guidelines, financial support for the prevention and treatment of the people living with the hemophilia. Support we are providing is the provision of essential drugs free of cost at Integrated Center for Hemophilia and Hemoglobinopathies, which are established at all the medical colleges, government medical colleges and district hospitals, where we provide the essential drugs free of cost, and 5 coagulation labs in the district hospitals and 3 in the medical colleges has been established for the diagnosis and screening. From the state, we conduct awareness campaigns regarding the disease. Even with the support of National Blood Cell, we are coming up with the policy where uniformity of the disease management we are looking forward. As of now, there is a gap between the requirement and the availability. Government is working on the bridging the gap. Till now, on demand treatment, our management is being given, and now at state level, all the efforts are being done so that prophylaxis can be taken up in the management. Prophylaxis in our state is given to the patients which are below the 13 years of age. I congratulate the organizing team for organizing such
such a wonderful workshop where platform has been given to the all the nodal officers from the integrated center of homeopathies to come up and have and get enlightened on the various management of the hemophilia treatment. So with these words, I end up my speech, and I think most workshops should be conducted in the state, and where the cross learnings from all these eminent faculty members can be given to every one of you. Thank you.
Thank you, ma'am, for your kind words. Now I invite Dr. Sheikh Mittal, Medical Superintendent, on the dais to say a few words.
Good afternoon, everybody. Respected VC sir, Professor, and Rural Governor, all the delegates, guests, I welcome here in the holy city of Faridpur. I show especially the Hemophilia Society. I ensure that the best available treatment or best available things will be provided to the patients of hemophilia in Teachers Hospital. I remember these things only that Dr. Varun every 15 days requests me for a vehicle to ask for a factors, and always the vehicle is provided, and best possible all things are being given. With the help of the Government of Punjab and the PSEX Society, every time we request PSEX, Dr. Bobby Bharti and Madam, for all the help they are providing to us. Thank you very much.
Thank you, sir. I request the principal, sir, Dr. Ajit Sharma, to come and speak a few words.
Very good morning to all of you. Very respected VC sir, Dr. Amish, Joint Director PSEX, Dr. Naresh Gupta, respected Dr. S.K. Singh, Dr. Shilay, all the delegates. I extend a very warm welcome to all of you, and I take pride that in this holy city of Baba Faridji, we have been able to conduct this 3-day workshop conference on hemophilia. I'm happy to see that so many academicians from such reputed institutes have visited us to enlighten on hemophilia. This is a real pride for us. And for all this, the efforts done by Department of Immunohematology and Department of Pediatrics, they need appreciation for that. And I would say that we should clap for both the departments. Such a big effort after a gap of 2 years of almost very reduced activity because of COVID, we have been able to conduct this workshop. The science has advanced so much that hemophilia, we have been conducting 3 days deliberations. So this is a real, good for the developing sites, I should say. And we should all look forward to develop it in future also. So thank you very much to all of you for coming here and gracing the occasion. Thank you.
Thank you, sir. I request our mentor for this conference, Dr. Naresh Gupta sir, to please come forward and share your experience being here in this holy city.
Thank you. I have been associated with the hemophilia care in the country, so right from the beginning. We started in 2007-8, and all the neighboring states, we had a great interest in them. We had actually a personal interest because if our neighboring states are good, we would offload the patient cost on Delhi's part. And all of them are doing well. Punjab for some reason was not doing well. It was very top and it just did not happen. But last few years, I have seen a dramatic change. And the dramatic change in Punjab, I see, has occurred because of two individuals who are institutions in themselves who have taken the cause forward. And they took it forward to the administration. And as I believe, the administration is always supportive of the good cause. Who were the two individuals who made the difference and made this possible? One is the interested hemophilia expert, Dr. Varun Kaur. There are many others, I'm sure, with him. And the other is Dr. Sandeep Verma, and we have Dr. Virendra Bara of the Hemophilia Advocacy Society. Both of them brought in a change. With his personalized thinking, I could see over these days, and previously we've been reading for some time, Dr. Kaur has got a concern for the patient. He has got a concern for human individual. It's not patient alone. You can see in his life, it is in his DNA. And the advocacy council, I say, because we have to do a lot of advocacy in the beginning, and the right advocacy council took the cause forward. And the administration just took it up and gave them everything. And as I said, when I landed here and saw day one, I have heard the bullet train coming in this country, but the bullet train of hemophilia has been launched with them. Thank you.
Thank you, sir. I am profusely elated to take an opportunity to welcome our chief guest, Honorable Modi Vice Chancellor, sir, to please come on the dais.
Good afternoon. Dear delegates, speakers, dignitaries on the stage and off the stage, faculty and students, I am pleased to convey the greetings to the academic feast being conducted by Immunohematology and Blood Transfusion Department and Pediatrics Department at Guru Gobind Singh Medical College, Faridkot. It is a matter of great honor and pride for Baba Farid University of Health Sciences, Faridkot, to continue and supplement the academic activities to enrich the knowledge of medical professionals. The theme of World Hemophilia Day this year is Access for All, Partnership, Policy, Progress, Engaging Your Government, Integrating Inherited Bleeding Disorders into National Policy by raising awareness and bringing hemophilia and other inherited bleeding disorders to the attention of policymakers. We can increase sustainable and equitable access to care and treatment. The whole bleeding disorder community coming together to deliberate on the continuous advances in treatment while raising awareness and bringing understanding and attention to the issues related to proper care to the wider public is a welcome step. People who have this disease bleed very easily and blood takes longer period to clot. The condition of hemophilia cannot be cured, but it can be treated to decrease symptoms and avert the future complications in health. We believe that every person with an inherited bleeding disorder deserves access to care and treatment. The vision of treatment for all is that one day all people with a bleeding disorder will have proper care no matter where they live. Awareness about hemophilia is must, as most people who suffer from this condition are not aware of it because the disease is mostly inherited. Hemophilia Summit is the best platform to raise awareness for the issue and generate new ideas for the betterment of the hemophilia community. Together we take the steps to care. And lastly, I'll again like to convey greetings and thanks to Dr. Neetu and her team for conducting this summit. Thanks and Jai Hind.
Thank you so much, sir, for your words. Now we have our results of oral presentation. I request our Vice Chancellor, sir, and all the dignitaries to present the prizes for the candidates who presented oral presentation in the morning. First prize goes to Harsimran Kaur. Her topic was Impact of Physiotherapy and Joint Health Score. Harsimran Kaur. Congratulations. Now, the second prize goes to Dr. Sarthak. His topic was surgery in hemophilia patient and experience of tertiary care hospital. Dr. Sarthak. And third prize goes to Tajpreet Kaur. The topic was effect of tele-rehabilitation on functional independence in patients with hemophilia during COVID-19. Dr. Tajpreet. A huge congratulations to all the winners for today as well as for yesterday and day before yesterday's presentation and poster competition. I request all the dignitaries to please take these seats. I request Dr. Gurmeet Kaur Sethi, Dr. Sashikant Bhi, Dr. Neetu Kukkar, and Dr. Varun Kaul to please come on the stage and felicitate our Vice Chancellor, sir. Dr. Gurmeet ma'am, Dr. Sashikant Bhi, sir. Thank you to the organizing committee. I request sir to please stay back and please felicitate our dignitaries. I request Dr. Neetu Kukkar and Dr. Varun Kaul to please stay beside sir. Dr. Gurmeet ma'am, Dr. Sashikant sir. I request Dr. Babin Kaur to please present Dr. Rajiv Sharma sir.
Sir.
हाँ
I request Dr. S.P. Singh, Controller of Examination, to please come on. I request Dr. Sunita Bhagat, ma'am. Dr. Sunita Bhagat, ma'am. Dr. Sheikh Mittal, Medical Superintendent, Guru Gobind Singh Medical College and Hospital. Dr. Naresh Gupta, former Director, LHMC, New Delhi. Dr. Sandeep Verma, President, Hemophilia Advocacy Society. Dr. Neetu Bhukkar, Professor and Head, IHPT. Dr. Varun Paul, Associate Professor, Department of Pediatrics. Thank you, sir. Now I request all the dignitaries to please come forward and felicitate the organizing committee for this Hemophilia Summit 2022. Organizing Chairperson, Dr. Neetu Bhukkar. Co-organizing Chairperson, Dr. Gurmeet Kaur Sethi. Scientific Committee Chairperson, Dr. Sashi Kanthi. Organizing Secretary, Dr. Varun Paul. Dr. Sandeep Verma, Hemophilia Advocacy Society President. Dr. Barinder Brad, Vice President, Hemophilia Advocacy Society. Dr. Seema Rai, Associate Professor, Department of Pediatrics. I think she is not here. Now I invite Dr. Parul Garg, Associate Professor, Department of IHBT. Dr. Sandesh Ganju, Associate Professor, Department of Gynecology. Dr. Amanpreet Sethi, Assistant Professor, Neonatology. Assistant Professor, Department of Pediatrics. Dr. Sandeep Karhe, Department of Physiotherapy. Dr. Smarty, Department of Physiotherapy. Dr. Ishwar Kayal, Department of Forensic. Dr. Aman Bharti, Department of Medicine. Dr. Ishwar Kayal. Dr. Navreet Singh, Senior Resident, Department of IHPT. Dr. Rajendra Prasad, Senior Resident, Department of IHPT. Dr. Harpreet Kaur, I think she is not here. Dr. Bableen Kaur, Senior Resident, Department of IHPT. Dr. Thane Morgan, Senior Resident, Department of Pediatrics. Dr. Richu Singla, Research Scientist, MRU. Mr. Gulbagh Singh, technician and who coordinated the workshop with Dr. Neetu, Dr. Paru. Our technicians who helped, Ms. Nimar, Ms. Disha, Ms. Disha, Dr. Vandana, Associate Professor Yukon, Dr. Simran, Associate Professor Yukon, Mr. Vijay Kumar, I request Gulbagh Singh to collect on his behalf. And Mr. Asifan. And Dr. Anjali Khanda, Assistant Professor, Department of Immunohematology and Blood Transfusion. Thank you to all the dignitaries for their patience. Now, I request all the dignitaries please take their seat. And I request Dr. Varun Kaul to please come for the vote of thanks.
Worthy Vice Chancellor, Baba Farid University of Health Sciences, Professor Dr. Avnish, respected Principal Sir, Dr. Rajiv, respected Controller of Examination, Dr. S.P. Singh, respected Medical Superintendent, Dr. Shlek Mittal, our honorable guest of honor from Delhi, who I look forward to as the ideal in hemophilia care, Dr. Naresh sir, and Dr. Sunita ma'am, who has come all the way from Chandigarh and always providing us logistics support, although we are missing Bobby sir today. But I believe that you will take the proceedings from here for us. Dr. Neetu, Sandeep, Dr. Sandeep representing the Hemophilia Advocacy Society, all the patients, and all the speakers who have come from different parts of the country. Believe me, ladies and gentlemen, people who you are seeing here as speakers, be Dr. Tulika, Dr. Neeta, Dr. Arihant, Dr. Srinivas, Dr. Prashad, Dr. Joseph, Dr. Reena Dasna, Dr. Jasmina, Dr. Savitri, all of them are phenomenal people and they are who's and who of hemophilia in the country. So we have, sir, a warm welcome to our Honorable Registrar, sir, Dr. Nirmal. Round of applause, ladies and gentlemen. Before I continue with my vote of thanks, I would request our Honorable Registrar sir to please say a few words on this occasion, please.
Respected Vice Chancellor of the University, Dr. Ramesh, Principal of the College, Rajiv Sharma, Controller of Examination, the SPC, and other dignitaries on the dais. I just walked in and not at all prepared for a speech. Actually, I have talked to you in the other ceremony already. So, again, I'm honored to be here. And I once again congratulate Dr. Varun and his team for organizing such a grand event in Faridpur, especially like many of others said, we came for this banquet and we were thinking we were in the wrong place, we came for some marriage or something. So it was very well planned and organized by the team. I think we think this is an opportunity to congratulate for the class and like in detailed planning they are put in on organizing this. And I hope other departments of college as well as across Punjab puts up their hand to come up with such major initiatives. Once again, I thank you all from across India and Punjab being here, being our guests attending this program. Thank you and all the best.
Thank you so much, sir. I request our Vice Chancellor, sir, to please felicitate our Registrar, sir. I request all the dignitaries to please come along. Thank you to all the dignitaries. Now I request Dr. Varun Kaur to please come for vote of thanks.
Thank you very much. So continuing with the same, so we are elated to have your august presence here, and I believe that you are very busy and you have taken out some precious moments of time from your busy schedule and given us your patronage and blessings. Thank you very much, sir, for being here. And I would like to thank my faculty and all senior faculty who have come here as chairpersons from different parts of North India for blessing us, especially Dr. Sanjeev, Dr. K.K. Kaur, and I forgot to mention the crown of our country, that is Kashmir. Dr. Sheikh Bilal is also here as one of the speakers. So all the delegates who have come from different HTCs, I believe और मुझे ये उम्मीद है कि जितने भी delegates हमारे हेमोफिलिया ट्रीटमेंट सेंटर से यहाँ पे आए हैं वो कुछ सीख के गए हैं और कुछ आज और सीखेंगे और ये बेस्ट प्रैक्टिसेस अपने सेंटर में इमिटेट करेंगे. I believe this it's going to be done. And जो कल हमने 2 दिन में वर्कशॉप में आपका जज्बा देखा है सीखने का और कुछ करने का, I think that we are going in the right direction. And it would be, I'd be failing in my, vote of thanks if I don't thank the pioneer of, hemophilia treatment care being provided in India, that's Dr. Naresh, and all the senior faculty who have come here from a long way. And we are blessed to have you here. And this land, although blessed by Baba Farid ji, has been blessed by your presence, August presence here. All the chairpersons from Amritsar, Patiala, and especially I would like to thank Dr. Joseph sir. So I remember around 3 years back when we were going in the government vehicle, doing the gap analysis of all of the centers. So sir, definitely we would like to go for another gap analysis, and right now we have done something, and we will like to have a collaborative effort so that we can get Punjab on the chart of the national as well as international, recognition. So all the light staff, all the supporting staff, especially the event managers, I thank you all, the media persons, and last but not least, the people who have sponsored this event. So I would like to thank you all and thank you from the core of my heart. So without much, I would like to say thanks to everyone. If I missed anyone by chance, so thanks to everyone and wish you all the best and all the best in learning. And we will break for, we'll have a national anthem. After national anthem, we'll break for tea for 10 minutes and within 10 minutes back again. Thank you very much.
जय गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जगधि तरंगा तव शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जय जय मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I request everybody to please proceed for tea. I request all the participants to please come inside. We're going to start our next session very soon. Welcome back, everybody. We will start with the next session. I invite the chairperson for the session, Dr. Gurmeet Kaur Sethi, Professor, Department of Pediatrics. Ma'am, please come on the stage. Our second chairperson for the session is Dr. Gurmeet Kaur Sethi, HOD Pediatrics, the Management Hospital, Amritsar. Welcome, ma'am. I invite speaker for the session, Dr. Tulika Singh, Professor Hematology, AIIMS, New Delhi. I request our chairpersons to please introduce ma'am.
Good morning, everyone. Please welcome Dr. Tulika Singh. She is Professor of Hematology at AIIMS New Delhi. Examined national board examination for clinical hematology. He is a member of the governing body of Delhi School of Public Health. He is a member of National Center of Excellence and Advanced Research. He is a member of AIIMS Stem Cell Ethics Committee. He is also a member of AIIMS PT Ethics Committee. He is a member of National Research and Development and Therapeutics for Rare Diseases, the Hematology Experts Group. And he is with the panel of Indian experts on drafted and guidelines for thalassemia and sickle cell anemia. He has authored more than 200 papers and more than 40 books published with a guide go back for more than 60 DMs, PhD and PhD. Please welcome her with a big hand.
So I thank you very much for this very kind invitation, and I am amazingly impressed by the work ethic and the interest that people have for hemophilia. With this, I will speak on my assigned lecture, and I am today going to be talking about extended half-life hemophilia factors. So the things I'll cover today are what are the EHL factors, what do the guidelines say about them, what are the techniques of making a standard half-life factor into an extended half-life factor, and what are the benefits of this, what data do we have about using these, and a little bit about the extended half-life factors that we have available in India and data related to that, and some things about what we can do in the future, because now we have an armamentarium of products to use for our patients. As you all are very well aware, hemophilia has transformed, particularly in the 20th century. Earlier, we were using things like whole blood, FFP, and then we were fortunate to get the plasma-derived clotting factors, and then an innovation was the recombinant clotting factors. And now we have extended half-life for long-acting clotting factors, and we have the non-factor therapies, which we talked about a little in the beginning. But we still have a lot of unmet needs in our country, and we know that the hemophilia care varies from region to region. A lot of patients, unfortunately, still have disability due to joint damage, and many still suffer from a very high ABR and have breakthrough bleeds despite the availability of products. Patients need multiple injections, which is a problem, especially for small children. And we're not really seeing the good outcomes that we would hope. And one of the innovations that can help us is the extended half-life clotting factors. So what exactly do we mean by an extended half-life clotting factor? So the definition is that they should have a extension of at least 1.3 or higher. There are different techniques by which we can do that, though there is still some ambiguity into what exactly we should call a standard half-life and an extended half-life. So the extended half-life products are able to give us a higher trough level because they are in the body for a longer period of time, and we all know that the routine 1% trough level that we want to aim for in hemophilia A and B patients often is difficult to achieve with the standard half-life products, where you need 3 injections per week every alternate day for the hemophilia A patients, and twice a week for the hemophilia B patients. So having 3 injections a week is quite a lot. So if you have a product for a factor 8 extended half-life product where you can reduce the injections from 3 injections a week to 2 injections a week, you are actually reducing about 50 injections in a year. So an extended half-life product can give you a higher trough level, and it can decrease the number of injections in a year. And we know that the extended half-life factor 9 products are even better because it's a different molecule, and with the same methods of using extension of the half-life, the factor 9 products can be used only every 10 days or even in some cases every 14 days. So what does WFX guidelines say about safety? So there is no preference to using any extended half-life product even in WFH, but they do comment that there's no evidence of any safety concerns, and there's different methods of using extending half-life by either pegylation or FC fusion or albumin fusion, and these are mechanisms which have been used in many other drugs and have now been used for the anti-hemophilic products. So, and WFH does highlight the fact that this decrease in dose frequency is important, and you can even maintain higher troughs, which can optimize the prophylaxis, because we know that there are patients who need a higher trough level in order to prevent breakthrough bleeds, and this could be either due to the pharmacokinetics of the drug in the patient, or due to increased activity, or having target joints. So these are some of the good things about safety that WFH 2020 says, and I just highlighted that there are currently 3 different mechanisms by which the extension of half-life is done: pegylation, FC fusion, and albumin fusion. And we have different products that are doing that, and pegylation is done in these products that have been labeled. So the benefits that we see are multiple. And these have been defined not only by many authors, but they can potentially improve the quality of life of the patients, because multiple injections may mean that patients would need to have a central line in order to get these. And definitely, we know that in many government hospitals where prophylaxis is being given, patients actually have to come to the hospital in order to get these injections. So having an extended half-life product would be less traveling to the hospital in order to get the prophylaxis if it is being given at the hospital, not the home. So, what does the WFH say about prophylaxis using the extended half-life products? It definitely says that these are useful and they can be used. So we can use standard half-life products for prophylaxis, or we can use extended half-life products for prophylaxis, and the choice then depends on the patient and the doctor and of course the payer. So what about real world data? So a lot of the evidence that usually comes when a product is released are through the pharma company sponsored trials and things. But this is some data from Canada where they actually had used a factor 9 extended half-life product, and they presented the real world data. And they did find that indeed in the 40 patients that they evaluated over almost 1 year, that there were 65% fewer bleeds after switching to an extended half-life product, and there was 75% less injections. So you are having a better quality of life with less injections. And the most interesting thing was that you have 65% reduction in factor consumption. So how does this reduction in factor consumption arise? One is that you are having less frequent injections, and two is because you're having less bleeds, that each bleed needs to be treated. And this is something that often people forget, that when you're doing prophylaxis, that is just to prevent the spontaneous bleeding, but even when you do have a bleed, each bleed needs to be treated. And so overall, this led to, when compared to the standard half-life product, this led to a significant decrease in the amount of clotting factor that needed to be purchased. So even though sometimes the extended half-life products will be more expensive than the standard half-life products, overall your consumption of products is less, and that will be important. So what about other country data? So from Austria, they did a review, because most of these countries, they have national insurance and they provide for these factors. And similarly, so that was from Canada. And then we find the same thing is there in Austria, Italy, and in Sweden. All of them found fewer bleeding events and overall a less usage of additional factors and improvement in the clinical outcomes. And the end result of this is that you may not end up having to have a higher expenditure in spite of the fact that you're using a more expensive product. So what about the extended half-life products that we have in India? In India, we don't have all of them at the moment, but hopefully more and more extended half-life products will be coming to us. So we have two that are approved by CDSCO, and one is a extended half-life factor 9, and one is an extended half-life factor 8 product. So both of these are available, and we've been using it for reimbursable patients. And they are mostly, both of these are by pegylation, and we know that by addition of a pegylation of the peg molecule, we can increase the size of the molecule, so that reduces the filtration by the kidneys. It decreases the accessibility to proteolytic enzymes, and basically improves the stability of the drug and the half-life of this product. So just a little bit on the extended half-life factor 8. So this, as I said, is a pegylated molecule, and it is a B-domain T molecule, and this is available in India with us. And it was approved by multiple studies which have happened over the last decade. And these studies have been completed, and over 900 patient years of exposure have been done, which have shown them to be safe and efficacious. And there are still some studies being done. The Pathfinder 6 is being done in PUPs. PUPs are previously unexposed patients who have not received any other factor. So we do have a large body of evidence, and this was approved by the FDA and EMA in 2019, and as I said, available in India now.
The main findings from this was that the effective dose that is recommended is about 50 units per kg, and it's given every 4th day. So you can reduce the amount of injections that are required. And in the data that they found, there was a reduction in the ABR to up to 0.84 ABRs per year. And most of the patients actually experienced a very significant reduction in the ABRs, and in fact, in the 50 IU per kg every 4th day, some patients even had 0 ABRs. So this was in the Pathfinder study. And over time, when you use these products, there's further reduction in the ABR, and I think one of this can often be because of improvement in the target joints. So when patients have target joints, often they will continue to see bleed into those joints, even when you are giving prophylaxis, because in the standard half-life prophylaxis, we know that the trough level is only 1%. So both when you're using an extended half-life product or when you're using a non-factor product like emicizumab, we are able to see an improvement in the target joints, and that is because you are raising the trough level to a much higher level. So continuous use of these products further leads to an improvement in the ABRs over time. And again, just like we had heard in the presentation with Dr. Naresh Gupta, there are patients who actually can have 0 bleeds. So with the standard half-life products, attaining a 0 bleed is actually very difficult, but again, with both the extended half-life products and some of the non-factor products, we are looking at 0 bleed. And in the Pathfinder 2 study, they had 64% of adolescents and adults had 0 bleed after a period of time. So, and even in children, this reduction in the ABRs was seen, and we know that children are very active and playful, and about 70% of the children here had 0 bleeds after using these products for a longer period of time. So, as you can see, very few bleeds in these patients. And as I said, the target joint resolution was really dramatic. And we know that a target joint is a joint in which a patient can have more than 3 bleeds in a period of 6 months. And so these are actually very troublesome joints, particularly since most of our patients actually are not on true primary prophylaxis, and many of them already have target joints by the time that they come. And so overall, not having a target joint is good. And with with less breakthrough bleeds, you have less bleeds that need to be treated. So these are all the benefits of doing this. And can you do surgery with these extended half-life products? Yes, you can. And in fact, these are very safe for surgery and can give you a good control during the pre-operative, operative, and post-operative period. And there is now enough data to support the use of extended half-life products during surgery in hemophilia patients. So altogether, the factor 8 extended half-life products are very good. Most of the data is on previously exposed patients. So these are patients who are not pups. So these are patients who've had more than 50 to 75 exposure days. And the inhibitor risk is not at all increased. The adverse events are very few, and there's no safety concerns with pegylation. The laboratory testing has to be done. You have to read the product label because sometimes the testing has to be done with certain company products. So it's important to read the label so that you can do that. But routine coagulation tests and inhibitor tests can be performed with these products. So this is just a summary of that. Now we'll move on to the factor 9 extended half-life product, which we have had a significant experience on. We've got quite a few patients, mostly adults, who are on this product. And again, this is a pegylated product that is there. It's also a three-domain cleaved product. And there have been multiple trials on this, most of which have been completed. And again, we have some trials in the population which are ongoing. So what are the characteristics of this? The half-life of this, as we said, it should be only 1.3 times more, but here you can see that the half-life is actually 5-fold increase. So this is an excellent extended half-life product, and because of the half-life of about 93 hours, which is about tenfold increase of the area under the surface versus the standard half-life factor 9, you can end up with giving the dosage at a very wide interval gap, and the dosing recommended is 40 international units per kg, and it's usually given every 10 days. So this is initially they studied 2 different doses, and they found that the 40 IU per kg once a week or once every 10 days is more effective than the lower dose. So that is the dose that is recommended, and again very effective in reducing the ABRs in children, and a very large number of patients were bleed-free and did not have spontaneous bleeding. And the number of injections, obviously, as you can see, would definitely decrease as well. So this is another very good armamentarium that we have available to us. And because of its very prolonged surgery, very prolonged half-life, in surgery it's even more effective, and you can actually do some surgical procedures with just a single dose, or even if you have a major surgery, then you will have a reduction in the number of injections that would be required to cover the surgical period. So this is again very useful for our patients, and altogether, again, most of the data is on previously exposed patients who had more than 50 exposure days. So there's no safety concerns, there's no risk of thromboembolism if used properly, and no other side effects that were available. And so, if you look at the long-term data that we have, pegylation is a very effective way of extending the half-life. It can be used in prophylaxis, it can be used on demand as well. So we do have patients in our country who are not on prophylaxis, but in both of these situations, it's very effective. It can be used in surgery, and we have real-world evidence to show that by putting patients on extended half-life products, we can reduce the number of injections, and we can overall reduce the number of bleeds, and altogether we would reduce the number of units of the extended half-life factor, so that it could be actually much more realistic and cost-effective. So this is just to summarize that because of the less bleeds that you're having, you're actually ending up using much less doses of factor. So if you compare the units that you would use if you are using an extended half-life versus the standard half-life, the amount of factor units you would need is actually going to be less, either when you're treating a bleed or when you're doing surgery. And to summarize, this is from several review articles which have been written by Dr. Manucci, who's a famous hematologist in Italy. And he also has in this review summarized that when you're using an extended half-life factor 8 product, you will have a reduction in the number of injections by 30%. You'll be able to increase the trough to 2 to 3 very easily. And you have the half-life of the product is usually 1.3 to 1.7. When you're using factor 9 extended half-life products, you're reducing the number of injections by 60%. You can raise the trough levels to 5 to 10 IU. And so all of these products will definitely contribute to fewer injections, less bleeds, which overall will lead to a better quality of life. So extended half-life products, I feel, are a very important value addition to the types of products that we have to help our patients. And there may be patients, especially those who live far away or who have target joints, who could benefit from these products. So that's it. Thank you.
And I think it would make it very clear for somebody who even does not know about EHLs to understand what it is. There's this one query that I have. Like you were saying that EHLs are basically expensive than the SHL. But if we were to look at the whole picture, the decreased annual weight rate and the total consumption of factors, wouldn't it be more cost effective than the SHLs?
So that's a really good point that you made. And we don't have data with us, but many other countries have looked at this and they found that over a longer period, over like 1 to 2 to 3 years, they actually work out to be cost effective because you are using less product and you have less visits to the hospital, less doctor-nurse interaction. And so what you said is completely true, that over time, they are cost effective. And that's why it's important to not simply look at the cost of one vial, we need to look at it over a longer period of time.
Thank you so much. And second, I just wanted to shed some light on the other methods of extending the half-life.
So the FC fusion again is a method of increasing coagulation, and this basically is done through by adding DWF and other factors. And albumin is actually not so commonly used. It's just given in the list of products, but I don't know of any albumin extended half-life product that is available in India. We have some other products which may be coming to India in the next few years, which are either pegylated or FC fusion. So these are all very safe, and as I said, they're used in a lot of other drugs like oncology drugs and other things. And the concern was that the pegylated product, there was some safety concerns about pegylated products earlier, but now we found that that also hasn't really panned out.
Thank you so much. Any inputs or queries from the audience?
Thank you so much, ma'am. I have,
Excuse me, there is a query there. Please hold the mic near the.
I heard the question, so I'll just repeat that for the audience. So you're asking about extended half-life products in low-dose prophylaxis. So you have to realize that the low-dose prophylaxis has been propagated mostly by the countries like China and Algeria and India. So this was done as a cost-saving strategy. So we've not actually had the extended half-life products for that long, but we have to wait to see if there is going to be any data. But I've not come across any low-dose extended half-life data as yet. But good point. I think maybe once we have these products with us for a little bit longer, I'm sure we will do our Indian jugaad and see how we can use them better. Thank you.
So can we use that as a low-dose prophylaxis?
So there is no data as yet. So I don't. So I always at AIMS we are very particular when we do something. We follow the guidelines. If we're doing something that is not as per the guidelines, then you should do it as a study. Because, see, the reason why we're using factor is to prevent joint damage. So, you may be doing something that you think will help the patient, but we don't have any long-term data of using less product. And if the patient suffers and you're doing something, I mean, your intention is good, right? You don't have much available, you want to do something, but unless you have data as a doctor, you may be liable. So I always would recommend that if you're doing something which is not as per the recommendations of the company, you should do it as a study.
Thank you so much, ma'am. Thank you.
thank you, Tulika ma'am. Now I request you to please stay back. I request our chairperson to please felicitate our speaker, Dr. Tulika ma'am. Huge round of applause. I request Dr. Sandesh Ranjan to please felicitate our chairpersons, Dr. Gurmeet Kaur Sethi, ma'am. I request Dr. Varun Kaur to please felicitate Dr. Manmeet Sodhi, ma'am. Huge round of applause. Thank you so much, chairpersons. Now we will take over another session, the diagnostic challenges and pitfalls in bleeding disorders. To chair this session, I invite on that stage Dr. Rajiv Joshi, Professor and Head, Department of Forensic, Guru Gobind Singh Medical College and Hospital, Faridpur. Dr. Rajiv Joshi, sir. The second chairperson for the session is Dr. Pradeep Garg, Associate Professor and Head, Department of Radiotherapy, Guru Gobind Singh Medical College and Hospital. The speaker for the session is Dr. Savitri Singh. She is Additional Professor, Department of Pathology, Postgraduate Institute of Child Health, Noida. I request our chairpersons to please introduce Dr. Savitri Singh ma'am.
At the onset, we congratulate Department of Immunology and Blood Transfusion and Department of Pediatrics for and Hemophilia Advocacy Society for making such a wonderful conference and workshop at this small town and raising the standard for the next conferences. Next speaker is Dr. Savitri Singh. She is Additional Professor, Pathology in the Department of Pathology. She has done her course graduation from the KDMC Lucknow. She is trained in hematopath from the UCMS Delhi, doing hematopath in Pediatric Institute Noida. She has keen interest in hematolymphoid malignancies, HLH, PID, and hemophilia testing. She has having more than 50 publications to her credit. Dr. Savitri.
First of all, thanks to organizer for giving me this opportunity to have to share my experience on hemophilia testing. So, first of all, I would take you to the normal coagulation phenomenon. All of us know whenever there is injury, there is role of breach in endothelium and there is instant vasoconstriction, followed by there is breach in endothelium and then there is release of one factor. All of us know that is present in endothelial cells in specialized body, that's called medial alert bodies. This one-milligram factor has a very important role. It unrolls on the surface of the damaged endothelium like a carpet, and then on them there is attachment of platelets. This is a photograph showing how the interaction happened. 1 milligram factor, platelets, and then later on the formation of primary hemostatic blood. Then we should see carefully in the photograph there are platelets created on the surface having this adhesion molecule, glycoprotein 1B, which is essential for attaching with the 1 milligram factor. And that's if there is defect in this particular receptor, then the diagnosis is Werner-Schulze syndrome. Then following this, there is change in the shape of the platelets, and further platelets are recruited to the site of injury, and there happens this platelet aggregation. Later on, there are these granules within that, and if any content of the granule is missing within the platelet granules, then we have a storage pool defect. Diagnosis for that is after having exclusion of other platelet disorders. Whenever injury is happening, primary hemostatic blood is in function simultaneously, both the cascade intrinsic as well as extrinsic comes into play. So extrinsic pathway, as we all know, thromboplastin tissue factor is released, which later on activates factor 7, which extends factor 10, make it factor 10 activated. And then simultaneously, intrinsic factor pathway is surface activation with factor 12, acting on factor 11, then 9, then of course on 8, and later on provides formation of thrombin. This Thrombin generation is a very important step in coagulation mechanism. This thrombin acts on fibrinogen, which is a soluble protein, later on converts into insoluble protein, that is fibrin, and this fibrin further is stabilized with the help of factor 13, and that forms the stable clot. So after having recap of coagulation phenomena, now we go on to little bit clinical. So primary hemostatic blood formation, that is involvement of blood vessels, platelet, and 1 milligram factor causes surface leaks, and it's instant. However, whenever there is secondary hemostasis comes into play, where factors are missing or reduced or chemically not up to mark, then we get muscle bleed, or maybe joint bleeds. So primary bleeding disorders mainly are platelet disorders. All of us know quantitative, whether there is production defect or maybe there is qualitative defect. So ITP, you all know a clinical manifestation where platelet will be very low and it's autoimmune. Next, which is of our interest is quantitative, where we see missing glycoprotein 1B, that is Werner-Schulze syndrome, where platelets are larger in size, and Glanzmann thrombostemia, there is aggregation defect is there, and third effect, their platelets may be normal in number, yet they will not be functioning well and having some storage pool defect, and the diagnosis is by exclusion of other platelet disorders. Next comes 1 milligram factor, which is very important factor in coagulation at every step, right from vascular endothelial injury released from there to unfolding on the surface of endothelium, and later on as a partner with factor VIII. Without this 1 milligram factor VIII cannot have proper functional activity and also stability. If this is lacking, factor VIII, even if present in normal amount, may be washed off, cleared from the body. So in general population, it is estimated that 1% population has this 1 milligram disease, and manifestations are maybe going unnoticed, like in females case may have menorrhagia, yet may not be investigated for the same. Another issue is that even if clinicians are suspecting 1 milligram could be a possibility, yet testing is not that plain and simple. We have to do multiple test levels and sophisticated tests to make the diagnosis. Then bleeding disorders because of the secondary hemostasis, we all know hemophilia, commonly hemophilia A, hemophilia B, and very rarely do we get hemophilia C, that is factor 11 deficiency. Maybe variable symptoms may not be picked up. Patient may have normal life, and accidentally it happened to get factor levels done, APTT prolonged, and then we might fix the diagnosis. Rare bleeding disorders, to name a few, are factor 5 deficiency, 2, 10, and factor 5 may be associated with factor 8 also. So by dealing with severe hemophilia, we should keep in mind if there is some clinical presentation or maybe treatment not effective or inhibitors are there, are we dealing with factor 5 deficiency as well. Then acquired causes are much more commoner than the actual bleeding disorders, so congenital. So in a case of bleeding manifestation in a patient, we should always know vitamin A deficiency, warfarin, and liver disease, and the test should be interpreted in accordance with these history available. Then this coagulation cascade, everybody is very well aware, and from previous days, when we were a student, always used to feel scared after having seen what is this, that many factors, we have to know about that many factors, then common pathway now. Since now dealing with this, I think we all have to understand it to make a simple approach for testing interpretation. So intrinsic factor 12 usually doesn't cause any bleeding manifestation other than maybe thrombotic pregnancy. So main factors in intrinsic pathway 8 and 9, which APTT is prolonged, most likely could be because of that. In extrinsic pathway, we are likely factor 7. And secondary causes should be kept in mind when dealing with PT preparation. Then, of course, common pathway, and then finally, fibrin formation. Then, the approach we have to ask the clinician requisition form that is very much mandatory before proceeding for the test. It so happened once with us that we had, our staff did not bring requisition form, and as usual we thought inhibitor assay has been asked, so we perform factor VIII assay on the patient. And when we make factor assay testing, always we do factor assay asset. So factor assay was found to be 1% and inhibitors are also present. When we had made report, we got to know patient was suffering from factor IX deficiency with inhibitor, and then we performed that molecular testing also that for the same, and it was found that the patient was having actually factor IX deficiency. So requisition form can save a lot of time, effort, and anxiety to the patient, and of course that financial burden will itself. Then there is one bleeding assessment tool which is very important to be kept by everybody in clinics as well as in labs. When we receive properly filled form, most of the time diagnosis is pinpoint and it can be correlated with the test performed very well. So for children, this score is more than 3, adult male more than 4, adult female more than 6. It may take 5-10 minutes to complete the forms with all the questions I put in back, but later on it saves and narrow down diagnosis to much extent. And many times it happens that normal test results not associated with bleeding. So we should consider when platelet count coming low, we should always see the CBC graph which is provided with the CBC analyzer, and if it's a well-fitted curve, then platelet count is taken as what is depicted in the impedance methodology of 3-part analyzer. Yet, if we see there are few very low count, and clinician is not expecting anything pertaining to platelet, we must always see peripheral thalassemia, which will resolve our problems to much extent. Then coagulation, there are instances where ATTP will be prolonged, but patient may not have bleeding. And even if there is no clinical presentation, ATTP is coming high, still there are possibilities such as factor 13 deficiency, high molecular kininogen, and leukocytic coagulation. Then this is a microphotograph showing that there are few clusters of platelet, and yet platelet count was less. When we checked this here, we found that there were platelets present in group that could be pseudo thrombocytopenia because of the EDTA dependent agglutinin. Then we can have fibrin threads also like that in NH platelets, also WBC. So in that case, WBC as well as platelets both were low. So we should always make it a habit to see peripheral thalassemia before jumping on to conclusion or patient is having thrombocytopenia, so for the workup to be done. Simple PS examination can solve the issue. So after this, we now go to coagulation level. As such, in our personal experience also, we have seen whosoever is posted in hematology, we try to do TLC, DLC, PS, everything, but when it comes to coagulation reporting and testing, nobody wants to take charge of that work. Everybody finds this difficult. So there should be dedicated staff, like from pathologists as well as the technical staff, who should have keen interest and who should be motivated to take the coagulation testing very passionately. Not that they have to do out of compulsion, then of course results may not be that correct. So the lab should have test proposed. So whatever test is asked, that only we do. Many times surgeons would say BTCT has been sent and you have to do. Then we have to tell them bleeding time in special circumstances may help, like you are suspecting vascular endothelial defect, or maybe von Willebrand disease, or maybe some platelet disorder. To some quite extent, bleeding time may help, but clotting time is not going to help clinician anyway. So if clotting time is asked, we should discourage and we should tell them you can rather ask the procurement time and ATTP, which will give you about the both intrinsic and extrinsic pathway functional integrity is maintained, and PTADP both are normal. Clotting time is obsolete and that should not be done. When it comes to equipment, we should have all the equipment which are validated AMC, CMC should be done, not that equipment was out of use and suddenly test has been asked. So today we are maintaining an equipment for 3 advanced coagulation का test आ रहा है. Always we should have some backup instrument. Like we have one semi-automated stato analyzer and as backup, and we have that fully automated also. So in case any problem with the small machine, we have proper big machine, and also we can cut short on the reagents itself. Then reagent, when we are receiving reagent from the person who is delivering to us, we should have in writing that reagent were transported as per the proper norms. The temperature was maintained, not that reagent was exposed to high temperature and then it is delivered at the end. And when we do calibration, it is coming all wrong, and subsequently results are likely to be altered. Then sampling, this needs very special mention, especially in pediatric setup where sampling itself is a difficult thing. So we should decide area which is veins are clear, not affected by any lesion, and free flow of blood should come. If it is difficulty, better that hub should be removed and then free flow of the blood to be taken into the proper vial, not that vial was of for something and sample was collected less and later on some more was added from the other vial and then reports are likely to be wrong, and it happens actually. Then transport of the sample is again very important. It should not be till patient will start 5 to 6 times inversion. Not that we have given patient sample and patient hilate में ला रहा है कि staff ने बोला patient जल्दी से लेके जाना है हिलाते हुए जाना. So by the time it reaches in that, it will be of having some minor hemolysis and our testing may not be appropriate. Ideal situation, coagulation lab should have a phlebotomist taking sample then and there and without further delay should be put in processing. Then transport, again the temperature is very important. It should not be placed on ice, like plasma was separated and placed in ice and sent from the camp or other area. Then there may be cold activation of factors and our results will be wrong. Time lapse after sample drawn is also very important. In some texts they say minimum within 2 hours you should do if it is at room temperature. And if you have to delay, then 4 hours we can accept at 4 degree temperature in refrigerator. Better we do within 2 hours. If any delay further than that, better to take out plasma. And where all we can go wrong while testing for basic coagulation testing, such as platelet count. I showed Then testing can be done on manual as well as semi-automated or fully. I'll take you 5 minutes more. Then reagent ISI, I've already talked about.
ये low resolution उठा रहा है.
Most sensitive PT reagent picks up the mildest significant difference in PT when factor 7 levels are 14% and 17%. So that's a good reagent. That's Bethesda assay, and it's a routine, classical Bethesda assay we are doing now, which may give little higher values as compared to chromogenic assays. So ideal situation when patient is put on EHL or any medication such as emicizumab, to have the correct value of the factor, we should resort to chromogenic acid. Then one word about inhibitor acid. When we are doing inhibitor acid, we have to take care of that buffer and PNP value should always be more than minimum 80%. If this value is not correct, rest of the dilutions and all are 100% correct, your calculation will be wrong and you will be giving wrong result for the patient. So we have to be very careful about PNP value. It should be more than 100. If it is 122, then also it is incorrect. If it is less, then also it is incorrect measurement of our Bethesda assay. So we have to be very careful about PNP plus buffer value, and our PNP should be close to 100. And nowadays commercially available PNPs are there, which will be having 100 IU, and then they are most accurate. Then shortcomings are there, so there are modifications for this Bethesda acid. Now, instead of buffer, we will use vector deficient plasma so as to provide milieu in the environment, milieu that pH and degradation of the protein doesn't happen, and that is a very good method to follow, which may be modification. Then there can be loss of factor VIII independent of inhibitor, that if the sample is left. So I'll skip to all, now go to last slide. I take pardon for taking more time. Take home message for today's talk is 1 minute rule. That's for sampling, right? From putting needle to having sample in the tube, mixing and coming tapping is 1 minute. If it is more, then it is not correct. We don't have to apply pressure or squeezing, and that will all be giving incorrect value. Maybe tissue fluid has gone, or maybe platelets because of margination will be giving wrong values. Backup plan should always be there. Today, when good start has not come, Bethesda cannot be done. That is unacceptable, especially when we are dealing with hemophilia patient. And then another thing, we should always keep 2-3% who are expert in doing and do manually also testing. What if machine goes wrong and we don't have backup, then also we should deal with that. Thorough knowledge of reagent is very important. Doctors who are ordering for P2 must know what ISI value they are asking for. Vendor will be, madam, this by no, we have to say we want this only, we will not do this. Right? Then APTT reagent also we have to see in the leaflet phosphatidylserine serine content is there, how much is there, and we can check with other doctors what they are using. So appropriate has to be, not that any APTT given to you and that is giving higher values and we are doing test for it. Limitation of test message we have already told. Communication between the clinician and pathologist is very important. We should not hold any information pertaining to patient care. If tests are coming incorrect, we should inform and ask for repeat sample. Then reference range for the age of the patient is very, very important, especially in neonates we are dealing. Not that some patient APTT is coming high of a 6-stage child and we will say the APTT is high, factor 9, then it is less, it otherwise would be less. So we should not label patient just because values are coming low. We should have knowledge to correlate with the set test. And that's what sorry for taking more time. Very exhausting.
Thank you, ma'am. It was very nice presentation, and that will recognize your effort for practical aspect of bleeding disorder. And it's, I think, it's a basic part of the hematology system. And thank you very much.
Thank you so much, ma'am. Now please stay back for a few minutes.
I have one question.
It is one question.
Ma'am, is there any advice for needle gaze while taking sample? I have seen some institutes started this reason. They say that needle is not correct. Any gauge thickness of the needle while taking sample advice?
That will be better. For adults, we are taking with vacuum cleaner and we have an adapter for that. That otherwise has a thicker bone needle. So adults we will not have problem. For pediatric population, better to have thin so that you should have access to the vein. And free flow of blood is more important and as early as possible within 1 minute from sample. And sampling is the only thing most important in history. Rest test always comes correct mostly.
Ma'am, I mean, in case of hemophilia, how much gap is advisable?
A huge round of applause for now. Next, Dr. Sandesh Chandu and Dr. Paul will please come on the stage and felicitate the chairperson of the session. Dr. Sandesh Chandu, please felicitate Dr. Rajesh Joshi, sir. Dr. Palu, now please felicitate Dr. Pradeep Garg, sir. Thank you so much, the chairpersons. We'll begin with the next session, recent advances in hemophilia B management, role of EHLs. The chairperson for the session are Dr. Sanjeev Bigra, Professor and in charge, Professor Pediatrics and in charge Thalassemia and Blood Disorders, GMC Jammu. Next, I invite Dr. Baljinder Kaur, Professor and Head, Pediatrics, GMC Patiala. Due to some technical issues, there is some delay. Please have patience with us. I invite on stage Dr. Meeta Radhakrishnan, Associate Professor in the Department of Pediatric Oncology, Postgraduate Institute of Childhood, Noida. I request the chairperson to please introduce our speaker.
Good afternoon, everybody, and thank you organizers for the kind invitation. It's a matter of pride for me to introduce such a highly accomplished person, Dr. Meeta Radhakrishnan. She is Associate Professor and Head Department of Pediatric Hematology Oncology, Postgraduate Institute of Childhood, Noida. She is fellow in hemostasis and thrombosis, University of Milan. DNB Fellowship in Pediatric Hematology and Oncology, St. Gangaram Hospital, Delhi, MD Pediatrics, University of Kerala, and her professional positions are: she is Honorary Secretary, Pediatric Hematology Oncology Chapter of IIT. She is co-chair SIOP Global Health Partnerships, and she is member Scientific Program Advisory Committee SIOP, and Vice President, Indian Society of Primary Immunodeficiencies. And she is also section editor, Pediatric Hematology and Oncology Journal. And she has published numerous papers and published various chapters in various books. So over to the Meeta Radhakrishnan. She will be speaking on recent advances in hemophilia B and management of role of EHL in management.
Thank you, Dr. Sanjeev. Before I start, I again want to thank the organizers for this kind invitation. And over the last 1.5 days, it's been a wonderful experience interacting with all of you. Like was mentioned earlier, it almost looked like a wedding party yesterday evening, and we were actually hesitant to go inside, and then we realized it was a very organized wedding. So coming to the topic, so we are asked to speak on the role of what are the recent advances in hemophilia B pertaining to new products like which are extending the half-life of this drug. So we start from where we are. So across the globe, we have very few patients of hemophilia B, let's say. So compared to hemophilia A, the numbers of patients are less. And in India, as per the World Federation data, we have around 3,000 patients of hemophilia B. Now, when you look at B versus A, the hemophilia B is the second most common type of hemophilia. It is an estimate is 1 in 30,000 live births. So if you go by estimates, you know that this is not the numbers that we should be seeing. We are seeing very small fraction of what should be actually diagnosed. Severity classification is exactly the same as that of A. And clinically, when a patient walks in with a B, we are not able to actually distinguish whether it is A or B because inheritance, everything else is similar. So for a while, there has been a discussion as to whether clinically patients with B are less severe compared to A. There was a lot of discussion around this also. So when you look at the mutation, so the bleeding profile is essentially same. It's just that there are series of patients, registry data, especially from US and Canada, which have shown that the patients who are present with hemophilia B series, the number of patients who come with a severe bleed joint involvement is actually lesser. So is there a biological basis to it? That has not been clear so far, but there are some thoughts on this. So if you look at the mutation also, there are in A, you know that 50% of patients, around 50% of patients are severe hemophilia A, and among them, the majority have this mutation, which is intron or inversion 22 is the major mutation in that. Whereas if you look at B, missense mutations or kinship mutations, etc., are more common than stroke codons. So that large deletions are little lesser, not little, are actually very less in hemophilia B compared to A. And also, if you look at the protein molecule, the protein is much smaller. So smaller protein, and probably because of that, there are some implications. There are some physiological implications for this. So the similarity ends in the fact that there is a bleed pattern which is similar, which is joint muscle deep bleeds that you see in both the diseases. But overall, apparently factor consumption is lesser worldwide. And even data will tell you that the patients who are on prophylaxis and hemophilia B, apparently the numbers of patients are less when if you have hemophilia B versus hemophilia A for the same degree of severity. And the patients who go on to have joint damage, the patients who go on to have as an ultrasound source or patients who need orthopedic surgery, hip replacement, etc., or knee replacement, etc., will be less. So there are a lot of explanations for this. Couple of things which have come up. So there could be associated prothrombotic factors. It could be some other, like I said, it could be that the mutation is less severe. It could be because of the reporting bias. Have we reported them wrongly? That is also a possibility. So there are some of the things which are floating out there, but some things which have come out interesting with that. There is a extravascular distribution of factor 9. So when you give factor 8, like all of us know, when we give 1 per kilo, there is a 2% that is we are expecting inside the circle. So if you want to raise 20%, we are giving 10 per kilo. Whereas in factor 9, we are dosing at the same. That is because the volume of distribution of factor 9 is more than the volume of distribution of factor. It's around 4 to 5 times more. Because it's not just staying in the intravascular system, it's actually coming out into the extravascular space. But whether this has a direct implication on the bleed or the recovery from it, that's not very clear. But this is something which is interesting, and this is thought to be a reason to explain the difference in the pharmacokinetics, the difference in the bleeding phenotype, as well as the response to a treatment that we are giving. Another interesting thing is that there is something which has been again reported, it's getting reported recently, is cross-reactive material processing. So that we all report factor 8 and factor 9 and 1%, 2%, that kind of number. But when you report, so any detectable circulating factor is reported as cross-reactive material. So when you look at that, compared to factor 8 and factor 9, there are more patients who have CRM, that is cross-reactive material. Any detectable factor reporting would be more for factor 9, hemophilia B than hemophilia A. So there is a thought process that there is some circulating factor 9, maybe it is dysfunctional, and that is actually enabling tolerance. And that is why, this is one reason why probably you don't see so many inhibitors. So inhibitors also we heard earlier also that around 20% of hemophilia A will develop inhibitors, the PUB patients, whereas around 1 to 2% of hemophilia B develop inhibitors. So this is one explanation that there is some dysfunctional factor. So it's all not completely absent factor 9. There is some circulating factor 9 which is getting picked up in these assays, and that probably is causing tolerance. That is why you don't develop, when there is self-tolerance, then you have tolerance to exogenous factor also. And this might be one reason. And another reason, like I said earlier, was that you have mutations which have large deletions, inversions, etc. are absent in factor hemophilia B. And because of that, you have a smaller protein, and maybe that smaller protein has lesser antigenic epitopes. And these two reasons combined have lesser inhibitors. So what is the verdict on A versus B? There is still no data, conclusive information on this. Since all of those papers which came out in 13 to 19, that period, was all on retrospective registry data. Prospective studies need to be seen to prospectively follow severe hemophilia A and hemophilia B, and then tell us how did these patients do. As of now, we are going to be treating them similarly, and we probably can consider a clinical escalation protocol, as in we started probably once a week prophylaxis, and we'll see how it goes. If you think that is enough to prevent a breakthrough bleed, you can probably stop it. Like you don't have to traditionally start on the same dose, which is twice a week as per WHO always. You could always escalate from a low dose upwards. This is what the current thinking is. So now we come to the management aspect of hemophilia. So for all of us, managing hemophilia has gone from saving life to saving disability. And now currently in all the discussions earlier also, we are all discussing quality of life heavily. So saving life would be possible only if we have awareness about it. So this children should be diagnosed early. Saving disability, once you diagnose, we should treat them properly, and we should probably not just treat bleeds, we should prevent bleeds in the first place, and that is possible only by replacement therapy. And finally, when we start giving replacement therapy also, you should start focusing on a good focus, a good quality of life. And if you are able to ensure these things, the lifespan of a PWS should be similar to that of a person who does not have hemophilia. So in our current challenges, I think this again was a little bit of it was discussed. We have a lot of awareness, and that's probably why we are doing this meeting today as well. And our access to care has also improved immensely. But still we have issues on late diagnosis. Most of our patients are being treated only on episodic treatment. The prophylaxis is available only for a small category of patients, especially who are getting reimbursement from their parents' employer or maybe their own employer, or maybe some carers get prophylaxis. Otherwise, most of it is episodic treatment. And when you are on an episodic treatment, your physiotherapy becomes suboptimal. Even if you don't want to do it, even if you have a very active physical rehabilitation department like here, but still it will be difficult for most patients because they are not motivated to do it, and they have breakthrough bleeds when happening when you are on an episodic treatment, and that results in joint damage, disability, and finally that is going to affect your quality as well as quality of life. So when you start treating hemophilia, we have gone again, I'm repeating what was discussed earlier by Dr. Gurika. So from whole blood, we have moved on to plasma, and from plasma, we moved on to episodic, standard half-life, plasma derived factor. So this is available even now. In most states, this is the product that is available, and this is the mode of administration that is available, that is episodic treatment. How can you improve on that? We can, if you have access to recombinant factor IX, that would be better for all the reasons we know about plasmid versus recombinant. If you have prophylaxis or replacement therapy on a standard half-life, that will be again way better than giving episodic treatment. And from there, if you go to prophylaxis with an extended half-life, that will be even better. And then after that, what is left is probably there are non-factor replacements like in A. There are many products which are there in B also. And once we have access, probably need to see how whether it is significantly better as in E or not. And then finally, curative treatment. There is already a lot of work which is going on. Permanent cure for hemophilia, especially hemophilia B. So when you give prophylaxis, the advantage of prophylaxis is reduced bleed frequency, preventing arthropathy, and better quality of life. But when you give them prophylaxis with a standard half-life product, like I said, adherence is a big issue. If you are calling the person to the hospital or even asking them to get an injection 2 times in a week, that becomes really difficult in the long term, especially for babies. Parents have to be taught, and a lot of issues can come up. Venous access and availability of home therapy. Like most states are not providing home therapy. So to bring them to a hospital for every infusion, even if you are giving it as prophylaxis, becomes difficult. And the second issue, so this is logistic issues. The scientific issue is behind this is when you are giving standard half-life product, you are supposed to give it at least 2 times in a week. So when you give it 2 times in a week, the logic is that in between that the factor level, the trough level is going to dip. So when the level dips, when you're giving good physiotherapy or when the patient is active or the child is very active, there can be bleeds. And that is why we never end up seeing that kind of reversal of target joints while you are on a standard half-life product. You may prevent further bleeds, definitely, but you may not achieve a zero bleed rate when you are on a standard half-life prophylaxis. And reversal of target joints becomes extremely difficult when you are on a standard half-life product. So considering all this, probably in 2020, the World Federation data also said that the EHL prophylaxis would be beneficial for 2 reasons. One is that the main focus was that you're going to get a higher trough level, so that gives you a consistent benefit or a constant benefit around the clock cover, which is there. And second, of course, that the number of injections reduced significantly. Madam already showed the ways of increasing the half-life. These are 3 ways. When it comes to factor IX, when you have an execution protein, the half-life increases, the product becomes around 80 hours. When you have an albumin product, that is again similar. And the third product, which is currently now available in our country, is glycopegylated factor IX, and that has a half-life of around 100 hours. So of this factor's execution protein is available in our country through the World Federation Humanitarian Aid Program, and glycopegylated factor IX is currently being marketed in our country. Another important aspect when you consider pegylation is that we talked about extravascular factor IX. So this extravascular factor 9, again in the context of extended half-life products also, even some of these products have been shown to have better efficacy because their extravascular penetration, or the fact that the percentage of the factor which goes into the extravascular space is also improved. So that also determines the efficacy. So it's not just factor 9 level we are chasing. So after you give an injection, if your factor 9 says 10% or 20%, so that per se does not directly correlate with the bleed efficacy. Maybe the bleed efficacy is much better than the number that you are seeing. It may be related to the extravascular factor 9 which we are not able to quantify. So when we switch up to an AHL product, we need to demonstrate efficacy in treatment, convenience, as well as cost effectiveness. And this is again a slide which I keep using, that whenever we cost in hemophilia, it is always direct cost as well as indirect cost. And direct cost, we end up only calculating the clotting factor concentrate cost. But even in direct cost, there are so many other things which we could calculate. And indirect cost, of course, things which cannot be quantified as a number, like the pain and the suffering which is undergone by the family, is again out there. So these all things, but wherever quantifiable, should be put in place when we think of making a significant change. So at our center, we have small experience with patients with EHL, which I'll share. I shared 2 cases where there was a little good experience, which we never expected in the first place. So this is a 16-year-old boy. He was on episodic factor 9 treatment, and he had an ABR around 6 to 8, active child. He was going to school, and 2019 December, he had a right psoas bleeding. And this right psoas bleeding, and he came in with, again, after a day or two, he came with bleed and pain and paresthesia, as well as difficulty in walking. And at that time, he was started on factor 9 replacement. And it's not like we do have continuous supply, but the numbers, the factor which is available is very restricted. So we started on factor 9 at 30% replacement, and his inhibitor screen for all severe bleeds we do inhibitor screening, and even psoas we have been doing inhibitor screening. So this was negative at that point, and he was advised that the usual psoas bleed management was started, and after a few days he was able to walk. This was in December. In March 2020, like we all know, COVID happened at that time. So at the same time, he had a bleed. So when he had the bleed, he was unable to again move the right same side. Bleed happened at that time. He was again started on treatment and continued on. He was advised to continue on a prophylaxis regimen at that time. But then at that time, regular follow-up to the hospital was not possible. So he was just given 1 or 2 doses of active at that time, and he did not come after that. At that time, we even advised a teleconsult for physiotherapy so that some movement, something can be managed at that time. So this was later couple of months later. This is how we had. So this is a bleed. I think you can see multiple, as in there is a new bleed as well as an old bleed which is there. And this iliacus bleed led down to finally femoral neuropathy with quadriceps wasting. So there was, by the time we saw him again after 1 or 2 months, he was really bad shape. He was wheelchair bound with neuropathy, quadriceps wasting, and now conduction injury also showed significant damage. So at this time, again, standard half-life was the only product which was available at that time. He was started on a prophylaxis. Again, not ideal doses, I agree, because we do not have that kind of factor available. But in this period also, he used to have multiple bleeds. And subsequently, he was shifted when we had access to the World Federation product. He was shifted to 40 IU per kg per week, and then it was continued subsequently. So from March to August, he was completely wheelchair bound. And so this is November. Here again, he's just been started on the EHL prophylaxis. So it's very difficult to walk. He has to walk slowly, and pain also associated with it. And subsequently, while on the product, while on prophylaxis and good physiotherapy. So thanks to Dr. Pamela Narayan, she took him up all over teleconsultations for physiotherapy, and that is how he managed. And now he's able to walk alone, he's able to travel alone. He can actually move to a different city for his further study. So in a scenario like this, where you know aggressive physiotherapy is required to reverse whatever damage is there, in such a scenario, even after establishing neurological deficits, we still may be able to regain the muscle power and get the muscle back into position if we have a good physiotherapy in place. And for that physiotherapy, if it will have an extended half-life product, that will be extremely helpful. Another case, again similar scenario, but target joints in the elbow, which were really troubling. Two children who used to come. So this is again being shown just to show the number of doses. So whenever we discuss EHL, it's not just IU per kilo costing. It is always the total number of units which have to be given in a month. So when you are on a standard half-life product, when the patient is on demand, so this line on the left side is on demand treatment. So this is the number of times the patient would have come to us, and this is the number of IU which is received. Into IU, which is total international, 6,000 IU has been given in April 21, and 5 visits to the hospital. Whereas if you put them on EHS prophylaxis, so we now give once in 2 weeks only. So once you reduce the schedule also, the number of IU, we probably give around 20 IU per kilo. The number of total dose which is received has also come down. The number of hospitals visits have also come down. And of course, there has been 0 weeks during this period, and target joint reversal also can be established. So it's kind of helpful from all these aspects as well. So during the first period that we used between September 2020 to August 21, we had around 7 patients in this group, and all of these patients we found that once you shift to the product, their ADS actually decreased significantly, and their joints also improved. Target joint reversal was also seen. And so again, right now, we had another period where we had access to this drug. Again, in this period, most of these patients were started as joint tertiary prophylaxis. 2 children had exams with bad joints, so that was a reason to start them up. And 1 child in the post-operative period. So he underwent surgery for an equinovirus deformity while on receiving SHOs, but immediately after that we got access to the drug. So then subsequently for the next 3 months, rehabilitation was done twice a week, a prophylaxis with glycopegilators after 9. So it helps in a big way. So from here, it's like a straight jump in here, and that helps not only establish patients with a bad joints, it just helps them reversing as well. And in new cases, if we have access for that to prevent bleeds also, that would be really good. So currently we are using it only for tertiary prophylaxis, so to say, or surgical treatment. But if we have access for other children also, especially, it's not like we are bad, but then there is a significant proportion of patients who have real bad joints, and for them it will be really helpful. So I'll stop here. I'll be happy to take it.
Beautiful presentation by Dr. Lita, and the rightful emphasis on generating awareness, early diagnosis, and more so that joint intact babies are needed. And for that, to increase compliance, I think EHL is the right call. Any questions, queries, and any additions by the audiences? Welcome. I think no questions, a very elaborate presentation.
Thank you so much, ma'am. I request our chairperson to please felicitate ma'am. Huge round of applause. I request Dr. Tulika ma'am to please felicitate our chairperson, Dr. Sanjeev Vidya. A huge round of applause, please.
Wait a minute, wait a minute, wait a minute.
Thank you to the chairpersons and the speakers. We'll take up with the other session, next session, prenatal diagnosis and gene therapy in hemophilia. I invite on stage the chairperson for the session, Dr. Seema Gurubharti ma'am. She is professor and head Department of Gynecology, Guru Gobind Singh Medical College and Hospital, Harirpur. Next, I invite our second chairperson, Dr. Amanpreet Sethi. He is assistant professor neonatology, Department of Pediatrics, Guru Gobind Singh Medical College and Hospital, Harirpur. Welcome, sir. Welcome, ma'am. I request our chairperson to please introduce our speaker of the day, Dr. Reena Das, Professor and Head Department of Hematology, Post-Graduation Institute of Medical Education and Research, Chandigarh.
We welcome Professor Dr. Reena Das. She's Professor and Head Department of Hematology, PGI Chandigarh. And her special fields of interest are thalassemia and hemoglobinopathies, molecular genetics of non-malignant conditions, prenatal diagnosis, and blunt research she is doing on undiagnosed practice cases of undiagnosed anemia. And we welcome them.
Thank you. It's a pleasure to be here. I'll try to make it a little short so that I don't come between you and lunch. And I'm sure there's a very sumptuous lunch which is awaiting us. So my job is to talk about prenatal diagnosis and gene therapy in hemophilia. So my disclaimer at the beginning is that we do a lot of prenatal diagnosis, but I don't have much idea about gene therapy, so you need to explain that. So prenatal diagnosis in hemophilia is basically, the problem is that we can't have prevention programs, at least as a screening. So basically we need a family where there is an index case where we can offer prenatal diagnosis and carrier screening to the family members, the females in the family. So initial diagnosis is extremely important, and I think we talk about diagnosis where we have patients who are just on plasma therapy. That is something which is not desirable. We need to know the specific types, whether it is hemophilia A or B, and also we know that few patients with type 2 N disease can overlap clinically as hemophilia A. So basically, integral part of antenatal care for pregnant carriers of hemophilia needs to be advice to these families. When we start with prenatal diagnosis, the first thing is we aim to diagnose the fetal sex. So we know that fetal sexing is not kind of legal in our country, but in disorders which are explained like the hemophilias, this is the first thing which needs to be done in the molecular lab. So in case the fetus is a male fetus, then we need to assess its hemophilia status. And the purposes of doing prenatal diagnosis in hemophilia are to provide an option for termination of pregnancy. Therefore, genetic counseling is extremely important because of the maternal inheritance. So we do a lot of genetic counseling for thalassemias where both the father and the mother are carriers. But here, because the woman is the carrier, we have to do the genetic counseling more sensitively. The attitudes are different in different communities, but fortunately in India, because of the problems which are there with patients, the uptake for prenatal diagnosis is quite good. It needs to be optimized because obstetric care is also required. So the gynecologists need to know about the status also of the lady as well as the baby which is in question. So what do we do in the genetic analysis? We need to know the mutation detection of the affected male. So the first thing is to know the molecular diagnosis before we can offer this to the family. The screening for the mutation in suspected carriers is important because sometimes we know that the mutation can be a sporadic mutation. So if the mother is not a carrier, we just need to tell the family that there is no need to do prenatal diagnosis. So this is extremely important. And then we know that the prenatal diagnosis, when we are doing in the female carriers, we know if the father is a hemophiliac, all the daughters are going to be obligate carriers. So in that situation, first when we are doing male-female, already 50% out, Then of the males, there's a 50% chance that the baby might be affected with hemophilia, and therefore there's a 25% chance in every pregnancy that the fetus may actually be affected. Nowadays, we try to avoid doing linkage analysis, but earlier on, when we don't know the mutations, in such situations, we can resort to linkage analysis. So this I have already told. So factor VIII gene is a very complicated gene. It is extremely large. It's 186 kilobases with 26 exons, and the length of the exon 14 itself is very high. And I'll show you that most of the mutations which are missense are there in exon 14. Even if we talk about the mRNA, it's a pretty big mRNA, and the major mutations, like was alluded to in the previous talk, is about the inversion 1. So what actually happens in inversion 1? So this is just a diagrammatic representation to show that when you look at the intron 22. So if you look at the intron 22, I don't think it's showing, but anyway, there's a region which is 9.5 kilobases. There is an identical region which is extra gene, and it is in the telomere end. And you can see that the red I have shown you there is also there as two different reds at the telomeric end. So what exactly happens is, because the X chromosome is a very long chromosome and the Y chromosome is a very short chromosome, when the telomeric ends come together, there is a chance that this X chromosome can actually skip onto, flip by itself. And if that happens, there is a chance that there can be a homologous recombination between either of the two red bars that you are seeing there at the telomeric end. So what happens is that, when it completely goes there, then the final result is a very severe type of hemophilia because there is a cut there. So you have the complete flip over. So, there is something, the product which is coming out in inversion 22 is a product which cannot be comprehended, and a definitive protein cannot be, there in the particular patient. So in the molecular lab, what we do is, this is a very good strategy for doing the molecular analysis. And this methodology, actually, I picked it up from UK during one of my visits. And now the entire India, wherever they're doing the inversion 22, they are using this particular methodology, which is known as inverse shifting PCR. This was a very difficult PCR to standardize initially. And what is done is that you make small fragments or rings, basically. So what is exactly being done is that you have these primers which are placed in such a way that finally, if there is a patient with inversion 22, this is how it looks. That there is a normal kind of rings which are made after you do the restriction enzyme digestion, and depending on the sizes of the bands that we are finally getting, we are able to tell whether the person is a hemizygous male, which is showing as a single band affected in the center, whether the person is normal or whether the woman or the mother is a carrier. So it's a fairly easy kind of a PCR method, but this takes about 1.5 days to do the analysis. The similar kind of thing can also happen with intron 1 inversion because of the similar homologous recombinations which can happen. And for the molecular diagnosis, again, we have to do multiple kinds of PCRs. What I'm trying to show you is that when we are doing molecular diagnosis of hemophilia, we need to do the diagnosis in a stepwise manner, and also it is a very costly affair to do the final molecular analysis of hemophilia, which is not the case as far as thalassemia is concerned. This is kind of a complicated methodology. In cases we really don't know the mutations, this is another method which is done, which is known as the conformation sensitive gel electrophoresis. Here, all those 26 exons which are there, they have to be individually kind of amplified. The larger exons have to be broken up by smaller amplification products, and then they have to be run on a special gel where we try to look for small variations which we can pick up in the lab and say that probably this particular exon has the mutation. So what we are trying to do is kind of having a diagnostic algorithm to come to more kind of cost-effective manner for diagnosis. Factor VIII gene is a much smaller gene and it has only 8 exons. So most of the people, what they do is not go through all the complicated methodologies of CSG and straightaway just do the Sanger sequencing, which is now much more amenable. So these are just trying to show you that when we are doing Sanger sequencing, what are we looking at? We have a normal read, which are these codons. This one codon is going to give rise to one amino acid, And if something goes wrong, if you have a single nucleotide change, you could get a missense. If you have a stop codon which comes on, then you call it a nonsense mutation because the protein becomes a smaller protein and it gets degraded. The other type of mutations which can happen is because of either nucleotides which are not in combinations of A, and they get either deleted or they get inserted. So finally what happens that you get a frame shift mutation, and this also gives rise to a protein which is completely non-readable or a protein which is not important, or it cannot be giving you the normal kind of amino acid sequence. You could also get various types of deletions. The sizes of the deletions can be a small deletion or it would be large deletion. So for molecular testing for hemophilia A, we have analyzed about 400 patients from our cohort, and we did the inversion 22. We found that to be negative, did intron 1 inversion, then looked for large deletions, then we did conformation sensitive gel electrophoresis, and finally we did targeted next generation sequencing. Wherever we found these probable mutations, we confirmed it by Sanger sequencing. For hemophilia B, fairly straightforward, straight away do the PCR for all 8 exons, do the Sanger sequencing. And when we do for other disorders and complicated gene like even 1 milligram disease, which is again a very large gene and it has other complications which we not get into, then we have to do targeted NGS, which is going to be a better cost-effective method. So this is the spectrum of bleeding disorders inherent that we recruited in PGI. We have about 400 cases of hemophilia A and 425 members within these families. Factor 9 deficiency was about 90 cases, 102 family members. So you can see the major bleeding disorders are actually hemophilia A and 14% constituted hemophilia B. So this is the entire algorithm that I kind of showed you. In version 22, if we don't get that, we then straight away do intron 1. So in our results, we have got 36% cases to be intron in version 22. And intron 1, we just had 9 cases which were positive, which made it about 2.25%. When we talk about large deletions, much smaller numbers, 2.25%, similar to intron 1. And then we straight away did CSG in some patients and shifted on to targeted resequencing in 112 patients. So the entire cohort of 400 patients is still not analyzed. We have about 100 more patients to solve. So when we look at the overall findings of hemophilia A after Sanger validation, what I want you to just make out is how complicated is it. You have these mutations which are all through, and that's what makes the hemophilia molecular diagnosis so very difficult to take it to the end result. Because of this large size of the gene, you actually have to end up doing the sequencing in a very large way. And the hemophilia, the protein B, which is there, which is the joining part of the A1 and A2, with the A3 and the C1 and C2, that domain itself is like a very large exome which is there with multiple types of mutations. So we had so many different kinds of variants which are there. And also we had 3 patients which looked like suspected cases of hemophilia A or query for Willebrand disease. Of these 3 cases, when we did NGS, we found them not to be von Willebrand disease, but we found it to be hemophilia A. And this is what I wanted to highlight, that if you have not targeted the correct gene, you can end up making mistakes in prenatal diagnosis, especially when you are doing linkage analysis. So this is the hemophilia B families, 90 cases, 90 index cases, 102 cases within the families. There were some hotspots which are there in exon 2 and exon 8. And therefore, if you are doing the Sanger sequencing, it's a good idea first to target exon 2. So this is the mostly cohort from Punjab. Then for prenatal diagnosis, it's extremely important that the mutation detection should be done before you are doing the fetal sampling. The chorionic sampling is what is preferred for us at 10 to 12 weeks of gestation, but around 12 to 13 weeks. Nowadays, we are lucky because the Indian laws have taken up termination of 24 weeks of pregnancy. We have to be very careful that there is no maternal contamination, and sometimes it can happen that you can have failure of DNA amplification. So this is how the chorionic biopsy looks like when the biopsy comes to us from the gynecologist. And in the lab, we need to clear up the entire maternal tissue which will be there, and just we end up with a very little amount of volume. Even a 1 millimeter tissue size is enough to make a prenatal diagnosis. So the first thing that we do is try to do the sex determination. And here you can see we have a control male with 2 bands. So basically the 2 emergent gene bands, PCRs, are coming, one from the X chromosome, the other from the Y chromosome. So therefore, the females will have only 1 band compared to the males who will have 2 different sizes bands. So first we come to know that if it is a female, then we PDC. There is no real rush. When it is a male, then immediately we have to get activated and try to find if the mutation is there. So in this case, the fetus seems to be a male, and therefore you have to find out the mutation. So then this is just an example that I've taken up. This is how the standard sequencing looks at. We look at the basis of APGC, etc. And then this is the patient affected male, showing you a green kind of a peak over there, which I have highlighted. When you look at the mother's mutation, you can see that the mother is a carrier because she has the normal complement as well as the mutant. And when we look at the fetus, we find that the fetus is a normal fetus. So we feel happy from the lab to give a report where the fetus is normal, and here it is a normal fetus. Now, when we are reporting prenatal reports, we have to report with utmost caution, because there is no way in the report we should be able to say that the fetus is a male fetus or a female fetus. And you will find that when patients' parents come for taking the reports, they try to keep on boarding the lab people that will tell, you know, kuch to bata sakte hain and all that. So because they are very sure that the fetal sexing has been done, and one has to be very, very careful when you're giving reports of prenatal. So basically the carrier female reports, the normal female reports, and the normal male reports, all of them read the same. So we just say that information on the carrier status, if any, will be made available to the parents only after the birth as per legal requirement, so that there is no way that they can make out that the fetus is a normal male or a normal female. So this is just giving you the summary of how it is done, and it is a bit complicated. So straight away, I will just move on to just talking very briefly about nowadays. You have a separate method of doing prenatal diagnosis by fetal DNA in maternal circulation. We have kind of standardized, we are in the process of, you can say, standardizing for thalassemias, but we haven't done it for hemophilia. It is available in the world literature. You need specific tubes in which the fetal DNA will be not like they will be, they won't be gray. And then you have again need special kind of equipment. This can only be done by next generation sequencing with a very high depth. And this is kind of the workflow where you can actually do the fetal DNA even by digital droplet PCR, or straight away go for next generation sequencing. So in the cases of hemophilia, what exactly are we doing? Basically, we have the cell-free DNA testing, which is done after 10 weeks of gestation. Approximately 11 to 13% of cell-free DNA is there in the maternal blood, and 2 hours after delivery, this DNA is not available anymore. So we do something which is known as digital related mutation dosage. What are we doing? The mother is heterozygous, she has the mutation as well as the normal allele. And when we are doing the fetal genotyping, there is a little dosage kind of thing which we do. If everything looks normal, then the fetus is likely to be normal. If there is equal amount of mutant and the bile, we think that the baby is kind of carrier. If more of a mutant is there compared to the normal, then it is a mutation which is there in that particular case. So you can understand that it is going to be a bit more challenging than trying to do a direct detection. So in hemophilia, there have been some reports from as way back as 2011 for trying to do this kind of thing. What exactly is being done is trying to find some location of the gene for the Y chromosome. So again, first step is to know whether the fetus is a male or a female. And here you can see over here that this is a male fetus, because some bit of the Y has also come. And after you've done this, then you have to do the related mutation dosage for the mutant site. So it is relatively a little more complicated. What about gene therapy in hemophilia? The idea is to replace the dysfunctional gene with an exogenous functional gene. And hemophilia A and B are very, very well suited because they are monogenic disorders. We also have animal models. So the small animal model is the mice, and the large animal model are the dogs actually, on which all the hemophilia experiments are done. And the major advantage for trying to do gene therapy is that you don't have to get it to 100%, the protein. You just need to get from 1%, maybe if you can get it to 10%, 15%, at least the patient is not going to have a very serious disease. So there is this major advantage which is there compared to other diseases gene therapy. So when you're doing gene therapy, you can do an in vivo gene editing. That means you have made whatever packaging you are trying to make, and you can put it in the patient. That is one way of doing it. The actually the non-integrating virus, which is the adenovirus associated virus, which is AAV. This particular gene, virus is supposed to be major advantages. It does not have any problems in the patient, in the sense it does not cause issues to any patient. Always that fear is there that something will happen to the patient if you do gene therapy. The other thing which is done is you make a package and put it in the patient. So it's an in vivo administration that you can do. Occasionally, you can have pre-existing immunity which can be there. And if there is a pre-existing immune complexes already there in the patient, then you cannot do this therapy. So before doing this non-integrating virus vector kind of gene therapy, you first have to see that the patient should not have antibodies. Otherwise, everything will just get dissolved in a tissue. So nowadays the other very efficient method that is coming up, which is known as CRISPR-Cas method, where gene editing can be done. It seems to be highly effective, sustainable, and does not have too many off-target problems. And it has been seen to be sustainable, but still the studies are ongoing. We really don't have kind of good data. So basically, the adenovirus is what you need to remember is there as the virus vector there. Now, what people have done is over time, there have been various modifications of this virus which has been done. It is an all-enveloped virus, but now, genetically, by recombinant technology, they are making a capsid around it. Then sometimes they're adding on a particular mutation which is there, which can stabilize the factor 9 gene, and I'll show you a couple of examples of this. So basically what we are doing is we are doing a gene transfer so that ultimately we are increasing the gene expression, and this is all basically done as a gene is getting incorporated into the nuclear material. So for gene therapy in hemophilia, the key points are you need the levels between 2 to 11%. It can be, you can discontinue the prophylaxis, which was done in about 4 out of 6 participants in one of the studies. The interval between the prophylaxis was also, increased. So there are certain advantages that can be done. The major disadvantage which is there is transaminitis, which can happen in some patients, and then you can also have discrepancy in the factor activity. And these are again some issues that I told you, hepatotoxicity, pre-existing antibodies will be there. And you can see that between patients also there can be variation. So you cannot predict every time that this is the value which is going to be there, which is very nicely shown in this particular graph. These are some of the recent hemophilia gene therapy trials which are going on. Some of them have already been closed, and they have found a fairly good effect among the patients. Factor 8, you can see much smaller numbers, but still people are going on and trying to make different kinds of modifications to the virus that we are putting in. Cost, of course, we really don't know the situation in India. It's a very expensive therapy. Dr. Alok Srivastava from CMC Vellore has been working on this for a very long time, and currently one patient has been given gene therapy, and the results are still awaited. We don't know the exact results which are there, which will come to know in a while. So there are certain regulatory perspectives we have to keep in mind, because when you're doing genome editing, there can be some off-target things, and also ethical guidelines have to be formulated for the country itself. And what I would like to end by saying, prevention is extremely close to my heart for hemophilias, because when you see the patients, you see that they are in so much pain. I always tell Dr. Jasmina that, the thalassemia patients, they just get a transfusion and they're fine. But for hemophilias, it's a very, very painful disease. And whatever we can do for prevention, I think needs to be done. Genetic counseling, carrier screening, clinical diagnosis, and it needs a very close collaboration between the clinicians, the lab, and the obstetricians for all 4 members of the team. Thank you so much.
Thank you, ma'am, for a very comprehensive coverage of a very difficult topic. Ma'am, as an obstetrician, I was wondering about prenatal diagnosis. You said that the carrier status is not revealed to the parents. Ma'am, but is it revealed to the obstetrician or not? Because whatever I know that invasive monitoring during labor has to be avoided, possibility has to be avoided. So the report is disclosed to the obstetrician.
Yeah. Whenever they ask for it, we definitely tell them, because we understand that they need to know the results. But for the family is the problem in case when we're giving the food. Obstetricians, of course, they're part of the team.
Because they have to take some preventive measures. And that it's not available as in India.
Yeah, in India, what we are doing it, we are trying to establish it for thalassemias, which is a little easier than to do it for hemophilias. But I think there are some centers who are working on it. But I haven't heard that it is available in India as well.
Thank you. Thank you so much.
Any questions from the audience? One question from me as an neonatologist. So I encountered a case once, one of my senior. She underwent delivery, and after delivery, she suddenly remembered that her father is suffering from hemophilia.
Okay.
And at the neonatal bedside, we were actually in a stunned state. It was not known to us. So in that case, this cord blood can be.
Yes, yes. You can do cord blood and see but then the lab people have to tell you that what is the normal level and whether the amount of factor VIII is like. I really don't know how much it is. I think just after delivery, probably factor VIII levels are on the higher side. So they'll be able to help you out with that. Otherwise, also people have done prenatal by cord blood factor VIII levels also. So there the obstetricians have to help us to get the cord blood to the factor VIII levels via the regular assay. So that can also be attempted.
And if in prenatal diagnosis, we diagnose hemophilia and we reveal it to the parents. And as now the newer therapies are emerging, so what advice we should give that whether they should continue pregnancy or?
You've asked a very, very difficult question, because this is something which is prenatal diagnosis is not done in the West, at least not in US and all. They feel very disturbed when they hear about prenatal diagnosis because of so many therapies which are there. They feel they can manage. But as clinicians, I think we have to take a call on whether we are able to give the best therapy to all the patients. I don't think we are yet at that level. The good thing is that when we are doing prenatal diagnosis and all, at the moment we are not charging the patients anything. It is a free thing, and this is all going to be dependent on the genetic counseling. Depends on the experience that the family has, whether they can afford to have a child with. It's not just giving the therapy. I think there are a lot of emotional angles which are attached to seeing patients, I think. But it's a very important, pertinent question you asked. Thank you.
Any questions from the audience?
Okay.
Carrier. The carrier females, they also have a lesser level of factor. So for delivery, there are a certain set of guidelines there. So in your experience, did you encounter any procedural hemorrhages or complications during the antenatal diagnosis? And
I don't know, because I think the obstetricians will be able to tell. I haven't been at least given a feedback about it, and there has been a problem. But
That's why they are saying that we should avoid invasive procedures like stamp electrode. It is avoided in biomarker positives because we don't want that transmission to same way. And for such there can be abrasions, there can be lacerations. Then we would decide whether patient is actually, it is better to take a no C-section rather than having a difficult process to be that is, I think
There are reporting of subgenital bleeds also after some instrumentation in severe hemophilia, and it was not known before. And when the child has severe subgenital bleed, it is a type of subgenital bleed. So we thought of that it can be hemophilia. So that
actually, when we are doing the counseling, it's very important that we have to counsel them in such a way to tell that if it is a hemophilia affected, then you have to go ahead and get the termination. If the termination is not the intent to start with, then we should not do the testing. So for all invasive procedures, yes.
So decide about termination, not.
If they don't want a termination, they can manage a child, then the family has to take the call on it. That don't do, there is no point in doing all this lab tests and then deciding that we want to continue with the pregnancy if the fetus is affected. Dr. Jackson.
So just offhand comment for Arvind, I would say, we are looking after the lab side and request for factor VIII. I don't recall.
Jackson, will you closer because you are not being.
It's for Arvind regarding the factor VIII and the antenatal female, whether they have to be given and the time of PND. We have yet never received a request for factor VIII in the antenatal female when a PND is being attended. So I don't think this is really going to be a major issue that female may be. Right? It may, at the time of delivery is another story, but by then the factor VIII levels can be normally also. So maybe that is sort of a natural protection thing. But I don't even recall one case where an antenatal female at the time of PND has been asked and sample has been sent for factor VIII. That's
In our experience, majority of the inversion 22 and even the patients where the mutation is there, we have found the mother to be a carrier. Very few cases we have got where it is a sporadic mutation, which is not the experience of the West. You must be really hungry now.
Thank you. That was a very good session. Now I would request our chairpersons to please felicitate Dr. Meena Dasman. I would request Dr. Anjana Ma'am to please felicitate Dr. Seema Ma'am. Thank you so much, ma'am. I would request Dr. Man Singh to please felicitate Dr. Amarpreet sir. Thank you, sir. Now, everyone, we'll all head to lunch because I know everybody is very hungry right now. We'll be joining back in 20 minutes.
पीछे बुलाना चाहिए
मैं नहीं खाना उन्होंने आज नहीं फिर टाइम पे मैं फिर तब उठा लाऊंगा बैटरी नहीं चार्ज हो पा रही है पैन बैटरी क्यों नहीं हो रही चार्जर फुटू हाँ तो चेंज करा चार्जर हाँ ਜਿਹੜੀ ਇਹ ਵੀ ਨਹੀਂ ਚੱਲ ਰਹੀ ਲੱਗਦੇ ਨਹੀਂ ਪੈਨ ਚਾਰਜਰ ਚੇਂਜ ਕਰ ਲਓ ਇਹ ਤਾਂ ਦੂਸਰਾ ਬੀਟ ਹੈ ਇਹ ਚੇਂਜ ਕਰਦੇ ਇਹ ਕਿਹਦਾ ਫਿਰ ਇਹ ਮੇਰਾ ਹੀ ਹੈ ਨਹੀਂ ਇਹ ਕਿੱਥੇ ਲਾਇਆ ਹੋਇਆ ਸੀ ਤੇ ਇਹ ਕਿੱਥੇ ਲਗਾਇਆ ਹੋਇਆ
What is the format? We have the army. Just people who are together, that is together. No. हाँ जी तेल दो चकली बोलो जी नहीं बस लगते 15 मिनट लगते हैं मैडम आपने जितना साउंड सिस्टम लग गया है किसके पास है? हेलो 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 हेलो
यही चाहिए
What is cure? So that may be a first explanation of health economics and outcome research. That is what we're talking about. Health economics basically focuses on measuring and valuing the outcome of healthcare interventions, which means in hemophilia, if you were to value an outcome, it will be ABR's reduction. That is annualized bleed rates are reduced, quality of So definitely go up in the next 10 years. Okay, so for that matter, have you had any cases of before they operated the patient and he had hemophilia?
None in my experience so far, but yes, it is well reported that surgeons may operate on some, like probably some thought to be some other diagnosis, but then eventually turned out to be hemophilia. It could be septic arthritis, looks like septic arthritis in case of hemophilia or tubercular arthritis, so which they have attempted to drain or tap and then eventually turned out to be hemophilia. So none so far in my personal.
Any inadvertent surgery, because that is a reflection of the laboratory support and the awareness aspect which we have, and both are related to how much budget we use up when we do an inadvertent surgery. Any in your knowledge of
In our institution, none such case was reported. But may have been unnoticed and gone to other institutes like yours, like in PGI.
So we don't have surgical experiences.
Okay, so sometimes we had sometimes the system is not working. So just go ahead. I mean, is there a possibility of getting the slides on this? So while the discussion is going on, just to give you some information again,
उसको बंद कर दो.
That union budget has 60,000 crores set aside for health care. Of them, 500 crores are set aside for hemophilia care as of now, which is a great thing. I'm not too sure about the actual figure which is set aside for Punjab. What I hear is about 12 crores. Now, the whole budgetary impact analysis that we have to do, what we need to understand is that how do we use this 12 crores to the best of its potential for both the use for factor purchases and for data collection and for services. So that's the balancing which we need to do. And often we end up actually giving the orders for factors on a 10% increase or a 20% increase. And that is where we need to fine tune and say, how do we ensure that we will get factors?
वो एक्सटेंड स्क्रीन पे चला गया ना.
So this is basically from some of the data for patients who have been referred to us after the surgery and found out to be bleeding more. And when we found out that some of them were a moderate hemophilia, osteoblast sarcoma, and there was a 10 days delay before the diagnosis was made. A crush injury, osteoarthritis, as you said, septic arthritis. In fact, we have another patient after we published who had a TKR. And then after the TKR, we found that the patient has hemophilia or the bleeding is not stopping, and they had done only CBC and PT at the baseline. And there's a young person who's got a 30-year-old man, a watchman with joint pain, hemophilia. And that is where this, important to have a hindsight and think through the entire process. Okay. My question to Dr. Girish. How do you choose a particular factor for a particular therapy? What are the parameters you would want in your mind before you choose a particular product, whether it is standard half-life or extended half-life or non-half-life?
Sir, regarding though ideally we would have our other choices, but sometimes there are some constraints regarding our availability of factors, and as far as our choice for like prophylaxis is concerned, we would also like to have a extended half-life.
Not that. When you choose a particular product, maybe that is another question.
The product should be safe.
One is
safe.
Number one.
Safety.
Okay.
And second is effective. It should be effective. Safety means it should not have any adverse event. severe adverse event or thromboembolic like hemophilia factors. So it should not have severe side effects, and thrombotic microangiopathy, etc. And the transfusion transmitted infection should not be there in that. And it should be able to decrease the number of bleeds, control the bleeding and prevent the bleeding. And secondly, product should be effective, and it should be available locally, and it should have access to the every patient.
So that is exactly the point. So whenever we as physicians have to choose between the factors, when the MRs come, the company people approach us, the questions we need to ask is, what is the publication? What is the efficacy? What is the safety? I want to see the evidence, and then evaluate it yourself before you actually recommend these medicines. It's a very important aspect. And of course, comes a cost as a major factor. After you have gone through the safety and efficacy and availability, of course, the cost. Dr. Prashant, how would you, if you were to choose the factors in your center, what parameters would you want the costs to be? How do you choose the costs among the, what procedure you follow?
So as a physician at the receiving end, mostly it is the availability of the factor that is the major constraint. What is available from the government, and what we are getting, that is what we have to use. So, but if one has to choose, so obviously the one factor which is effective as well as which costs less to the patient, that will be chosen.
So generally what I understand is that as physician, you don't have much control over the cost and choice there. So it's the same in your center.
Yeah.
You have not.
So we don't have any say in purchasing.
So obviously this is at one step behind on what they choose and what's the L1 and the L2 So to Dr. Narendra first, what's the proportion of A and B at your center?
In our center, it is 80-20. 80% hemophilia A.
1:4 approximately. What about you, sir?
Same.
Okay, you're just starting off in but in your experience, what do you think is the ratio there usually?
The center is a relatively new one, only we have started just 1 month back. So as of now, I have 30 odd patients of hemophilia, out of which around 25-26 are hemophilia and around 4 to 5 are
So it's about 1:5 ratio is mentioned, but in most of the Indian data, it is about 1:6 to 1:7. So that's something, because we need to keep this in mind before your budgetary allocation for A or B factors to be brought in, and the percentage of inhibitors. So 3 major parameters we need to understand is that what's the distribution of A, B, and inhibitors, so that we can do budgetary allocation proportionate to the percentage of the patients and the cost of the product. So that's the demographic profile of in hemophilia was published in 2018. This is patients of hemophilia who had come to CMC till then over a period of 5 to 10 years, which were published. So if you look at this, one insight we must understand is that what is the distribution of patients at that particular point in time in various districts of Punjab. That's the 22 districts of Punjab. And if you see, it was leaning towards mostly Ludhiana and Patiala at that time, because of, and Jalandhar, because Amritsar had facility for doing the factors. So Jalandhar used to come to CMC Ludhiana and then that was done and go. But now things are much different. So when we do a study now, if we have to do, it will be very interesting to see how this has changed over the years. And that's a very important feature we would understand how to predict for the future as well. So this is an important, interesting picture which I have. This is the number of patients in blue, and the green, the red is basically the expected number of patients. If all the patients potentially were diagnosed based on the population of the place, this would be the distribution of the patients across the districts. Okay, so Dr. Girish, what is the estimated factor utilization at your center per annum? Do you have any number to that?
We don't have any number for that.
Total number of patients?
We have 16 patients. So, it is some factor we are getting from the society and some from the government sector on demand.
Okay.
That's
Units, I've got data.
Total number of patients at your center?
Number of patients 167.
167, 80% are A and rest are B. Okay. So about 1/3, 120, maybe about A, 120, 130 A and the rest are B. Okay. Factors?
Factor units, data 11,24,000 units we have given in a year.
Okay, 11 lakhs is your potential.
11,24,000. Factor A. And 3,85,000 units, factor 3.
Yeah.
In the last
So as a budgetary thinking or the future thinking, what you need to do is divide that by the total number of patients and say how many units per patient is utilized in my center. That would be the going forward. If we want to do a study, that is what I was talking to Dr. Varun, saying that we should do a collaborative study across the centers in Punjab to see at each district, each center, what is a unit per patient. Subsequently, do that per kg of factor utilization. So, so Dr. Narendra, since you have the numbers with you, what is a reasonable way of budget allocation for AV bypassing and NF therapies at your center? Suppose you got 1 lakh rupees or 1 crore rupees. How much would you keep aside for A, B, bypassing and NF?
Bypassing, we have 18 patients. So accordingly, proportionate amount will be kept for bypassing and 80-20 for A and B.
Yeah, so it is an important aspect for us to think through these numbers. Right now, we have to, aggregation of numbers are the key. We need to work with Dr. Bobby and get these numbers right, because then we can actually be very specific about it. That was basically, we have done this math earlier sometime. Not that, not this slide, the previous slide. Okay. On the thumb rule would be about 50 to 60% A, about 20 to 25% and about 15 to 20% of bypass. NF therapy has to come into the pool of A. And that would be the approximate distribution there. So this was a calculation based on the cost per unit. So this is something which you can look at and say, if the factor 8 is standard half-life is only 7 rupees, that is per kg would be about 14,000 per annum if you were to give prophylaxis. And this calculation across the districts, across the centers, if we can do, we can have a very a reasonable calculated estimate of what and how we must distribute. So this is in comparison. What a thumb rule, if you come to, as though if you do a low dose anesthesia, if you can prove the 3 mg, it will match in with the low dose standard half-life. Okay, so I'll just rush through the next 3 slides because only some 3 minutes left. I want some take homes after this. Hemophilia treatment is expensive and we need to justify the incurring cost, and we need to have a standardized hemophilia care. Right now, we can all go with the WFH guidelines. We don't have to reinvent the wheel. We need to follow the principles of hemophilia care in the Asia Pacific perspective applied to Punjab. So all these 22 districts and the medical colleges, if we can follow these principles of care, that it fetches a long way ahead. So our next step should be promoting and propagating these principles of care across. Data collection is more difficult than actually treating. So we must work on that on a more rapid way. What would be our steps forward in improving budgeting allocation? So we have a few ongoing studies in our institution, the socioeconomics cost or quality of life among the patients. We have started the data collection 30-40 over. Hopefully we'll get a small modeling which what can be done, and then we can extend it to the rest of the centers. We also have a mixed method study on the personal, social and economic domains for the quality of care. It's a more of a mixed method of qualitative and a quantitative study. But what I foresee is that joining hands with the medical colleges and the civil hospitals and PGI, I didn't put the name there because that is a union territory in itself, and the civil hospitals combine and have collaborative studies. That's the way forward we can do that. And we can have levels of care across the Punjab can be stratified. All the colleges can be collaboratively utilized. This is a stratification model which we had proposed earlier for primary, secondary, tertiary level of care in the clinical based on functionality and the facility, and also on the laboratory care. So with this, we'll be able to actually say that how we can join hands and make this possible. So there are few studies I had proposed is that in a collaborative way, we can do an economic evaluation, barriers in hemophilia prophylaxis, quality of care and socio-economic care. We can discuss as much as we want, but unless we have data and publication and compare and contrast with our centers with the national level and international level. I hope that Punjab one day will be a model hemophilia care for the world, how we can come to a developed level of care. I would, all we need is willingness to participate, dedication to learn, and data management and funding human resources and data management and few training sessions. Impact will be that we can be a best data-driven delivery program in the country. I'll stop there. We are already sort of time. Thank you. Panelists for being with us, and we understand the time limitations also we have to understand.
Thank you. One thing I want to stress that best data we can get is if we get interconnected health hemophilia treatment center, and it is computerized. Online registry and interconnection of the HTC.
Okay, thank you.
Thank you. Thank you. Now we'll have the felicitation ceremony. For that, I will request Dr. Gurmeet Kaur ma'am and Dr. KK Kaul sir to please come on the stage to felicitate our speaker and panelists.
सही वाला लोग डॉक्टर अरिहंत हाँ
First, Dr. M. Joseph Johnson.
ये तो वो वाली स्लाइड है कितना होता था और यही है मेरा प्रेजेंटेशन
Dr. Prashant Chabra, sir.
फाइनल स्लाइड ये करना इसको पूरे पोस्ट करेंगे कहाँ से नहीं आता
Dr. Narinder Singh, sir.
फाइनल स्लाइड देखिए सही वाला कॉपी किया
Dr. Girish Sharma, sir.
कौन सा वाला है
Thank you, everybody. Now we'll take up another session, the panel discussion, approach to a patient of hemophilia scheduled for surgical treatment management. For this, I invite our chairpersons, Dr. Radhesham Garg, sir. He is Professor and Head, Department of Orthopedics, Guru Gobind Singh Medical College and Hospital, Faridpur. So please welcome. I request our second chairperson for the session, Dr. Sanjay Gupta, sir, to please come on the stage. He is Professor and Head Department of Community Medicine, Guru Gobind Singh Medical College and Hospital, Faridpur. I would also like to invite our panelists for the session, Dr. Jasmina Aluwalia. She is Professor, Department of Hematology, PGIM at Chandigarh. I invite Dr. Karthik, Assistant Professor, Department of Orthopedics, PGI at Chandigarh. Our third panelist for the session is Dr. Varun Kaul, Associate Professor, Department of Pediatrics, Guru Gobind Singh Medical College and Hospital, Faridpur. I request our chairperson to please introduce our moderator, Dr. Arihant Jain.
So indeed a great pleasure and thank for me to introduce quality in hemophilia. Which Associate Professor, Department of Clinical Hematology and Medical Hematology, PGIM at Chandigarh. Texas in Department of Leukemia and Stem Cell Transplant. He has got more than 50 publications in various chapters. He is also actively involved in more than 10 national and international projects. He has contributed immensely to drafting the guidelines for national training manual for hemoglobin and hemophilia under the MOH training.
Thank you, sir, for the introduction, and thank you, organizers, for giving me this opportunity. My task is to take you all through the journey of a patient of hemophilia who is scheduled for surgery, and I must thank Dr. Jasmina, who, in my opinion, probably around 80 to 90% of the patients, at least 2 to 3 years back, who were being diagnosed with hemophilia were from her lab and problem. And Dr. Karthik is my friend who assists. He's an orthopedician who is actively involved in surgery of these patients, and Dr. Varun Kaul obviously presently an introduction. So what comprises multidisciplinary team for a hemophilia surgery care? Actually, we need a laboratory specialist, a hemophilia physician, a surgeon, anesthetist, physiotherapist. Financial support obviously is the central core, and the transfusion support team. So the goals of these comprehensive care team would start from the accurate diagnosis of the bleeding disorder, the need for the assessment of surgery, the accurate calculation and planning for the factor support, the conducting the surgery with minimal trauma and blood loss, and adequate post-op rehabilitation. So surgery in hemophilia, the NHM manual, we classify them as major and minor procedures. A major surgery is one which in general would require a GA or a spinal anesthesia, while the ones which are done in local are typically called as minor surgeries, or anything which involves a penetration of major body cavity, joint surgeries, extraction of more than 3 teeth, and the WFH says that if you are requiring a hemostatic support for more than 5 days, which probably is in context with single half-life products, then it is classified as a major surgery. So I would start the panel discussion with Dr. Karthik. So in your practice, what are your common indications for which you get a referral for surgery in hemophilia? And how do you decide whether to take that patient for surgery? It is to be elective, a semi-elective, or an emergency surgery, and what is the timeline you take, and how do you decide on that?
So being a referral physical center, we receive
trauma cases. And along with that, we will receive end-stage orthopedic cases, knee joints or ankle joints, and septic arthritis. Those kind of cases we commonly receive in our center. So coming on to the second question, there are three scenarios: one is emergency, second is semi-emergency or urgency, and third is emergency scenario is where you have to intervene immediately, maybe within few hours of situation. Semi-elective is you have to treat within up to 24 hours like that. And elective or you can plan in a planned manner. You can do planning and you can do planned. So, for example, in emergency, we usually receive cases having open fractures within vascular injuries, or patients having septic or fatigue of the knee. These kind of patients you have to intervene immediately. So semi-active, so remaining trauma cases, closed fractures, they are also considered as equal as urgent cases. So that also needs fixation within 1 or 2 days, so that we can mobilize it. So the common elective cases are end-stage orthopedy, which needs total knee replacement or orthodosis of the joint. The common kind of cases we receive in our center. So regarding the timelines, I already told emergency cases you have to implement within 2 hours, maybe 2 to 6 hours. But semi-elective within 24 to 48 hours. Elective you can do surgery in a planned manner.
Yeah, thank you. So just wanted to say that these patients keep falling because of their joint health, and fractures and trauma requiring surgeries are not so uncommon, is what I feel. So, ma'am, so what would be your so for a center or a hemophilia treatment center to start a surgery program? So, what do you think would be the recommended minimum laboratory support it should have before they contemplate a major surgery?
So, like for any other thing, we need three important things, which is man, machines, and materials. We need a trained set of people who know how to run coagulation tests and interpret them, and sometimes in an emergency situation. We need machines which can do them fast with good reproducibility and minimum error. And we need materials about whom we understand what their limitations are, so that we know that our reagent will not give us a good answer in this particular situation or with this particular factor that we're using. That said, if we do not know the diagnosis, then we definitely need facility for the screening test, which is EP, APTP, fibrinogen. These three things are a minimum. If we know the diagnosis, then we definitely need factor assays. We need to have facilities for a Bethesda assay and an inhibitor screen, because invariably that's asked for before surgery. And I think once we do with these, sometimes we are in a little bit of a spot in the beginning when we don't know the diagnosis and the factor VIII levels are in the mild or moderate range. Then the laboratory must have facilities to diagnose 1 milligram disease also, because that can, have low factor VIII levels. So that facility should be available. And I think a blood bank with its cross-matching and materials.
So yeah, so this is what the panel of tests which we would minimum require in almost all our patients who are undergoing surgery, and that is why this is the role of the lab, which ma'am already summed up, including the transfusion support. So again, Dr. Karthik, this is a question for you. So almost all these patients would come with a painful knee joint. So how do you clinically differentiate whether it is a acute hemarthrosis, an acute synovitis, a chronic synovitis, or a hemophilic arthropathy? Like in the clinic or in the outpatient OPD, how do you kind of make that decision?
So again, for any clinical examination process, you have to start with this is very important. Again, in acute hemarthrosis, the patient may have sudden onset of discomfort or feeling of any tingling sensation around the knee. On clinical examination, the patient may have warmth, tenderness, and joint effusion. The range of symptoms are very plain. So the acute synovitis also mimics like acute hemarthrosis. Here, the swelling may not be much acute synovitis, but it is also painful. Chronic synovitis may not be that much painful compared to the acute scenario, but here, due to the synovial hyperplasia and proliferation, there is a lot of swelling around that. But it may not be that much painful compared to acute synovitis. And coming on to hemophilic arthropathy, the patients having history of repeated bleeding, having had associated deformities, joint tenderness will be there. There will be associated contracture of the joint. So this is based upon the history and examination, and we will always supplement with the imaging by using radiograph or
Yeah. So what I want to convey is, so by examining in the clinic, we should be able to make a mind what exactly it is. And these are the 3 stages we all know: first bleed, then synovitis, and chronic hemophilic arthropathy. And because the management would differ in each case, right, from simple price in acute hemarthrosis to some splinting in an acute synovitis stage to maybe radioisotopic procedures in a chronic synovitis stage to a knee replacement or surgical correction in a case of hemophilic arthropathy. So, so what is your, you talked about the imaging that you always supplement with imaging. So we all know that there are so many, so we have MRI scores, we have X-ray scores, and we have ultrasound scores for hemophilia. So how do you take a call between each of these in the clinic?
I always start with radiograph. Even joint infection also in radiograph you can see surface suspension. So radiograph is a basic mandate. In the radiograph you can see any joint swelling or any osteopenia of the bone or any joint infection. So if there is a joint swelling, yes, next is you can go for point of care ultrasound. But you have to be cautious in this operator dependent. It is very important. The ultrasound you can check whether how much is the swell fluid level, whether it's a pulse or blood, or what is the extent level. But again, you have to be very cautious in operator. So the advantage of the MRI is you can get a very good soft contrast. You can look at the extent of swelling or where the pulse is going on. You can look at the synovium, how the synovium. You can see synovium in ultrasound also, but you can better visualize the synovium. Here you can look at the cartilage over the cartilage. But in children, MRI needs sedation, so you have to be cautious.
Yeah. So this is how we would probably take the call. And Dr. Varun sir, so we talked about so many factor products. So how would you choose and what would you recommend in our setup?
This is a very tricky question, but the simple answer to this is beggars cannot be choosers. So whatever is available, we have to use that in the limited resources which we have. So although world has come a long way in giving EHLs and with 3 doses of factor 9 you can do a surgery, but we are not privy yet to it yet. So we would recommend, like, we have not the experience of using the factors in surgery, but as we have discussed over telephonically also, and you are doing it in BGI, so we're going for the standard half-life products, like in a decreasing dosage manner over a period of days and weeks, and taper it off gradually. So maybe some kind of an intermittent prophylaxis.
Yeah. So SHA products too, one because they are available to us, and second because our lab are kind of equipped to monitor them. So, what's new is that one, we know, I think it's almost established that low dose protocols can be used for perioperative hemostasis. EHLs, we heard in the morning, Verifixia, they are very good during surgery. For minor surgical procedures during emicizumab, you probably don't need factor support. In major surgeries on emicizumab, you would need the bypassing or half-life product support. This is a very nice publication from Dr. Apte regarding managing invasive procedures on extended half-life products. On emicizumab, mostly there are case reports of surgery, and almost all of them did use a FIBA or a Novo-7 while negotiating their surgical procedures. So again, coming to Dr. Karthik, so fractures you can manage with a cast or a splint, and then there are these operative advanced internal and external fixation. So hemophilic family often they are apprehensive. So how do you take a call personally, and what is your discussion with the family before you take up a patient for a surgery in a patient with hemophilia?
So first we will always look whether we can manage this factor. So what will you do for a patient who is normal? First we will say for the same factor pattern, if it's a normal patient, whether you will manage conservative or non-operative. So the same applies to hemophilic also with the help of the factors. So this next, what are the that on that because if there is a female factor anyway you have to fix it. Other factors in upper limb fractures you can manage conservatively, humerus fracture or distal fracture. So you will go for non-operative method. So what are the discussions I will have family? So I will first tell whether this fracture needs surgery or can be managed operatively or non-operatively, and what are the pros and cons. Next, what is the patient's demand? What is the operation and what is the demand? Next, what are the complications you can expect even with factor support also? Like there will be wound dehiscence or wound oozing from the wound, and then in terms of infection also, and intraoperative there will be bleeding even with the I have to explain in detail about these things to the patient.
Yeah, so good discussion with the family and the patient is must. The guidelines do say that the standard modern operative technique should be used, whether it is a hemophilia or a non-hemophilia. Again, you have to individualize it in your own setup. Knee replacements often are challenging because they have a lot of deformities with them, a lot of soft tissue contractures with them. So you would need a lot of specific techniques, augments and wedges while negotiating the knee replacement surgery in hemophilia. So this is a meta-analysis of outcomes of knee arthroplasty in hemophilic populations, and they said that even in advanced arthropathy cases, knee replacement does give them a quality of life benefit. So ultimately, it is a shared decision amongst the patient and the clinician about the perioperative and postoperative management. So again, coming to Jasmina ma'am, how does the choice of product impact your laboratory monitoring in patients with hemophilia during surgery? So these are the four routinely available things, and how does it impact your management? Because they have given me a time cutoff.
We didn't have too much choice, and we had the standard half-life products, so there was nothing much to do. We all did a one-stage factor assay and could use that data to give feedback to our clinicians about what the factor levels were. But now with the arrival of the long extended half-life factors, there is enough literature to support that all of our APTP reagents do not behave the same way with these long half-life factors, factor 8 and factor 9. So we need to have, in fact, we are planning this for our institute, maybe it will be helpful to others also, to make a performer saying which exact product is being given. Because it may so happen that the main lab which is running the test has one particular set of reagents, and the emergency lab which may need to do the test of 2 TRs has another set of reagents which is not compatible with a particular extended half-life factor which you plan to use in your surgery. So there is a whole list, and it is far too comprehensive to be discussed here. Every lab should know that this particular reagent that we are using has this particular shortcoming with this extended half-life factor, so they need to keep that in mind. For the bypass agents, there's really no monitoring available currently. I think the best thing is being done clinically, managing clinically. Though I think at some stage all of us will have to look for thrombin generation, because that seems to be the way to assess the level of thrombin, which will be protective for the judging how much bleeding will be there. For emicizumab also, I think currently there is APTT will fall really flat on its face because it will be shortened whenever emicizumab is given. So that will not be the way out. We will also at some stage need to arrange for chromogenic factor assays in our laboratories. Sadly, in India, these have just been licensed, I think, a couple of years back. So now most of us will have probable access and will be able to help you out with better.
Yeah. So the lab needs to know which product you are using. So the factor levels would need monitoring, and in the interest of time, I would kind of just brief the slide. So we would need a peak level, which is generally done 1 hour post the bolus injection, which is like immediately prior to the neck, and a trough level needs to be monitored. And the dosing, this is the rough guideline which is available, and we can use it to dose our clotting factors approach in the pre and post operative period. So the penultimate question, often the discussion comes about the continuous infusion regimes. So a lot of studies have been done on continuous infusion regimes, and initially it was thought that probably they are more cost economic while using, particularly in the perioperative period. But the final takeaway is that logistically it is difficult to negotiate these costing continuous infusion regimes, and that is why a low dose intermittent bolus replacement therapy is probably the way to go. So pre-anesthetic considerations, yes, there are a lot of pre-anesthetic considerations, including the type of neuromuscular blockade and the type of intubation you need to do, hypothermia you need to avoid. And the post-operative complications, obviously we need a very strong physiotherapy team who would day-wise, they'll set goals which need to be done. And that is how surgery can be successful in the post-operative care. Obviously, we need to monitor the inhibitors post-surgery also. Particularly, they should be prior to surgery, it is a mandate, and post-surgery, generally within 4 to 12 weeks, they need to be monitored. So the criteria of discharge again have to be individualized. These are a few of our patients. I think Dr. Pooja is here from Gurdaspur. So we shared this patient. He had come with a big intracranial hematoma in midline shift. We operated him overnight. This is a knee arthrodesis done by Dr. Karthik. We had seen the videos how he bled. He had very high titer inhibitors. So, but now he is walking comfortably. So this is a septic arthritis patient. Dr. Karthik just operated yesterday with a severe hemophilia. So thank you. Excuse me because I had to be economic about the time. So I had to rush through. Thank you.
Thank you, Dr. Jain. I'm a person of a community medicine, and we are the doctors of the poor people. We work in the fields like anemia, malnutrition. And when a child sees a new bird in the sky, he becomes very happy. Would I'm very happy to see the things, the surgical treatment in the hemophilia. It's a very good session, interesting session. And thank you very much for the panelists, for the chairperson, Dr.
Thank you, sir. I would request Dr. Neetu Cooker and Dr. Sandesh Ranju to please felicitate our panelists, our chairpersons, and our speaker. I request Dr. Sanjay Gupta, sir, and Dr. Radhe Sham, sir, to please come. Dr. Radhe Sham, sir.
कैसे लेंगे
Dr. Radhe Sham, sir.
लेना है अभी नहीं, मुझे जॉब ही नहीं लेना सर बताएं 4 जुड़ गए
Dr. Sanjay.
आपका तो आ ही नहीं रहा कौन सा मेरा नेट से चल रहा है
Dr. Jasmina, ma'am, please stay. Dr. Jasmina Aluwalia, ma'am. Dr. Karthik, sir. And our moderator for the session, Dr. Arihant Jain, sir. Dr. Arihant Jain, sir.
नेट का इशू होता है
Thank you to our chairperson, our panelists, our moderator for this wonderful session. we will take on with the other session, which is online. I would like to invite for the chairperson, Dr. Gurcharan Singh. He's Professor, Department of Pediatrics, Adesh Institute of Bathinda. He's former professor and head Pediatrics, Gyan Sagar. He's a mentor and has trained many MD students and worked as senior consultant at GMC Patiala. I invite you, sir. Next chairperson for the session is Dr. Parul Garg. She's Associate Professor, Department of IHBT, Guru Gobind Singh Medical College and Hospital, Faridkot. We will soon be on a Zoom meeting with Dr. Emna Gaudier. The topic for this session is prophylaxis in hemophilia, how to start and the way forward for developing nations. It will be a virtual session.
तू ले लेगा नहीं तू नहीं लेगा ये तो बंद है ना पहले वो तो जुड़ गए वहां पे
जुड़ गए तो कैमरा उसको स्क्रीन पर लेना है ना उनकी आवाज रहनी है उधर
क्लोज कर दूं
कर दो सर इसको हम करेंगे उसके बाद उधर रहना
भाई आवाज लेनी है
उधर
लगाओ उसमें लगा
Hello, everyone.
Yeah, ma'am. Just a minute.
Okay, I'm waiting so for your sign.
करूंगे अभी ये तो बंद पड़ा ये तो बंद
वो करो ये वाला उसमें आएगा ना हमने हाँ हाँ आएगा
सर ये वाला तब आएगा तब इसमें से HDMI तो ये लगा
I'm not able to share my screen.
नहीं लग रहा ये अभी उधर लगा
Good evening, madam. We can see you, ma'am.
I am not able to share my screen.
Just a minute, ma'am.
Okay.
सर वीडियो स्टॉप है वीडियो ऑन करो आप
नहीं कुछ नहीं
सर वीडियो
ये उधर लगाना पड़ेगा ना कैमरा उसमें Now you can, ma'am.
Now we can. Okay.
ये रहा कैमरा ये है
Do you see my screen? Is it okay?
Yes, ma'am.
Yes.
Okay.
Over to Dr. Emma. She is from Tunisia. It's a virtual session. She is hematologist at Hemophilia Center, Aziza, Botswana Hospital, University, Tunis, Almanar, Tunisia. Over to Emma. Welcome, madam. Good evening.
Good evening.
आपका कैमरा जोड़ो ना उसमें ये वाला कैमरा जोड़ दो उसमें टीवी पे लग जाएगा वो वाला टप
कौन सा
वो वाला टप
You can start, ma'am.
Okay, so good evening, everyone. I would like, first of all, to thank you for the invitation. So my talk today will be on prophylaxis in hemophilia, how to start, and the way forward for developing nations. So I will start with some definitions and some data, and then we will see what is required and how to do. So first of all, prophylaxis in hemophilia used to be defined as the regular intravenous infusion of the missing clotting factor 8 for hemophilia B or factor 9 for people with hemophilia B, given in order to increase the level of factor with intent to prevent the bleeding. And through the evolution of the care, of the requirement for prophylaxis, this definition evolved to another one, which is the regular administration of hemostatic agent or agent with the goal of preventing bleeding in people with hemophilia, while allowing them to lead active lives and achieve quality of life comparable to non-hemophilic individuals. This is the definition of prophylaxis for people with hemophilia. So the goals of prophylaxis for people with hemophilia is to avoid bleeding, to prevent bleeding in order to prevent the joint disease, and so to have a normal daily activities in order to achieve a better quality of life, at least as people in the same range of age without hemophilia. So for that, we need minimal requirements for implementing prophylaxis in hemophilia. First of all, it is mandatory to have an established healthcare system, well organized, with healthcare providers, with a regular supply of safe replacement therapy, with the home treatment and patient compliancy, and of course, you will need to work and to communicate always with the patient organization. So now let's start to see some data published by the WFH in hemophilia in the world. So the last published annual global survey of 2020 was published in October 2021. You can see that in all over the world, the number of the identified people with hemophilia and the global consumption of factor VIII in the world for the countries who participate to this survey. And it is around 0.9 IU per capita for factor VIII and 0.40 IU per capita for factor IX. Now, if we try to see the identified people with hemophilia in the world in the different regions and to compare this number to the theoretical, the expected number of patients, you can see that in the majority of the region of the world, the expected number of people with hemophilia is higher than the real one, than the identified people with hemophilia. So if you see the Eastern Mediterranean region, you can see that almost half of the population, if not more, are not identified. In Europe, it seems that it is the region where the identification of people with hemophilia is the best compared to the expected number. In America, it's a little bit more than the half. And in Southeast Asia, it's a very huge difference between the identified people with hemophilia and the expected number. Though the biggest number of people with hemophilia came from Asia. Here is exactly what I said in a map where the different regions of the world are represented with different colors. And the more the color is blue, the more the people with hemophilia are not enough identified. The more the color is yellow, so moving from blue to green to yellow, the more the people with hemophilia are identified. And you have another map where you have the consumption of factor VIII in all over the world. And again, so here, the countries with the red color are those who have less amount of factor VIII compared to the whole population. So you can see that there is a big gradient between the south and the north, and the countries that are violet and the blue are those who are identified. Now, if we analyze the number of people with hemophilia and the consumption of factor VIII in the world, you can see here the different part of the world, and you can see that America and Europe, which represent 31% of the population of hemophilia A, they have a consumption of almost 80% of the factor VIII in all over the world. So we can understand that in this country, they have a lot of factor VIII for their identified population to be used. And if we analyze the population by gross national income, you can see here that the low middle income country, where the population is almost half of people with hemophilia, they use only 12% of the factor VIII in the world. So a big disparity for that. Is it possible to start prophylaxis in those countries? Yes, there is some barriers, but we can start, and many countries coming from low middle income country started with prophylaxis. So again, I come back to the number of identified and expected number of people with hemophilia. And this is just to explain to you, for example, if you have a country where only 50% of people are identified, and let's see that their consumption of factor VIII in international unit per capita is 0.5. If only half the population is identified, and 0.5 per capita is in relation to the whole population living in this country. So in reality, you have a double of consumption of factor VIII for your people identified with hemophilia. In Tunisia, for example, the country from which I come, according to the last global survey, we have identified a little bit less than half of a patient with the people with hemophilia, so 44.88%. And we have now a consumption of 1.4 unit per capita. But in reality, it's not 1.4, as we have not identified all people with hemophilia, but it is 3 units per capita. So it's easy to analyze the data just to compare the global amount versus the number of people identified with hemophilia. Of course, we need to continue to outreach people with hemophilia, but this is a step in order to say, okay, we don't have enough factor VIII, but in reality, we have more factor VIII for our patient than we thought. For example, here in India, where you have one of the biggest population in the world, only 9% of children have been reported to be under prophylaxis. It's 9%, but it's a huge number. So even if it is 9%, it's a huge number of people, children with hemophilia who are under low-dose prophylaxis. I do not have the exact population of children, but it should be around at least 1,000, if not more, children on prophylaxis. Now I come back again to data of the World Federation of Hemophilia and the third edition of the WFH guidelines for the management of hemophilia, where a chapter was dedicated to prophylaxis in hemophilia in this edition. And this is a chapter number 3. And in this edition, but also in the previous one, they define prophylaxis according to the dose used, and they separate the high dose prophylaxis, the intermediate dose prophylaxis, and the low dose prophylaxis with escalation of dose intensity as needed. So the high dose prophylaxis is for use of more than 4,000 IU per kg per year for hemophilia A and B. The intermediate one started by 1,500 IU per kg per year to 4,000. And for the low dose prophylaxis, it's around 1,000 to 1,500 IU per kg per year for hemophilia A and hemophilia. So even in the guideline of WFH, they recognize that prophylaxis is not practiced in the same way in all over the world. In some countries, they used high prophylaxis. In other one, they used intermediate dose prophylaxis. And in some countries, and they became more and more frequent now, they started with a low dose prophylaxis. So the intensity of prophylaxis has generally been referred as high, intermediate, and low dose. It should be appreciated that the intensity is a function of both dose and frequency. And the high dose usually refers to a combination of both high doses and high frequencies, while the low doses usually refers to a combination of lower doses and lower frequencies, although not always. That means that sometimes, for example, in a regimen of a low dose prophylaxis, you can start with low dose at a frequency of once a week, then you can increase to twice or 3 times a week, and it is low dose prophylaxis. Now, the benefit of prophylaxis. In the recommendation number 6.2 of the guidelines, you can see here that prophylaxis using clotting factor concentrate, that all forms of prophylaxis, high, intermediate, and low dose, with clotting factor concentrate, but also with non-factor replacement agents, like emicizumab, provide superior benefits over episodic therapy. So this is not to convince you that prophylaxis is the better way, but it is just to emphasize again that prophylaxis is the only way to treat people with hemophilia today. And conventional high dose, intermediate dose prophylaxis initiated early in life have been associated with over 90% reduction in joint bleeding rates, annualized joint bleeding rates below 3 per year, and a significant reduction in joint deterioration and degenerative joint disease. Even if we are not able to start with the so-called conventional high dose or intermediate, we have the option of low dose, and it is recommended by the WHO. And keep in mind that even in countries where they have a lot of resources, the story of prophylaxis in hemophilia started with a low dose prophylaxis. Indeed, the first experiences started in Sweden and in Netherlands in the mid-50s and 60s, and it was low dose of prophylaxis. The first data was reported by using the cryoprecipitate, and then we have the plasma-derived clotting factor concentrate that were used on prophylaxis in a regimen of low-dose prophylaxis, and then doses were increased. And then we had the first result of large cohort in the 60s and 70s. In 1992 and 1994, we have larger report of the result of prophylaxis. In 2007, first randomized clinical trial demonstrating with objective data the superiority of the prophylaxis. Then we have the concept of primary prophylaxis. The more we start early, the more the result will be better. Then we have the individualized protocol depending on pharmacokinetic, on physical activity, but also on availability of the clotting factor concentrate and you have. And then we move to another concept, which is the higher through level. And today we have in the market new drugs with the extended half-life product, but also the non-replacement therapy, and the era of gene therapy is here today. So low-dose prophylaxis could be an alternative in developing nations. So keep in mind that the message of the WFH again is that the prophylaxis is the only way to treat people with hemophilia. Now, what about the low-dose prophylaxis and the data reported in the world in country with less than 2 units, if not less than 1 unit per capita? You have data from India. You have a lot of data published from India, and according to the recent WFH, the consumption of India now is 0.27 IU per capita. We have a lot of data also coming from China, and when they started prophylaxis in 2018, the consumption was 0.03 IU per capita. Then they do not report their data to the WFH. Sorry. Oh, We have also data from Indonesia, from Thailand, from Malaysia, from Tunisia, from Ivory Coast, and recently in 2022 from Senegal and from Nigeria. And you can see here that all those countries reporting experience of introducing prophylaxis with some economic constraint, with not enough factor concentrate compared to other regions, started with prophylaxis some years ago now, and all the studies published conclude that even if we use the low-dose prophylaxis, we are able to reduce bleeding, to improve the hemophilia joint health score, and so to improve the quality of life. I will not enter in details in the regimen of low-dose prophylaxis, but just to be online with the recent publication, 2 papers submitted almost in the same period and published in the same period in March 2022. The first one is coming from India, which is a review on low-dose prophylaxis and its impact on the health of hemophilia patients. It reported 9 studies, mainly coming from China and India and Ivory Coast, and another one coming from a different region in the world, with the 12 study reporting the experience on low-dose prophylaxis with the benefit of this regimen. So low-dose prophylaxis now is recommended for countries with economic constraints. But it's a starting point. We should move forward step by step. I mean, we cannot move from nothing to a high regimen of prophylaxis. So we have to start step by step. And in this way, starting with low-dose prophylaxis is a very good starting point in order to implement prophylaxis in country with some economic restraints. But the quantities of clotting factor concentrate is not the only barrier to implement the prophylaxis. In Tunisia, we started with a low-dose prophylaxis in 2007. But first of all, we abolished the use of a cryoprecipitate and we generalized the use of a plasma-derived clotting factor concentrate to all people with hemophilia, and we developed the concept of home treatment with the NMO. And we started with a protocol of a secondary low-dose prophylaxis, initially with children who bleed frequently, and then to all children going to school. And then we moved to a protocol of primary low-dose prophylaxis with children. And then we push other centers in the country to do the same that was performed in the center, in my center. And then the concept of prophylaxis is now recognized as standard of treatment for children. So we started step by step in 2007, and now in 2022, it is well recognized that for children, we need to start treating those people with hemophilia with prophylaxis as early as possible. Of course, we develop and we train physiotherapists, which is something mandatory essentially for monitoring, but also to strengthen the muscle. We need to communicate and to work closely with pharmacists in order to have regular supply of clotting factor concentrate, and the amount increases step by step. We need also to have trained nurses who will play an important role for education, but also in clinical skill, essentially for the technique for venous access. Education is something mandatory, education with families, with healthcare providers, but also with the NMO. And the better we communicate, the better we are strong, the better we have better results. Monitoring is something mandatory, essentially using the outcome assessment in order to have objective data to convince the authority, but also to convince the center who was who were not very motivated to start prophylaxis, and we need to continue to improve step by step. And today we have some adolescents who started receiving low dose prophylaxis and who are almost on full dose prophylaxis. So this is the first message. We need to implement step by step. We cannot move from nothing to all. We have to define the priority in order to implement prophylaxis. So if you see the data here in my country, again, in the north, almost half of all people with hemophilia, adults and children, so 53% of them received low-dose prophylaxis. 96% of children are on low-dose prophylaxis and 40% of adults. For the south, you have almost the same result. Almost half the population are on low-dose prophylaxis, including children and adults. Whereas in the center, we are pushing them to set up prophylaxis. And the problem is essentially in this center because of the team and the multidisciplinary team, which is something mandatory in order to set up prophylaxis. We still have challenges to have regular prophylaxis, adherence of people with hemophilia and their families. The regular follow-up is something mandatory, the physiotherapy, and of course, with the parents, you have to educate, to repeat that the treatment of people with hemophilia is not only a replacement therapy, but it is a multidisciplinary care with monitoring, with physiotherapy, with strengthening muscles, with educations, and follow-up is something very important. And here again, this is the data given from the WFH. You have the national consumption of factor 8 and factor 9 through the years. So when we started in 2007, just here before 2008, we were on 0.25 unit per capita. We improve outreach, but we improve also with the low dose prophylaxis to give prophylaxis to all children. And you can see that the amount and the consumption increased step by step because of outreach, but also because of prophylaxis after a long term. So again, as I said, the barrier is not only the clotting factor concentrate and its availability. We need to have a regular safe replacement therapy. So we need a regulation system for purchase of clotting factor concentrate. The best one would be the tender of call. And you have the humanitarian donation of program of WFH, sorry for the mistakes, but it is not enough, as country should get their autonomy in getting the product for people with hemophilia. And we have the development of new drugs, the extended half-life product, the emicizumab, that are very interesting. It is not the purpose of my talk today, but with tender of call, especially in region where you have a lot of people with hemophilia, it could be interesting having interesting prices and to implement these new drugs in your country. So if we summarize what I said, we need the supply and the access to safe replacement therapy, but we need something else. What do we need? We need the pharmacist for that. It's important. So it's one of the components of the multidisciplinary team. So regular supply and safe supply of products is mandatory. And we need the concept of home treatment. We cannot talk on prophylaxis without home treatment, especially for people with hemophilia living far away from their centers. And you will need a trained nurse to teach the good skills in realizing their injection and the replacement therapy. So the education is something which is repeatable every time with the healthcare provider, with the families and the patients, and also with the patient organization which play an important role in pushing people to adhere to this treatment. So the multidisciplinary team is something mandatory. Patient and parents alone are not enough strong to obtain what they needed, so they will need different healthcare providers working in a team, in a multidisciplinary team, and they will need also the patient organization with the support of the WFH in order to receive the best care, the best treatment, in order to be implemented in the society, to be able to go to school and to work. And of course, we need the advocacy and we need the support of the government. So these different stakeholders are mandatory to achieve a success and a regular prophylaxis. Now, patients should also have empowerment in this healthcare system. How? With education and communication, they must understand their disease, their conditions, and how prophylaxis and replacement therapy works. They should have an active role and they should exchange their feeling, their thought with the healthcare providers. They should be able for self-management. They should learn and through experiences recognize the different bleeding symptoms, but also to early recognize the bleedings, to have home treatment in order to be able to have a self-administration of treatment, an adequate factor for treatment with sufficient clotting factor concentrate available at home. They should record all treatment received for prophylaxis, but also they should record if they experience bleeding events while receiving prophylaxis. Adherence to prophylaxis is important. That's why communication and education is important, because the feeling you have as healthcare providers is not also the same that of families and people with hemophilia. They need to know the importance of physical activity and to manage their weight. And of course, they should play an active role also in supporting their patient organization and advocacy. So family and patients play an important role in this healthcare system, and it's one of the conditions of a success of prophylaxis. So the goals of families is to avoid joint disease and to obtain a quality of life, a better quality of life. So they will need healthcare providers. Again, they are here in the middle. They have the healthcare providers, they have the NMO, they have the society and the government. And the healthcare providers should work in a multidisciplinary system. So we must build a team. It's important that this team of multidisciplinary healthcare providers communicate and meet and try to improve as better as possible the level of care. We need communication, we need training, we need monitoring, and we need research and data. The multidisciplinary team involved around the patient, the hematologist, but also the biologist, the nurse, the pharmacist, the physio, the orthopedic surgeon, the psychologist, the social worker, the dentist, the surgeon pediatrician, and the hematologist is a kind of conductor between all those kind of healthcare providers. And it's true that in our region, where we are involved in a lot of things, sometimes the hematologist play also the role of the psychologist, of the social worker, of the technician lab, of the physio. He needs to communicate with the orthopedic surgeon. He needs also to communicate closely with the pharmacist, with the dentist. And on the other side, he needs to communicate with the hospital administration. He needs to be involved in registries. He needs to be in contact with insurance, with the Ministry of Health, and for those who are included in university to teach the medical community. So it's true that it is not easy. And in our region, usually this is not this kind of conductor of you will have, but let's say this kind of conductor, but nothing is impossible. What we should keep in mind is that the hematologist alone is not able to treat people with hemophilia, even if there is no problem of access to replacement therapy. Even if you have a lot of amount of clotting factor concentrate, the factor concentrate alone, the replacement therapy or non-replacement therapy alone is not enough to to improve the care. So the most important healthcare provider are the hematologists, so our conductor, who is in charge of accurate diagnosis through family history, clinical presentation, and factor level. He needs to guide treatment, to monitor treatment, and also to treat complication by using outcome assessment. And he should be involved in hemophilia research and clinical research. The nurse will be involved with the clinical skill for venous access, home treatment, advocacy and advices. They will play a role of coordination, but also they will play a role for outreach people. They will help people with hemophilia to go to school and to adopt their dose and regimen of prophylaxis. They should be aware of research, but also participate, if not initiating research. And they are closely involved in the education of family and people with hemophilia. Now in the lab, we need also accurate and reliable diagnosis, and we will monitor also the pharmacokinetic. They will perform the inhibitor assay, and they should work in a system of quality control, including both internal and external quality control in order to have a good performance. They will also train technicians, scientists, and medical students, and they are involved also in the monitoring with the new drugs and the new assay for the community of inherited disease. And what about the patient organization and the World Federation of Hemophilia? It's very important to communicate with them and to collaborate and to exchange. The feelings and are not the same. The expectancies, the feeling of expectancies is not the same. They will need their support and they need our support. They will help us in training and we will help them in training. And the awareness of patient empowerment is very important, especially in our region. So to conclude, prophylaxis is the only way to treat people with hemophilia. Okay. Low-dose prophylaxis is a starting point, but it is not enough. Improvements may be achieved step by step. Replacement therapy is not the only barrier for implementing prophylaxis. We need to have a healthcare system with a hemophilia comprehensive care system, or at least an hemophilia treatment center, collaborating with the government and the patient organization. And just to share with you the different steps we had in Tunisia. In 2007, we were on episodic treatment and 0.25 unit per capita, and we started first experiences with low-dose prophylaxis in some children bleeding frequently. 7 years after, 50 children were on low-dose prophylaxis. In 2015, low-dose prophylaxis was also set up in other hemophilia treatment centers, and we also used prophylaxis for some adults, and we introduced also the concept of prophylaxis for people with hemophilia. In 2016, we started with the ITI for people with hemophilia and inhibitors. We were expecting that in 2023, we will have the extended half-life products and maybe move to full-dose prophylaxis. In 2022, the extended half-life product is now registered, not yet used because of problem of insurance, but it is registered. We have also the emicizumab registered, and it will be used for people with inhibitor next month. We have some patients who started with low-dose prophylaxis, especially some people with big activities. So in 2025, maybe we will have new drugs. And finally, you have some sheets in the website of the WFH. Some are dedicated to patients and families. Others are dedicated to healthcare providers. You can download it and you can use it for advocacy of prophylaxis. Thank you for your attention.
Thanks, Dr. Emma. That was very informative, inspiration, comprehensive talk. Dr. Parul.
This was a very informative lecture. Now the session is open for questions. Any questions? No, I think there's no question. Thank you, ma'am. Thank you, Dr. Emma.
Thank you.
Thank you, Dr. Amna Gaudier, for this wonderful session.
You're welcome. It was a pleasure.
Okay.
We'll wrap up this session. We'll take up with other session now. Thank you, ma'am.
You're welcome.
We'll send you an e-certificate. We'll send you an e-certificate. E-certificate.
We'll send you the e-certificate, ma'am.
Thanks a lot.
We'll begin.
Thank you. And it was a real pleasure to be with you, even if it is virtual, and hope to have the opportunity to see you in another situation and in another meeting. Thank you very much.
Thank you, ma'am.
So I have to stop share.
Yes, ma'am. You have to stop sharing the screen now.
Done. Thank you very much.
Now I invite Dr. Shashikant Dhi to please felicitate Dr. Gurcharan Singh, sir. Dr. Gurcharan, sir, please come on the stage.
अब इस पे डालना है, इस पे तो डाल देंगे, पर फिर एक ही डलेगा। कौन सा? इस पे एक ही डलेगा।
A huge round of applause.
ये तो आ गया।
इसमें जो इसमें लगा देते हैं कैमरा।
I request Dr. Bableen Kaur to please felicitate Dr. Parul Gardner.
सर की आईडी खुली हुई है सिर्फ।
तो कोई बात नहीं।
इसी आईडी से वेबकास्ट हो रहा है।
लॉग कर दिया था क्या?
नहीं चालू है, ये लॉग आउट नहीं है।
Thank you, Dr. Bableen. Thank you, Dr. Parul.
और पार्टिसिपेंट नहीं दिख रहे ना इसमें।
Our next session is on the topic of inhibitor management in hemophilia A on-demand therapy, a lifesaver. The chairpersons for this session are Dr. S.K. Dhi. He's a professor and head Department of Pediatrics, GGS MCH Faridpur. Dr. Sumit Kumar, professor from the Department of Dermatology, GGS MCH Faridpur. The speaker for this session is Dr. Srinivas PP. I would request our chairperson to introduce our speaker.
So I welcome Dr. Srinivasan Bem for this presentation. He is DM PHO and he is assistant professor in Department of Pediatrics at PGIMR Chandigarh, and his area of interest are childhood leukemias and its effect, brain tumors and bleeding disorders. He has more than 20 publications in nationals and international journals to his credit. Dr. Srinivasan, please.
Good evening, everyone. So thank you for the invitation. I know it has been a very long day, so I'll try to wrap up very quickly. So coming to the topic proper, so I have to talk about inhibitor management in hemophilia A and its on-demand therapy. So my plan of presentation, I quickly take to case-based discussion, which involves inhibitors and types management, which includes treatment and also monitoring while using treatment, and only a little bit on eradication for inhibitors like ITA therapy. So I'll not be talking on hemophilia B with inhibitors, neither I'll be talking about prophylaxis in patients with inhibitors. So why is this important? As we all know, the prevalence of inhibitors in hemophilia A ranges from 20 to 30%, especially in case of severe hemophilia, whereas it is less in mild and moderate hemophilia. The disease burden in patients with hemophilia A with inhibitors is quite high in the form of increased bleeds, increased hospitalizations, decreased quality of life, increased cost that is involved in the medical expenditure, and increased morbidity and mortality. So this was a publication by Armstrong done. So you can quickly see, clearly see here that patients with inhibitors clearly have more hospital admissions, and also the median healthcare cost involved is also quite high when compared to patients without inhibitors, both in hemophilia A and B. So this is one famous quote given by a mother of a son with hemophilia A and inhibitor. So it's like you always feel like you are drowning in a sea of emotional and financial debt. So it's true because the management of hemophilia has been a nightmare, especially in a low middle income settings where you are not having free access to your therapeutics, which I'll be dealing later. So I'll take you through a small case. RS, 11-year male, resident of Derabasi, Punjab. He was diagnosed as a case of hemophilia A severe when he presented at 4 years of age with a right knee hemothrosis, and he was not on a regular follow-up, and neither he was on regular prophylaxis therapy. This was his initial coagulation profile and diagnostic assay, which was factor VIII assay, which was showing 0.1%, indicating he's having severe hemophilia A. So coming to his bleeding history, he had 3 significant bleeds in the past, one in 2012, 2017, and 18, with intracranial bleed and left arm hematoma with compartment syndrome, and infected hematoma was right hand, and multiple bone fractures, 2 bone fractures following a trauma. So with this, he came this in the current admission. He had accumulation swelling over the right arm and neck stiffness and multiple episodes of vomiting with a bilateral lower limb weakness and inability to pass urine. So however, there is no other positive history. On examination, he had bilateral lower limb weakness with neck rigidity, spinal tenderness. Tone was decreasing in both lower limbs and power was also decreased. So without a compressive myelopathy and spinal bleed. So this is MRI. Showing, if you could see here, he is having a hematoma in the cervical region, so anterior epidural hemorrhage, and also in the thoracic level. So for this, he was started initially supportive measures with IV dexamethasone for cord edema, and he was catheterized and rectal support she was given, and neurosurgery consultation was taken. They advised urgent decompressive laminectomy, which we cannot do in this child, obviously, for a known reason that he is a case of hemophilia severe, and the morphine infusion for his pain. So then we started him initially with the factor VIII because he came with cord compression. We have to give. We started on urgent therapy with factor VIII infusion at 3 units per kg per hour. However, his coagulation profile was showing APTT is not yet normalized. It is still prolonged. So then we had to increase the dose to 4 units per kg per hour. So there is a poor response to whatever the hemostatic agent that you are giving. So we suspected inhibitor in him. And not a surprise, he had a factor VIII assay of 0.1% and the inhibitor assay, which was 16 Bethesda units per ml. So what's the inhibitor? So we all know it's an IgG agonist exogenous factor 8 or 9, which neutralizes the complement factors. And the peculiarity in case of factor 9, that is hemophilia B, is it can cause anaphylaxis and nephrotic syndrome on exposure to factor 9, when particularly they have inhibitors. So mechanism action, these inhibitors, they bind to phospholipid moiety of factor 8 and then interfere binding of factor 9 and 10, leading to inhibiting formation of 10S complex, and it also decays the factor 8. So that way prolonging the coagulation cascade. So we all know there are various risk factors involved in the inhibitor development. So however, switching of the products are giving like infusions, which is like bolus doses or intermittent dosing, does not affect the inhibitor formation. So when to suspect? So we should have suspected in this child a day or 2 prior, before even he started increasing the factor 8 infusions, because what is the WHF states that after initial exposure, every 6 to 12 months, one has to actually screen for the inhibitors, presence of inhibitors. or if he had received any intensive factor exposure, that is like very high doses for more than 5 days in the last 4 weeks, then one has to screen. And poor or no response to factor replacement therapy or before major surgery. So in this child, he had a previous significant history where he has received intensive factor administration, and in the current admission, he had a poor response to the factor replacement therapy in the form of still prolonged APTT, and clinically his power, everything has remained the same, and he was planned for the surgery. So these are the indications to screen for inhibitors as such. So more than identifying or diagnosing inhibitor, the most important challenge is like how to treat them. So how to treat a bleeding hemophilia K with inhibitors. So what are the things that we have in our armamentarium? These are factor VIII concentrates, bypassing agents, and immune tolerance induction. So of which factor VIII is available, bypassing agents available nowadays, but if a patient has to buy, then it's very costly. And immune tolerance induction is, in reality, it is not possible for all the patients to do this eradication therapy. So things to keep in mind. So whenever you are dealing with the patient with inhibitor when you are managing, so first of all, you have to see whether the titers are like low responding titers or high responding titers, because your treatment lines will change according to the inhibitor titers, and clinical response to the product. Because whenever you're using a therapeutic product, the child may not respond to whatever the therapy that you are giving, be it factor VIII or bypassing agents, or sometimes they may respond to one product, not the other product. Even though they have responded to one product in the past history, they may not respond to the current product. So this thing has to be kept in mind before just giving continuously the same product. And site and nature of the bleed, because depending upon the site and nature of the bleed, one has to decide how aggressively one has to treat the bleed, and obviously finance and product availability. Remember, emicizumab is used as an effective modality for preventing the bleeds and not for treating any acute bleeds. So because whenever you give emicizumab, to achieve that, what are the trough levels, it takes at least 1 to 2 days. So it is not intended for any emergent or acute management of bleeds. So coming to what is high responder and low responder inhibitors, as we all know, anything more than or equal to 5 beta strands is high responder. So most cases of inhibitors in hemophilia A are high responding unit. They typically respond to bypassing agents. For eradication, one has to institute ITA therapy. Whereas in case of low responder, one can still give a benefit of the patient with factor VIII at a very higher doses and maybe frequent dosing. So in a child who is actively bleeding, just one has to consider bypassing agents or factor VIII depending upon your inhibitor titers. So when the child is not actively bleeding or has been incidentally found to have inhibitors, then one can consider doing this desensitization, but this is not feasible in our setting, at least for every patient. So if you follow a simple algorithm, first see whether the child has acute bleeds and categorize whether he has low responding or high responding titers. If low responding, start with the factor VIII infusion. But however, whenever you are starting factor VIII, sometimes you may have an amnesic response. They may not respond in a way that we desire. So one has to look for the clinical response and also do factor VIII activity, actually whether they are responding or not. If they're not responding, then just quickly move on to the second line of management with the bypassing agents, which is either recombinant factor 7A or APCC, activated prothrombin complex. So in case of patients who are receiving prophylaxis with emicizumab, then preferably factor 7A should be used instead of APCC, because it has a very high risk of thrombotic microangiopathy and also thrombosis risk. Whereas in case of high responding agents, there is no point in giving factor VIII either plasma derived or recombinant routine. So we have to start them on bypassing agents. Again, in patients who are receiving emicizumab prophylaxis, one has to prefer or use recombinant factor 7A. So in nutshell, the choice of therapy in low responding will be factor VIII. However, one has to monitor for the clinical efficacy and also lab parameter with the factor VIII activity. If no response, move on to bypassing agents. In case of high responding inhibitors, the mainstay of therapy is a bypassing agent, because it bypasses the normal coagulation pathway and leads to increased thrombin generation and clot formation. And POSIN factor VIII has been advised as a mode of therapy, but because it has little or no cross reactivity with the human inhibitors that are formed against recombinant factors, but our availability remains an issue. And there are various studies where reports where they use plasmapheresis or immunoadaptation for immediate short-term elimination of inhibitors, but however they are not accepted modality of treatments. So coming to the bypassing agent treatment, so be it APCC or recombinant factor 7A, they have overall efficacy in controlling the bleeds to the tune of 80 to 90%. The mechanism of action are different for both, and so the clinical efficacy will be different. If a patient is not responding to one, change to other. So same patient may have different variations. They may show response at one point of time, they may not show response at other point of time. and there could be multiple inter-individual variability also. So this everyone knows the basic mechanism of the factor 7A, it just bypasses and then leads to 10S activation and then coagulation cascade activation. Whereas in case of APCC, it contains various products, but mainly the factor 2 prothrombin and factor 10, which contributes for the thrombin generation. So the essential difference is, you can see in this table, the recombinant factor 7A and the APCC. So the name itself indicates it's a recombinant, whereas the APCC, it's a plasma derived. It contains multiple factors, though the active moiety which are involved in thrombin generation are factor 2 and factor 10. So it has some component of factor 8 also, because it is a plasma derived, so which can lead to anamnestic reactions when you use in case of low responding inhibitor titers. So the advantage of APCC is it has a relatively long half-life when compared to recombinant 7A. However, the disadvantage is it requires a lot of infusion volumes when you want to give repeated doses. While the recombinant 7A has a disadvantage being very short half-life, however, the infusion volume is very low and it's readily available. And the infusion time, it doesn't take much time. The moment you bring, you can start giving infusion in next 2 to 5 minutes. So in that management, so we are aware of these doses. The dose for factor 7A is 90 to 120 mics. Sometimes you can even use a single dose of 270, whereas for APCC it is 50 to 100 units per kg. It has to be given every 8 to 12 hourly. The efficacy for both of them are more or less similar, but however the cost is definitely inhibitory. So if you see for 1 mg vials of this recombinant 7A, it costs you somewhere around 40,000, 45,000. While this FIBA costs around 30,000 for each 500 international units. So they can also be used for a prophylaxis, but it's not possible in our settings to use prophylaxis with bypassing agents for a patient with inhibitor. So for now, it has been resorted to on-demand therapy, and it is a life-saving whenever it is used. So it's just to show that recombinant 7A has effective in preventing, in controlling bleeds, in severe bleeding, both in severe bleeding and all sorts of bleeding in up to a tune of 90%. And the infusion time is very short, so that once you buy or you procure this 7A, you can start infusing immediately, and the bleeding is controlled in next 5 to 6 hours. So in case of especially like knee hemarthrosis, achieving good bleed control as early as possible is important for a joint to prevent joint disease. So similarly, FIBA, it has a very good modality in controlling bleeds, up to 80% efficacy with a single dose at 36 hours. Sometimes even a single dose can bring about a change in next 12 hours. So coming to this child, so we initially started in with the FIBA because we did not get factor 7A at that time. It was only available at the institute at that point of time. So he was given a dose of 140 units per kg per day for 2 days. But despite that, his APTT was prolonged. So now one can understand, after listening to so many talks, the APTT based assay is not a good modality to look for response in patients who is receiving the bypassing agents. It's not a good modality. So then we went ahead and done sonograph, which was luckily available in our institute, which tells about your activated clotting time, which was again prolonged in this child. So the reason we resorted to, though there are no any recommended usage for these previously, because we were left with only this option of monitoring because he had a spinal bleed, so we cannot go and do imaging. Clinical parameters we have been monitoring, he did not show any response. So we did sonoclot, which was showing still prolonged activated clotting time. It means that he's not responding to that FIBA. Then we gave 1 dose of Novo 7. Subsequently, his activated clotting time has improved, and he has responded to the single dose of Novo 7, which was given at that time. So which bypassing agents? So how one chooses whether it is a recombinant 7A or APCC. As I mentioned, both of them have very good efficacy, but obviously for various reasons, recombinant 7A is used ahead of APCC, because in factor 7A it can have anamnestic reactions, and in case of a patient who is on emicizumab prophylaxis, so one is advised to use recombinant 7A. So there was a comparison which was done quite a long time ago with the PHENOX study, that is FIBA and Novos and comparative study. So it was a randomized study where they evaluated the efficacy of these 2 products. So not surprised that both the products at 6 hours after the institution of the therapy, they had a similar efficacy. So majority of the patients either had hemostatic efficacy control or complete stoppage of the bleeding at the 12 hours after the start of infusions. So one point to be noted is 10% of them, they did not respond to neither of the products. So there was one meta-analysis which again showed that there is no much difference which products, because both of them have a similar efficacy in controlling bleeds. So one important things especially is, what is the ideal dose? How long one has to use? So it has to be determined both clinically, and if you have any assets to monitor, then you can monitor with this. So typically for joint bleeds, either one dose of APCC or 2 doses of recombinant 7A would be sufficient enough to stop the bleeding, and the patient will start feeling better with a single dose of APCC or 2 doses of factor 7A. So, but one has to individualize therapy. So we can't go and start with a similar type as I have mentioned. So sometimes they may respond to other products. So we have to switch and see if they're not responding clinically. So if they have poor response to single agents, then or we can try combined or sequential therapy, alternating the products one after the other. So it has to be given with a caution, and especially in expertise center where they manage hemophilia centers day in and out, because there is definitely theoretical and also there are isolated reports where there is a risk of thrombosis and DAC with this sequential product. So these are the WHO says that we can alternate the product every 6 hours, that is at every 3 hours one can give a factor 7 or APCC alternating. So the evidence for this came from one of the short case series published by this Granger. So they had 11 patients where they used alternate APCC and 1 to 3 doses of factor 7A. So dosing intervals has been 3 to 6 hours, and these are the doses that they use. So bleeding control was achieved in all the patients when they used this sequential therapy in 12 to 24 hours. And in that study, they did not have any clinical adverse events. However, the conclusion was that this sequential therapy should be used. It is efficacious, but it not without adverse events, as has been reported in various reports. So it has to be used as a salvage treatment in case of patients who are not responding to one single therapy. So a few cautions, especially when we are using APCC. So there is a risk of anamnestic reaction up to the tune of 30%, especially with factor 8 inhibitors, and anaphylaxis in factor 9 inhibitors. So, and it has to be used in caution, especially when you are using in patients who are receiving emicizumab. So the recommendation is to give preference to recombinant factor 7A, but exceptionally when the patient is not responding to recombinant 7A or it is unavailable, one can use, but with a caution that your single dose of APCC does not overshoot 50 units per kg, and per day cumulative dose of not more than 100 units per kg per day. So how to monitor? Because you saw in this patient, we have been giving FEBA and we have been monitoring with APTT, but it was still prolonged. So is it what is the ideal modality? So APTT based assays should not be used, and the WFHS recommends, especially when the patients with high responding inhibitors, when you're using bypassing agents, one can use a thromboelastography or thrombin generation assays, but unfortunately it's not available in majority of the labs. So monitoring, so conventional coagulation tests are not useful. So periodic clinical assessment is the principal determinant to monitor therapy in the absence of these laboratory investigations. When you have access, yes, the testing that covers overall activity of the coagulation system, like this thrombin generation assays or thromboelastography, are a better tools to monitor than your APT-based assays. So, however, they're not been standardized, but for clinical use, one can consider, especially in difficult cases like this, where you cannot reassess the patient with imaging as and when needed. So, this is the sonoclad. So, just to demonstrate how it looks. So, this is like original picture. This is how it should be in a normal patient. It will be like this. In this patient, after giving fever, you could see the cord remains flat. That is, there is no initiation of any coagulation in this patient. That is clot in this patient. So, after giving factor 7, you can see it has somewhat changed, and it is somewhat resembling this curve. You can see this red curve of this patient. So there is some clot formation after giving the factor 7 in this patient. So and the imaging also, after we have reassessed after 2 weeks, so there was a dramatic response. So the hematoma has resolved in the cervical region, and there was decrease in the size of hematoma in the thoracic regions. So in this patient, so after 2 to 3 weeks, his power has improved and his bowel bladder function has improved, and surgery was not needed, fortunately, because he has regained all his motor functions. So this is the picture when he got discharged and he came back on follow-up. He was mobile. So just very brief on immune tolerance induction therapy. So this is especially for eradicating the inhibitors. The ideal candidates would be the patients who have inhibitor concentration of 5 to 10 Bethesda units, but most often we see they are high responding and typically very high values. So however, WFHS say if one is considering ITA, it should be started as early as possible, no matter what is the titer that is present. And if the patient is having a breakthrough bleeds, one has to give bypassing agents in these patients again. So the dose remains questionable and debatable. So for now, it is somewhere between 200 units per kg per day daily. So it has to be given for prolonged duration So like say 2 to 3 years, if the patient is not showing adequate response with the negative titers or recovery in factor 8, and then one is declared as a failure. So you can see how difficult it is to give every day so much high doses for so long period. So it is not feasible in our settings for every patient. So the take-home messages are inhibitor development has increased morbidity cost and an extremely worrisome complication in hemophiliacs. So in low responding inhibitors, a higher dose of factor replacement, especially frequent and very high dose, would be helpful and rewarding. In case of high responding inhibitors, the most important and mainstay of therapy is bypassing agents and followed by immune tolerance induction if feasible, which is not in our case. Thank you.
Thank you, Dr. Srinivas, for such a lucid presentation. You have beautifully explained a very important topic, the inhibitor management in hemophilics. This inhibitor management, you all would agree that is increasing day by day and definitely increasing the cost as well as the morbidity in the hemophilics. So you have explained in detail when to suspect the inhibitor and how to manage which all drugs are present, what are the various factors, how we can monitor this. And the best part of your talk was that you have explained it with the case-based scenarios that will help our clinicians to understand this important concept better. Now, I would invite the audience to ask any questions if they want to ask Dr. Srinivas.
Thank you, sir.
Okay, since no question is here, thank you once again, Dr. Srinivas, for
Thank
such
you.
a beautiful
Thank you.
talk. Thank you. I'll request our chairpersons, Dr. S.K. Reed and Dr. Sunil Kumar, to felicitate Dr. Srinivas.
Last one, कौन सा? Sheikh Bilal.
Now I'll request Dr. S.K. Dhi to felicitate Dr. Sunil Kumar. We'll proceed to the next and the last session of our day. Von Willebrand disease, what are the pitfalls in diagnosis and management? The chairpersons for this are Dr. Raj Kumar, Professor and Head Pharmacology, Dr. Neetu Kukar, Professor and Head Department of Immunohematology and Blood Transfusion. The speaker for the session is Dr. Sheikh Bilal Ahmed. I'll request our chairpersons to introduce our speaker.
Good evening to everybody. Welcome to Dr. Bilal Ahmed Sheikh. He's a professor in Department of Pathology, Government Medical College, Srinagar. He has done a BSc, MBS, and MD Pathology. He has more than 14 years of experience. He has more than 30 publications. He has also done a similar project. Okay, sir, you have to start the things.
Thank you for the kind introduction. I know that there is a 2-day exhaustive workshop and today's 1-day scientific session. Everybody is exhausted, and my topic is also very, complicated. The von Willebrand disease, because as per the thing about hemophilia was 10-20 years before, the awareness was not there. Similar is the case with the von Willebrand disease, because much awareness is needed about this rare bleeding disorder. So you have to bear me out, and I thank organizers for inviting me for this talk. Reserve Medical School, where I have graduated as well as post-graduation. So this my disclaimer. So von Willebrand, before I start, the von Willebrand disease, usually one should know that von Willebrand factor is an important hemostatic factor, which is a very, 2050 amino acid protein, have a lot of multimers, and it has a lot of binding capacity with platelets and collagen and factor VIII. So it acts as a very important bridge for primary hemostasis. So von Willebrand is an inherited disorder, which is by definition you can define it as by quantitative or qualitative tests. If you have less number of concentration in your blood, so you usually type 1 and type 3 are usually when there is quantitative deficiency, and when there is a qualitative deficiency, I mean there is a deficiency in the quality where we usually harbor in von Willebrand type 2. So when there is deficiency of this factor, so it usually leads to defective platelet adhesion, aggregation, and activation. So when this is the basic thing which needs for the hemostasis, which is the primary hemostasis. So as far as the prevalence is concerned, it is 1% of the general population. It's because they are very rare bleeding disorder, and usually 0.1% of the people have bleeding manifestations, and 0.5 to 5% per million harbor the severe type of von Willebrand disease. So this is the mechanism of action. It plays very important role in primary hemostasis and secondary hemostasis. So primary hemostasis is usually by adhesion, aggregation, and activation, and secondary hemostasis is, by the way, it binds with factor VIII and increases its half-life, and in that way it helps in less clearance of factor VIII from our plasma by the Kupffer cells or hepatocytes. So this has been classified basically into again similar way as in hemophilia. We classify them mild, moderate, and severe. Here also we classify them in that way: mild, moderate, and severe. So the proportion of von Willebrand disease which is expected, just like hemophilia A is 60 to 80%, similarly type 1 is 60 to 80%, and type 2 is 10 to 30%, and severe type is 1 to 5%. So bleeding propensity is more in case of the severe hemophilia, which is type 3 von Willebrand disease. So diagnostic overview, usually for all bleeding disorders, is very important. The first point should be the history. So the history is very important for before going for any diagnosis. The history is very important, because if history is not giving you the bleeding history, even if your diagnostic test is raised, so that is not accepted. So always take history and correlate with the lab diagnosis. So these are the 3 criteria. So these are the 3 criteria where we diagnose clinical history, differential diagnosis, and lab. Because von Willebrand presents differently, different types, particularly von Willebrand type 1, which is very milder form, can have a lot of diagnostic overlap with healthy individuals, and milder form of this. So where the history is very important, which can help us out to rule out von Willebrand. So then, so what is a significant bleed? So usually in history, one should know what is a significant leukocutaneous bleed. So usually there are so many symptoms where we have nose bleed more than 2 episodes without history of trauma, which is not stopped by less than 10 minutes, and one episode which needs blood transfusion, or there is a GI bleed, there is a mucocutaneous bleed or oral bleed, which attracts medical attention. So those are significant mucocutaneous bleeds. And a positive family history, we take as a positive family history if you have one first degree relative have a history of bleeding, or two second degree relatives have a history of bleeding. So you should take it as a positive family history of bleeding. So that is very important for workup of the patients for von Willebrand disease. So these are the history, because von Willebrand factor is a multimeric factor which have different expressions in different types of citrus, surgeries or infection, where they are much more leads. So we have to take those points also into account. So differential diagnosis, usually the lab workup should be, the mind should go towards the von Willebrand when your basic coagulation testing like PT, APTT, platelets, they are all within normal range. Or sometimes in von Willebrand type 2N and von Willebrand type 3, you have increased APT. So otherwise, your coagulation testing are all within normal. So when this is happening, so you should switch over to the other diagnostic modalities for evaluating for the von Willebrand disease. So this is a very important test, which can be practiced at even normal labs. This is an in vivo platelet adhesion test, which is a modification of bleeding time. So what it is test that you can do it in a lab, because when we do a modified use method, we do a platelet discount on the venous blood, and after 1 minute gap, you will do on the prick platelet count. This difference should be at least 70%. That means this gives an indirect view of about this adhesion and aggregation of the platelets. So when the this plasma concentration, for example, is 1,50,000. So if it after the 1 minute it comes around about 30,000, that means 1,20,000 platelets are used for the aggregation. So that means your aggregation part is okay. But if the this is less than 10%, so you should suspect that there is some defect in adhesion, aggregation of this thing, and that will help you out for going for the this von Willebrand workup. So this is very important. Modified this. Change. So this we are discussing, and these are the basic work of for the von Willebrand disease. So these are the basic tests you should know. One is in vivo test is hinting you about that there is some problem with adhesion, aggregation or something. Then you should go for von Willebrand antigen, von Willebrand and activity, and factor VIII. And there are other tests like platelet count and multiple tests von Willebrand you can do. So usually von Willebrand antigen and activity is low, and this ratio is very important, antigen and activity ratio, which helps us out in differentiating different types of von Willebrand disease. Like in type 1, they are decreased antigen and both activities. So the ratio is in between less than point. So it is 0.6 less than 0.6. So there is one type of von Willebrand type 1C, where there is more clearness. So we use this ratio that it decreases, it dramatically decreases. So we go towards the von Willebrand type 1C. So these are the battery of investigations where we can differentiate different types of von Willebrand. So this is the thing, first work of one-event antigen, activity, factor VIII and platelet. So when both are low, go towards type 1. And if they are very absent, both antigen and activity is absent, so we label it as one-event type 3, which is a severe type of one-event disease and just mimics the hemophilia, severe hemophilia. And then obviously we can differentiate different types on the qualitative methods of these abnormal one-event capacity. There are different type 2A, B, and N and M types, which are the qualitative effect in one event. I think that type A, there is defect in multimers, and there is less adhesion of platelets, and type 2B, there is activity of the like protein 1B, and there is increased activity of platelets. They get adhered to the one event, and they are cleared. There is pseudothrombocytopenia, and there is type 2N, where there is decreased activity of one event with attachment to the factor VIII, and there is decreased concentration. And in type 2M, there is less attraction of the platelets to the multimer. It is a basic work of the investigation where we, so the basic investigation we should remember in case of the one event is one event antigen, activity, factor VIII, and antigen antibody ratio. And there is another investigation which is antigen propeptide ratio plus antigen, one event antigen. Because propeptide is released from the megakaryocytes and endothelial cells, which remains in the sperm, and factor VIII is an active form which is cleared by the blood. So that ratio also helps us in
screen पे zoom वाला चल रहा है
कर
रहे ऑनलाइन उठे
So what are the pitfalls, challenges in the diagnosis?
जब बैठा ऑफ कर देंगे तो उन्होंने चलता रहेगा कि उन्होंने भी ऑफ हो
CBC, they are very nonsensical. There is no standard diagnostic test for one event, and there are other specialized tests which can do for one event, like binding assays and factor VIII activities and multimer analysis, which helps out in differentiating different types of the one events. These are the biggest challenges we face. So pitfalls in this level of one event for defining type 1. Usually there is a lot of confusion between this, but basically the overall studies which are being done is that less than 30 RU per DL as in the cosmos has been said that it is a useful subject for the one event work. One event normal range is 50 to 200 IU per DL. But if it is less than 30, so it goes towards the one event. These are the different stages which have the consensus. So genetic test is not useful because one event is a very huge gene on the chromosomal chart arm of the chromosome, and huge gene. There is a lot of SNP variations. So there is not a definitive genetic test, which is in case of the hemophilia, where we can go for, except in case of the type. So these are the challenges at the diagnosis, and these are feature-related factors and diagnostic-related factors. Because there is lack of awareness about the disease, not including as a differential diagnosis. When we see male coming with menorrhagia or having increased PPH, during that he has no bleeding history previously. So then we have to think that one event has to be kept as one of the differential diagnoses in case of particularly. So low orientation of these disorders will go to complete lab. And over rate of diagnosis is only because we have over-equipped labs and training staff of the lab and lab logistics availability there, which are the challenges for diagnosis. Computer has also been exhausted. It's not known. Slide is not known. So these are the three general strategies for the treatment: promoting extra release of non-virulent factor, and replacing with non-virulent factor, and promoting hemostasis. These are the three important treatments So these are the 3 decimal places which increases release of the already stored 1 factor in our cells, which increases the release. And usually in case of type 1 event, and the biggest limitation is that after some time it doesn't work when the exhaust scores are there. And replacing with factor VIII concentrate, particularly 1 milligram concentrate, it should be at least at the ratio of 1 milligram factor, and factor VIII should be at least as a concentration of 1 because as is in our body, so it should be in that way when we replace, particularly in case of the 1 milligram type, and promote hemostasis while we use anti-fibrolytics and hemostasis, topical hemostasis. These are the things I have discussed about. So this the alternatives for this, but they have the risk of TTIs. Usually in current era, we don't use gravity plasma having wide variety of drugs available. So this is the pitfall and the challenge in the management, because knowledge is very important. Unless until you have the knowledge about the disease and about the evidence about the disease, you cannot manage it well. And we have to balance 1 milligram factor and factor VIII concentration to avoid the thrombosis. Usually it is US guidelines recommend that to decrease the risk of thrombosis, levels should not exceed 200 IU per DL per activity, and for factor VIII it should not exceed 250 IU per DL. These are the US guidelines for to prevent the thrombosis factors. So ABRs have been significantly decreased on non-event prophylaxis. That is the case also with the hemophilics. When you put on the prophylaxis or the primary replacement therapy is standard of care for every bleeding disorder, severe bleeding disorder. So these are the challenges for the long-term prophylaxis. Benefits are definitely there, and you improve the quality of life. But there are other barriers where the adherence and cost and all those are the challenging things for the prophylaxis. And this is our own center where we have 25 patients of Hemophilia disease. We have 13 patients females and 12 males. And usually 8 are severe and 4 are moderate, and rest are 13 patients are mild. And we have kept severe hemophilics on prophylaxis. These one event severe, we have available drug for them. They are on prophylaxis as they are being. The take-home message for this is that von Willebrand is the most common inherited bleeding disorder, characterized by qualitative and quantitative deficiency. The diagnosis depends on family history, personal history, laboratory tests, which include platelet count, bleeding time, level and activity of von Willebrand factor and factor VIII. The challenge in diagnosis include fission-related factors and diagnostic-related factors, like no clear cut of value, no standardized tests are available yet. The management depends on increased release or replacing factors or anti-hemostatic agents. Currently, clear guidance for management is lacking, and especially for long-term performance. Thank you for bearing me.
Thank you, Dr. Bilal, for nice presentation. There are so many challenges in the diagnosis of von Willebrand disease, and there are challenges in the prophylaxis also. And he has explained it so nicely. If there is any question, you can ask him. Thank you, Dr. Bilal. Nice presentation.
Thank you, sir. Now I would request Dr. Neetu Kukur ma'am and Dr. Rajkumar sir to please felicitate Dr. Bilal, sir.
यही डालना पड़ता है।
I would request Dr. Neetu Kukut ma'am, please felicitate Dr. Rajkumar sir. Thank you, sir. Thank you. Thank you, everybody, for your patient listening, and I congratulate the organizing team for such a wonderful 3-day conference. I would request all our company partners to please come inside the hall.
चारों स्टैंड अपने
I request our company partners to please come forward. I request Dr. Varun Kaul, Dr. Birinder Brad, Dr. Neetu Kukut, Dr. Sandesh Ganju, Dr. Sashikant Dhi to please come on the stage. Dr. Parul Garg, Dr. Ishwar Tayal, please come on the stage. We'll felicitate our company partners. Dr. Navreet Singh, Dr. Rajinder, Dr. Bableen Kaur, Dr. KK Kaul, Dr. Sandeep Sir, Dr. Man Singh.
Your phone बज रहा पूरी.
I invite our partners from Roche.
Hello. नहीं कुछ करो चल ठीक है तो सारे लोग यहीं हैं ना मैं अभी आ रहा हूँ सारे लोग बुला ले खत्म हो गया फोटो खिंचवाओ फोटो खिंचाओ जल्दी सारे लोग सब बुला ले सारे लोग क्या वोट दो सारे लोग बुला ले सबकी फोटो खिंचवा ले.
Everybody from Roche, please come on the stage.
Mark 2.
Huge thank you to all partners. Next, I invite from Novo. I thank you all and congratulate you all for the huge success of this conference. Huge round of applause. Thank you. Now I invite from Takeda. And now I invite from Reform.
YouTube live
In task. A huge round of applause for company partners from INTAS. They have worked day and night for the success of this conference.
ये क्या निकाल दिया तुमने तेरा निकाल दिया क्या कैमरा नहीं कैमरा बंद हो गया कैमरा मेरी तरफ से बंद नहीं है आपकी तरफ से बंद है ये देखो यहाँ पे ये आपका ये आ रहा
Do we have anyone from Pfizer?
ये बंद हो गया
I invite Dr. Varun Kaul on the stage for a vote of thanks to our organizing committee and our partners.
Thank you very much, Anjali. And, when it has been a wonderful experience, and especially the participation by the faculty, which probably deserves no introduction. We have been able to get the faculty which is a master in this subject. So I believe, Faridkot has seen this faculty for the first time, and the way they have told us their feedback, they are wanting to come back again. And this is an achievement for the team, organizing team, and our college, that we are able to pull out this magical rabbit out of the hat. And all the chairpersons, all the organizing team, all the allied staff, all the industry partners, we are highly thankful for all the support, all the dedicated hours you have put in to make this conference a success. Looking forward to continue this summit in the coming times also. Thank you very much, and a big thanks to Anilji and his team, Anilji and Harjinder ji, Vicky ji. They have been phenomenal. I mean, हमने सभी लोग ये बात कर रहे हैं यार ये कैसे कहाँ से हुआ? So it is all Anilji's magic, and I think daily in and out we used to be on call till 12 o'clock in the night. We used to we used to talk before sleeping actually at 12:30. So how it is going, and कल रात को भी हम 1-1:30 बजे सोए हैं ये सब करके. So all kudos to their team pulling out this magic. Thank you very much. Thank you all.
कर दिए बंद?
ठीक है सर,
लीव मीटिंग।
ठीक है ना।